PGI has given us much more than degrees and clinical training. It gives us a way of thinking, a way of practicing medicine, and most importantly, a culture of learning, humility, and helping each other. So Cardio Connect in this year is our small effort to bring that spirit back together. Over these 2 days, we will discuss science, we will share our experiences, debate clinical difficult cases, and learn from each other. But beyond the academic program, I hope we also find time to reconnect with old friends, old memories, and perhaps make some new friends. I would especially like to thank all our respected seniors and faculty members for joining us and all our colleagues who have traveled from different parts of the country to be here in Jaipur. So let us keep the presentations sharp, the discussions open, and our evenings enjoyable. Welcome to PGI Connect, Cardio Connect 2026, where PGI connects hearts, minds, and friendships once again. Thank you all, and let's begin for the first session. I just request Professor B.N. Shahi sir to have a words of blessing for us and give us formally open the first session of case presentations. Sir, please.
Thank you very much. Today is a special occasion when I see my children doing out, going out, doing outstanding work everywhere they are posted. I am keeping a track of all the activities of our people who have passed out from PGI Chandigarh. I am very happy that wherever they are in the forefront of not only in interventional cardiology but also in clinical cardiology and research. So today I am so happy to see all of you and I bless all of you. The last time I went to my institution, I call it alma mater, in 2006 when my friend K.K. Talwar was the director and I was called as DM examiner, and also later on I came there as a DNB examiner, and great occasion indeed, and I congratulate all of you, bless all of you to go higher and higher in profession. Thank you very much.
And Dr. Mukul to be on the stage for the first session, to conduct the first session.
We'll keep it the introduction short, so we'll invite Dr. Ashwini Kumar Sharma to present his first case. We are
Thank you, Chairperson, and good morning to all. I am going to present an interesting and complicated case of post-TVAR aortoesophageal fistula. So the gentleman was 80-year-old man. These images are AI-based images. So in 2018, he underwent PCI 6 weeks before first contact, he had Malina, but at the time somehow he was on aspirin and ticagrelol 90 milligram twice daily, almost almost 8 years after the PCI. So evaluation was done, transfusion was done, and then it was switched to the clopidogrel only. 2 weeks later, he had fever, got admitted, workup was done, and he was symptom free and got discharged. 1 week post this admission, he had hoarseness of voice, and further evaluation confirmed to be the left vocal cord palsy. So the evaluation for that in the form of CT angiogram revealed a secular aneurysm from the arch of aorta opposite to the left subclavian artery. Later he had streaky hemopsis, a small amount, got admitted, and it was planned that the intervention will be done for this secular aneurysm. Based upon the frailty, the decision was that we will go from left carotid to left subclavian debranching, surgical debranching, and then we will go for covered stent placement across the left subclavian artery. Because the secular aneurysm was beginning just opposite the subclavian artery, and a good landing zone was there in zone 1, zone 2. आगे चलेगा। Okay, so post TIVR, there was total exclusion of the secular aneurysm. Patient became symptom free. There was no hemopsis. Somehow, after 2 weeks, he got admitted with generalized weakness, and workup revealed multiple infections in the form of methicillin resistant staphylococcus in blood, enterococcus in urine, and MDR Klebsiella in sputum. He was given prolonged antibiotics. Once he was symptom free, he was discharged. And now for 2 days there was Malina, one episode of hematmesis. It was clotted blood day before, and then in the night he has massive hematmesis and got admitted in hypovolemic shock. Patient was resuscitated, and after stabilizing on inotropic support, CT angiogram was performed. We can see that there was expansion of the previous secular aneurysm. Not only expansion in the axial dimension, but also it migrated more towards the origin of just distal to the origin of innominate artery. Also, the previously excluded left subclavian artery opened up. So at this moment, there was also some gas bubbles in the mediastinum. The stomach was full of the blood in CT, so it was sure that it was a case of expansion, rapid expansion of the aneurysm, previously excluded aneurysm with the formation of aortoesophageal fistula. Patient was resuscitated. Obviously, it was a ruptured aneurysm, so there was no scope of open surgery. It's not a content perforation or rupture. So the planning was that we will go from ascending aorta to beyond the previously implanted graft, and for that the transposition of the anatomy of CT angio was done on paper. Planning was done. The plan was that we will put two fenestration, for one for brachiocephalic trunk and another for left common carotid artery. We will start from midway of the ascending aorta, which is absolutely normal zone, and its dimension was 30 and 32 millimeters. So we opted with 36 graft, and we'll go beyond the previous stent and will park in descending thoracic aorta where there is minimum amount of calcium, so that no further leak should occur. And we preloaded a long length wire through the fenestration of left common carotid artery. A 5 French sheath was introduced in the left common carotid artery, and the MPA catheter was parked outside, and through that the preloaded wire was externalized. So the assembly was advanced in across the descending thoracic aorta. Its appropriate position was confirmed, and partial deployment of the stent was done. Then we entered the penetration of brachiocephalic artery through the access from right brachial artery. Then crossing of the fenestration of left common carotid artery was attempted. It was really challenging Then we soon realized that our wire was actually crossing across this superstitive wire of the brachiocephalic trunk. It was removed from that by just withdrawing the sheath, advancing another stiff wire so that we won't lose the excess, and then a reattempt to cannulate the fenestration of left common carotid artery was done. It was really challenging, but finally we could. And in that attempt, we used JR guide, we used RDC guide, and many other things. Finally, the covered stent was parked in both the branches, and stent was fully released. After releasing the stent, first we deployed the covered stent of the brachiocephalic trunk. It was post dilated, it was flared as well, and then the stent of left common carotid artery was deployed. It was not post dilated because still the wire was just outside the sheath at this moment. So we don't want to jail it after post dilating. Now, what happened that in one of the maneuver, the tip of RDC catheter got broken, and we really don't want that this tip go into the renal artery or somewhere where it can cause another mess. And it was really much more challenging for this small tip to bring it out because it was allowing the blood flow and it was just dancing there, it was not moving altogether. Anyway, 18 French sheath was advanced, the assembly was removed. We tried to advance the MP and JR catheter, but these could not because the wire was so much and so deformed. Slowly, by rotating that JR guide and allowing the movement of the wire, the tip could slowly bring into the sheath, and then sheath was removed en masse. Now the left carotid covered stent was post dilated and flared adequately. There was total exclusion of the graft. During the procedure also patient has massive bleed and he required 3 units of PRBC transfusion at that time. Later we occluded the left subclinical artery also. We don't want to leave anything for future to for recurrence. After 2 days, 3 days of parenteral nutrition, UJ endoscopic guided RICE tube was inserted, and we can see there was adherent clot on the posterior wall on the esophagus. It was not disturbed. Put the RICE tube and then come out. So the take-home message from the given cases is that this patient has classical Chiari triad manifestation in the form of mid-thoracic pain, sentinel hemorrhage in the form of melena 2 days ago, and then there was exsanguinating UGI bleeding 2 days later. The interval between these two bleeding may vary from days to few weeks. It's a highly fatal condition. Truly need multidisciplinary approach with much more short as well as long-term complications. Thank you. Thank you so much.
Great case, and I think this is how the meeting should have begun, with this great case. We have another we'll have 5 minutes of discussion, so the forum is open for everyone to say how it could have been done better, or where things were missing, why this patient had to be readmitted so many times, and what went missing in this patient. The final result was great, but definitely we'll have some learning steps.
Yeah, very good case and very well attempted. Just two things I would like to know. One is how old, when did you do this case?
This was within last 4 months only.
Last 4 months only. Do you have a follow-up on this patient, especially the chimneys?
Yeah, so right now we didn't have the follow-up. It's just 3 weeks post the event. And very recently we have discharged the patient.
Okay. And what about the vascular access? See, I'm not going into the procedure. What sometimes creates problem in these cases is that you were having multiple vascular accesses. How did you manage them? That is going to be the crux of this case, I think.
So we did the ultrasound, we took the ultrasound guided access, both the brachial access and left carotid access was there. Left carotid access was taken in last. Once the on the back table graft was ready, everything was ready. We took the sheet, 5 French sheet in beginning. And left femoral large bore access was taken 18 French. Last time it was right femoral access which we obtained. So our aim was that we will close the left carotid access as much as early possible, which we did. After that we closed the femoral access, and then we closed the brachial access as well.
So for femoral closure, do you use perclose or what?
Yes, we use the two perclose in this patient.
Perclose. Have you used the Menta device as a?
No.
Okay.
Any questions from forum?
So this patient we gave aspirin and clopidogrel because we have taken the excess in the carotid artery. Otherwise, I would have kept this patient on single antiplatelet. See, it's a big vessel; it won't going to go to thrombose, and I don't want any bleeding risk in this patient. So my aim is that for 1 month we'll give double antiplatelet and then we'll come to single only. Yeah, patient has been mobilized now. Yeah. He's mobile now. Yeah, he's failed patient, but he's mobile now. No hypertension, sir. No diabetes.
If no more question, thank you very much, Dr. Ashwini. Now, second case will be presented by Dr. Anil Chaudhary, sir.
Good morning, everyone, and thank you all my teachers and seniors who taught me all the principles of the intervention cardiology. So please take this case as a cath lab class. Sorry, 76-year male come to the emergency OPD at 11 p.m. with acute chest pain for 1 day associated with profuse sweating. ECG showed SCT changes in anterior chest leads. Cardiac biomarkers highly elevated. Echo shows the apical and apical septal hypokinesia with LVEF of 45%. Transradial angiography was done in the night. We saw the C-valley calcified DVD with LED D1 bifurcation. Medina class is 111 and critical stenosis in the L6 and OM with left dominant circulation. You can see the LEDs, there is the tram track calcification. Severe tram track calcification, and LED and D1 both are classified with Medina classification of 111. So how do you approach this case? Would you do in the night, or would you do it by the after planning? Yes. So how I plan this case femoral approach because this patient require the more support. 7F long sheath with 7F XB3 3.5 guide, fine cross, run through for main vessels and the filter for side branch. Atherectomy versus IVL, intravascular imaging, and the technique is the DK crush versus DK clot. This is why my planning in the night for tomorrow morning. So I took the 7F femoral access. You can see the aorta is tortuous. So I put the 7F long sheath. While pushing the microcatheter at the tightest part, I am not able to push the microcatheter and the guide is bounce back. From here, I remove the run-through wire and directly wire with the rotafloppy wire. Then I started with the rotablation with 1 point, because this is the balloon microcatheter uncrossable lesion or balloon uncrossable lesion. So that's why they started with the rotablation in spite of the IVL, because the IVL balloon may not be delivered. So I started with the 1.5 bar at 160 RPM. At the tightest part where the microcatheter is not crossing, I am not able to further burring with the help, because even as per the 3 to 4 attempts. So I increased the speed to the 190 RPM and able to cross the lesion, and this is the finest polish run. After that, the IVS run. The image beautifully showed there is the lot of reverberation. We saw that I saved the calcium and there the multiple cracks. So I did the good plaque modification. After that, both LED and the diagonal lesions are post balloon dilated with the cutting balloon. Cutting balloon 2.25 in the diagonal and the 3 into 10 in the LED. First, I put the mid to distal LED just below the diagonal, and second is in the LED to D1 2.5 to 28. LED D1 wire crossed to the distal studs, and this is the scene after the first kissing. We can in the stent boost we can clearly see that the wire crossed towards the from the towards the distal studs, so towards the diagonal ostiums. That means this is from the distal studs. If you cross from the proximal stud, the carina length will be more. That will affect the long-term outcome of the patient. And how we should cross from the distal stud? First, go to in the diagonal distally, then pull the wire. This is the best approach to cross the wire from the distal studs. Then the proximal LED was stented with the 3 into 38 and port done with the 3.5 into 15. This is the second kissing after the wire recrossed from the distal studs, and this is the stent boost which show the clearly the these are the final IVS run which shows the IVS MLA at the distal is the 5, at the tightest was 5.9, and then the proximal LED is 8.2. So my take home is the calcification and bifurcation. These are the two problems, and the one lesion they treat the both, not just one. How to modify the plaque, either rotablation or IVL. So I use the rotacut approach, which achieves the synergistic plaque modification for optimal stent expansion and the long-term to improve the long-term outcomes. I choose the decay clot because the decay clot and the decay crush trials are more favoring the decay crush about the long-term outcome. In case of the complex bifurcation lesions, I use the decay clot, which ensures the complete the reproducible bifurcation strategy, and IVS confirms the adequate preparation and the adequate good final results. Thank you.
Thank you. A great case again. And do you feel that a non-compliant balloon would have done the same trick instead of cutting balloon? Because you had good cuts seen on IVS.
Sir, I dilated after the just rotablation and the IVS run, I dilated with the NC balloon, but NC balloon is not properly dilated, especially at the tightest part, where the increase the rota bar. That was scenario not included, sir.
So you said that the 1.5 bar was not crossing and you had a speed of 160 to begin with?
160.
160. So by any chance, did you not consider coming to 1.25 with a higher speed? Because why I am saying so is 1.5 bar at a higher speed can sometimes stall in these very tight lesions, right? And it can also cause a no reflow immediately. So a better thing which I do, I may be wrong, is to start with a 1.25, which are lesions which are not dilatable, and go at a higher speed so that you don't achieve a stall over there. And then you upgrade to 1.5 and then you achieve a good result. Just a suggestion. That's about it. Otherwise, the result has been excellent. And you have by any chance, used the Abbott system?
Yes, sir.
Abbott ablation system, you have used that? No.
No.
Instead of Rota?
No, no.
Okay.
So orbital is not because of the orbital should be in the this because even the microcatheter is not crossing, so maybe orbital is not a good option because the nose cone is not easily go. Oh.
But
Sir, not available at my center. Not available, sir. But it's much more costly also, sir.
also two strands in this.
It has larger cells at the
Yeah.
to be placed at the branching point. And then
But
you
they
will
are-
pass another stent through that. No, they haven't. They haven't presented long-term data. Nor for that, nor for their tapering stent. The data for long-term is not available.
No, tapering, there is available. We have a long strands data that is published of 100 strands. From that, every company has made this long strand. Earlier this was not there, but long back, our one of resident our total is EMCH. At that time, we did one full study, more than 100 pages. And one of those, there, those who did that long strands are better than two strands every overlap. And every company has made after that. That is a noble study. You could read all of long strands.
Dr. Anil, is there any data that DK Culotte is better than DK Crush?
No, sir, no data. But data supporting the DK crease is more, sir.
And
I see.
yes. And how many kissings did you do in total?
Yes, sir.
How many kissing balloon inflations?
Two.
So in DK Culotte you are supposed to do 3 actually, not 2, 3. And in DK, no, he said he did DK Culotte.
I did
in Crush you do 2, in Culotte you do 3. And the reason you do the third is because basically you have more metal at the bifurcation. So you have to do 3 first, second and third. There are 3 crushings and 2 pots. You have to do a final pot also. Those final pots were maybe you did, I think, but it was not.
I did the final pot, sir.
The other thing is that
I didn't do the third kissing.
Like sir was mentioning. Okay. With 1.5 bar, do you think you removed enough calcium? Because after the burring, the IVs that you showed, obviously you had shaved off a lot of calcium, but there was still, it seems there was a lot of calcium and the cracks were not very obvious. Maybe you did it after the cutting balloon. Did you repeat the IVs to show the cracks?
No, sir. I just repeat the IVs only after the root ablation. Or I choose the 1.5 bar because I'm theoretically stuck bar is more common with the 1.25 bar. That's why I choose the 1.5 bar.
What was the
or this case now my early career phase just after the 6 months after passing out from PGI. So I just want to safest process.
No, in your setup you have done a very nice job. There is no doubt about that. We are just discussing. So in that sense,
I think he took help of balloon inflation test, how the balloon was expanding after that, and then realized that he needs to go for cutting balloon. That is how it happened. After you did rota, you inflated a non-compliant balloon.
Non-compliant.
That whether it is expanding or not, it wasn't. Then you went
after rota. I took the IVS run, then took the NC balloon, but the NC balloon shows the waist only at the tightest part where the increase the rota speed of the rota.
That's another.
So very well done case. One comment regarding the reverberation in IVOS. Reverberation per se doesn't say that you have made enough cracks. Rather, the windows through the through the echoes. I mean non-acoustic region hai. If you can see some anatomy beyond that suggests that there are cracks. Reverberation per se doesn't say that the plaque has been modified and there has been cracks.
Yes, sir. Reverberation is the 2 times. How would you interpret the if the reverberation seen before the plant modification, that is correlate more with the thickness. If you did see the reverberation after rotablation, that is more favor of the good plaque saving, good calcium saving. Where you did the iverson after the rota or before the rota? If you I did the before the rota, if you see the reverberation, it is more correlated with the calcium thickness. If the more the reverberation, more likely to have thicker calcium. If I reverberation seen after the rota, it is more likely favor that you did the good saving or good plaque modification.
Shadow. If it is a thin calcium, you might see some reverberation. Your second point is well taken, that after you've done a rotablation or any plaque modification and you see reverberation, that indicates that some part of the calcium has been modified. You may not see cuts.
Oh.
You might just see reverberation, which indicates that the calcium has been shaved and the plaque left behind is a little lesser than what it was earlier. That's what I understand.
How old was the patient?
Yes, sir.
How old was the patient?
75 years, sir.
75. And it was his first episode of
Yes, sir. First episode.
unstable.
No installation. Trope is highly elevated.
Huh?
Trope is highly elevated. Already hypokinesia, EF around 40.
It was a sort of MI.
Yes.
And his left ventricular function was out.
45% just already apical hypokinesia.
Now, first episode, could have this patient been treated with an aggressive medical management for some time and followed up?
No, sir. The acute coronary syndrome has to be treated, sir. The medical therapy mainly.
In a sort of rural area for some time, and everybody is not cannot afford all this procedure. Except for few centers, nothing is available. And I have treated many patients. Unstable angina. This is unstable angina or acute MI, whatever you call it. And if you give them an first episode, if you give hypertensive.
Yes, sir. Hypertension. He is already on hypertension.
Diabetic?
No, no diabetic.
If you give him aggressive medical management, treat the blood pressure to a level of 130/80 or so, and give him statins in the optimal doses. Today, what is happening is that most of us give statins 10 milligrams. Higher doses of statins, it doesn't produce a 10 milligram and not produce any side effect. The 20 milligram will also not produce side effects. Let me tell you. So I give them optimal dose of statin, antiplatelet drugs, keep the blood pressure between 130 120, and give them the lifestyle changes. The patients are there for 15-20 years. No problem. So in our scenario, we have to decide who are the people who are going to die if no intervention is done. Versus people who can be given optimal advice on lifestyle changes, treatment of existing factors like smoking, high blood pressure, diabetes, and give them aggressive medical management. We develop the breathing behavior and statins where they die. I have many patients, hundreds, who are living and doing very well. Because nature has provided a situation where even if these arteries are affected, then the provided some patients are not close to the
Exactly right. This man wants me to say that every patient is lifestyle and in activity. And that is learning is that most many factors are there. So yes, if you are good optimal lesion, the circumference and your lesion, it can be tried with a medication. And medication should be not that Nitrates are not there, beta blocker are not there. So every drug will be given that. Some patients may not afford. Some patients will say no to a treatment. If I just tell you, sometimes any person very highly educated day, he takes the time to get every day, but not actually. He will medication. There are patients like that also. So yesterday we actually gave a talk on patient who will get a calcium score and it was not even ready to go on the CT. They go on the I won't name very high one. And already the patient is different. But every patient is taken individually, highly depending on the race and his activity. So the pilot is there, driver is there. In that you have to do intervention. He is active.
Yes, sir.
He is there. Then you have to move on. If he is elderly, 80, 70, 81, he is a medication and that is immediately to the
Yes, sir. Exactly, sir. I think the times have changed now. The patient comes and tells you that I have to get a CT angio done, and you have to decide that it is not necessary for you. That is how it has happened, and I don't think atorvastatins or anyone would be prescribing 10 milligrams, any cardiologist, and I still do not believe that it would be without ezetimibe now. Most of us would be practicing at least mid-intensity to high-intensity statin with ezetimibe combination to most of our patients. Sir, you have to use the mic. We cannot hear.
Hello.
Passenger plane.
Hello.
They are not made fit because you have done enough damage to intima. And intima is a very, very sensitive organ. How it is going to behave in a particular place, we do not know. Therefore, I personally feel in what Smith is saying, if we give them, I am trained in PGI, when regular metoprolol was available, not the long acting. Clopidogrel was not available. Aspirin was available then, and statin was not available. Let me tell you, no statin, no the ACE inhibitors and other, drugs were available. We only had a regular nifedipine, 10 milligram nifedipine capsules, and that too very rarely being available in medical stores.
Yes, sir.
And that is the time we have been taught by our teachers. But most important, that what we learned was
Yes.
that intima is an endocrine organ.
Sir, we'll have last comment from Dr. Bali, sir.
How
He
it
wanted
will
to
behave,
have the comment.
we are putting so many things. It's a very good result. But long-term follow-up, we have to do. Whether does it increase the longevity of that individual? And since it was not a proximal LAD and circumflex was all right, with all our knowledge, we know that this patient is at low risk.
Dr. Bali, just small comment.
Yes, just a small comment. I think Dr. Sahi is a very senior cardiologist and has been there much before we even started our graduation in medical college. But the 2 points which I want to make, the comments that aggressive medical treatment has to be done is basically for stable chronic coronary artery disease. Here we are talking about an unstable angina or NST elevation myocardial infarction. And NST elevation myocardial infarction, there's enough number of trials now to show that invasive is better than conservative. We started from Vanquish trial, and subsequently there have been about 20 trials which have consistently shown that invasive treatment is better. This next step we took over was how invasive, how early. Is it going to be within 24 hours? Is it going to be within 12 hours? And we did a broad trial to show whether it will be good for within 2 hours. And now we have data to show that all these patients need to be risk stratified. According to GRACE registry, there are a number of other registry, and we have low risk, medium risk, high risk, and very high risk. So all of them do need invasive intervention in addition to an aggressive medical treatment. These are not alternatives. This is plus, invasive plus aggressive medical treatment, and high dose statin is one of them. But how early we have to take them for invasive would depend on their risk profile, which would be clinical factors, which will be hemodynamic factors, which will be electrical factors, arrhythmogenic factors, troponin levels, and risk factors. Number of all these factors go into formulating how high the risk. But I beg to differ with Dr. Sahi that today alone conservative management and acute coronary syndrome probably would be a very, very debatable. Yeah. Thank you.
In fact, cardiology has changed so much over the period of 2 decades. As Dr. Sahi has said, it was Lasix and digoxin only for heart failure. But definitely, wherever there is an unstable acute coronary syndrome in the present era, angio should be done. And if it is suitable, if it is not suitable in any reason, he is having anemia, sepsis, pneumonia, other disability,
I think
then they should be.
we are on the same plane, sir. Any acute cardiac event means you have to go invasive. There, if you are not invasive, it's a crime. I'll invite the speaker, Dr. Manoj, sir.
Dr. Sumit, this is a picture of all cardiologists where PGI started. So don't in that way think that he is wrong, he is right. And whatsoever in some of the patients, when there is diffuse coronary artery disease, you are not to patient is a contraindication for surgery as well as stenting. You give him medical treatment. You don't say that you will die or go for ECG. So there are subset of patients. Wherever you can do, because here consensus has to be made. A lot of learning from the elderly also is there. So one should not think that we are young generation and we believe in this. Regarding left main stenting, I'll just tomorrow tell that stenting is better than surgery. From the PGI data of 490 patients. Tomorrow I'll disclose that.
Thank you, Yashpal. And let me invite Dr. Rohit Manoj now for his case. Please.
Good morning, everybody. Seniors, some of them did not get opportunity. Good morning, everybody. I'm working as a professor of cardiology in PGI Chandigarh. Some of you I have not interacted with you. Ram insisted that I should present something, so I happen to learn from this case, so I will share with you. 34-year-old male came from Manipur with left-sided free wall pathway. For ablation, we did the ECG is basically with recursive pathways where there he has a recurrent PSVT. We demonstrated on EP maneuvers that he had a indicible tachycardia, and pacing morphology confirmed that he had a left-sided free wall pathway. So we normally do transept. We can do retroaortic also, but our my practice is to do transept procedure and do ablation from left side. So normally it's very safe procedure. I've been doing for last 20 years, but in this case it didn't turn out the way we intended. Well, I was doing a transept puncture. Sorry, just. So before I could realize that I gave a test dose and I realized that I have punctured the aorta instead of through from RA septum to left atrium. And then what do? As soon as we realize, we basically he had to. You can see the previous slide. There is a transformer sheath is there. I use SL sheath. SL sheath is about 8 French sheath. dilator is there inside the aorta and the sheath is outside the wall. Ideal would have been to push the sheath into the aorta and put the device. Unfortunately, we attempted the push device. The sheath did not pass through this aorta, and so we had to change the sheath. That resulted into more catastrophe. So you can see that here we are doing pericardiocentesis, putting a wire and and simultaneously we have to change the sheath, and that resulted into massive blood loss and almost a cardiac arrest. And so with this, we did not lose the wire in the aorta. Aortic wire was kept, and we changed over to sheath to delivery system, which was very fine. And we deployed Conar MF device is there. Once this was achieved, and we waited for 10 minutes, and the Conar MF device has a covering, so we were successfully able to seal this thing. So, and after you can see that the leak has completely sealed off from aorta, the angio shows, and there is a further. And so he settled down and he recovered, and next day we extubated him. Since he was very symptomatic, and once he settled down after 3 days, we again took him for the RF ablation. This, we didn't do any further T or thing. Normal transfer puncture was done, and we were able to ablate his pathway successfully, and we were able to discharge him after 1 week of hospital stay. So what did I learn from this patient is that although the procedure is commonly performed and you are experienced operator, a small mistake can lead into catastrophe. So what did I do? Error of judgment. Normally I use two views, RAO and LO view for transfer puncture. First attempt I was not successful. So I attempted second pullback from the SVC to RA. That time, unfortunately, I did not check into both RO view. I simply went into LO and went. So that was my error of judgment. I should have checked. So learning from this case is that if you repeat the pullback from thing, you must check in two orthogonal views, which I didn't do it. That was a massive mistake on my part. This resulted. And it was fortunate that I was aware of the device, what is available and what can be used. And it was fortunate that it happened during the time when the devices were easily available. Conan MF device has a covering, and we were able to seal it, and so we were able to think. And so second time, I took the patient from posterior. I was wondering, since I already, should I do TE and do transfer puncture, or should I do it? So, but then I think it's been done large. We have been doing procedure for so many years, and we should have trust and faith in yourself. If you don't trust yourself, then what is there? So we took him and we did his transeptal without any worry and fear. We follow the rules that we use check into orthogonal views, and we tested and we did, and then we did, and he's doing, unfortunately, he's doing well. So thank you very much for the opportunity. Thank you.
Great learning case, sir. We always learn from you. That is how we have grown. Sir, do you routinely put pigtail? Because in our EP cases, we do not put a pigtail anymore. We just do a septal puncture.
Sorry?
A pigtail.
Yes, yes, there are various ways of doing transfer puncture. So there are large volume operators who simply don't put any pigtail. They don't put a pigtail. So what we can do is that you put his catheter, his bundle is there, that can be used as a marker for aorta. That people do it. Lot of people do it. So but I always put a pigtail.
You put a pigtail.
Yes. Well, you can use his bundle as a marker for cusp, aortic route, and you can use. You don't have to put pigtail for that. So there are operators in the large volume center. I went to China, Fuwai Hospital. He does not put anything. He just simply puts his catheter, and he does. He has a series of thousands cases of transeptal puncture without arterial sheath.
And this was NCC, sir. Had it been any other cusp, what would have been your approach?
No, I think basically, if you puncture the aorta, you should be able to seal it. You should do something.
So, amongst my younger colleagues, how many of you are doing BMVs? Good number, right? And I learned my BMV from Dr. Bali. In fact, Dr. Bali would remember it very clearly. In the years 94, 95, his majority list used to be BMVs, and I used to be his first assistant. And very clearly, he was so particular about the puncture. I mean, the puncture itself used to take sometimes 15 minutes or so, because he was so particular about it, seeing it in two different views. And unless he was very sure, he would not puncture. And this has come with me. for years together. Now, after almost 30 years also, I still keep my pigtail over there, right? I always check it in two views. And when I have punctured it, I take a shot with the contrast before passing the mulling sheet. So this is what I do still after 30 years, despite doing many procedures like this. I'm not scared of coronaries, I'm scared of BMBs because of this reason even today. Am I right, Dr. Bali? Please.
We, sir, we are also scared because that is how we are trained. One good thing is, I think we follow what Dr. YPS has taught us. Sometimes we pass the dye into RA and delineate the septum, and that makes life very easy. When you are doing BMV, I also consider that in doing BMV, I am very meticulous. But when you are doing a EP case, your guards are down, and you have a list of another 12 EP cases lined up. So you probably do not worry that you just take it that septal puncture is a septum. It doesn't forgive you. It doesn't take it that you are doing EP or BMV. It is unforgiving, but we as an operator, we have our guards down when we are doing EP.
Basically, in 2005, we presented 250 cases of this one in an international conference in Canada. And the whole data was presented. This simple technique, which we showed in one of the CSI in Bombay, when Dr. Tyagi was also seeing, although it was arranged by Dr. Anil and a very big CSI conference, but people were left only 20 sitting. So when we presented, Dr. Tyagi saw when this septal deletion technique with the 100% accuracy and no this one perforation, because even no TE needed, because from the SPC with the just amply capital and Leo, you just give a bit of height and light. The whole of the septum you take on the lateral side and just like you wherever you puncture, it is 100% correct and no perforation or any. When he saw that, he said the concept of biology has changed. You can give a puff anywhere. Otherwise, always used to go blind. It was written in the books that this catheterization and this is a blind procedure, but it is not blind. It is now, of course, come with IVUS and other things, but you give a dye and you proceed further. So this is a septal deletion technique, which was, in fact, at that time, I think, just Behal technique we labeled it in that paper, because Behal was working with me at that time.
Thank you.
Now I would like to invite Dr. Pavan Sarda sir, for his talk.
वीडियोस कैसे चलेगा नहीं नहीं एक मिनट वापस जाओ गुड मॉर्निंग एवरीवन so how to run the video from here okay no this is slide now so this is the RCA angio of a 50-year-old female. She is diabetic. She came to us with class 3 angina and echo showed mild inferior hypokinesia with good LVEF. So we took him for angioplasty. So we crossed the lesion with Fielder FC wire with some difficulty using fine cross. But the lowest available balloon in my case was Sapphire 105, but it did not cross the lesion. So what are the options left with me? One is either changing the guide to AL or put a buddy wire. But since the initial crossing was so tough, So these two options are not in my mind. So what I did, I put one more wire, run through wire, to the extent where it went. And I put one more NY sapphire balloon, 105 on the another wire, and I inflated it at 12 atmosphere. Then I crossed another balloon on filter FC. This time it crossed. So in the main branch, I am having two wires, two balloons, both are 105. One wire was crossing the lesion, another wire was before the lesion. And this time balloon crossed the lesion. And then we did the serial dilatation and put the stents. And this was the final result. So we did two cases like this where we were not able to cross the balloon on the initial wire. We put another wire wherever it went, we inflate the balloon on it and it acts as an anchor also. So even if you don't have side branch, appropriate side branch, you can inflate the balloon in main vessel also. It will also act as an anchor balloon and it will give the support for initial crossing of your main branch vessel.
Why do you think that it did? Why do you think that it crossed?
Because, sir, it gives you extra support because the balloon, another balloon is inflated. So it holds your guiding a little bit more because was very difficult to change the guide at this moment. You have already had so much difficulty in crossing the lesion.
Or is it a guide wire bias, which you are changing actually by inflating another balloon in the proximal segment?
Yes, maybe. But
Right,
I think it gives
because
more support
I'm not very
because we
sure.
did two cases.
That's
Similarly,
okay. I mean, we have done such cases in the LED actually when the balloon is not crossing. I put another balloon in the LED, right? And on top of that balloon, we are able to glide the first balloon which
Yes.
was not crossing earlier. I feel that it is primarily because of the guide wire bias which is caused initially, and that guide wire position changes with the other balloon. That is why your first balloon is able to cross. And by the way, I would still recommend that all these cases, just do a rota. Rota makes life so easy. Or maybe orbital atherectomy is available now these days. Orbital atherectomy, you don't even have to buy the module, they will bring it for you. Because, I mean, this case, I'm pretty sure you must have taken 40-45 minutes to do it. With rota, you would have finished it in 20 minutes. One run of rota, right, dilate, put in a standard, come out. That's it.
Was this
no, it's a scheme patient because I discussed with this
the
Smith
photo,
also.
rotor orbit?
That's why the
Dr. Pawan, can I make a comment? I think first and foremost is to have a good guide sport before you start attempting a case. I don't think JR is a guide caster one should be using.
But there was pressure damping with JR, sir.
Okay, so that's
Sorry, AL. There was pressure damping with AL.
okay. That's one part. Second part is that it is very easy to change a guide. Even if you have a wire down, if the second wire is not going, just put an extension wire and you can change the guide catheter.
So
the third point is that this anchor balloon technique, anchor wire or anchor balloon is of various types. You can put an anchor wire in the side branch, you can put a balloon in the side branch, you can have a power anchor guide. So you put in a guide extension and put a balloon outside the guide extension to anchor it quite well so that it goes into this. Now, in your case, one possibility is very well that the wire bias may have been altered. The other possibility is there is a diffuse disease proximally also before your CTO. So once you are taking a balloon there, it is acting as an anchor balloon. If the proximal vessel is normal, 3 millimeter,
then it will not give enough
millimeter,
support.
then it won't do it. The other thing you can do is you do a balloon angioplasty in the proximal part, which is a normal segment or disease segment, but not critically narrow or occluded vessel. You do a 2.5 or 3 millimeter balloon dilatation there and take your guide extension to as low as possible, close to the total occlusion where you have, and the balloon will cross. The other option, we're not talking about laser here. What you can do is you can do a subintimal wiring in such patients. Put another wire, a stiffer wire, CTO wire, and go subintimally and do a re-entry technique. So a number of techniques, but I think your either it is wire bias or it is because it is diffuse disease, or you would have to use a larger balloon to give an anchor. The same thing in a side branch is a much easier concept because side branch is smaller.
Yes.
And you put in a 1.5 or a 2 millimeter vessel, so that will give you a very good sport. The idea is to get a good sport, whatever way you get it, by good guide catheter, guide extension, balloon, wire, or a power balloon. So idea is to get a good, and the other thing is tortuosity. So many of these lesions, the right coronary mid lesion, would be very tortuous. So your force is not getting transmitted. So you have to devise a method by which you can have the force being transmitted at the site of the lesion, and you would be able to cross. And I learned from Antonio this time that he says that sometimes you can use a wire with a propofol, dip it in the wire, and the wire would cross. So if exposing, normally what we do is we take a microcatheter at the site of the lesion as much as it goes and change to a rotawire. But supposing it is not going, you dip the rotawire in the propofol, and then you are able to. I have not done it. I don't know anybody else has done it, but that is another option which can be considered.
That is how we use it for Yeah, used to. We used to. We used to do it earlier.
Sheath is okay.
Sheath is okay, but
we're talking about rotawire. We're talking about rotawire.
So there was a time actually when I used to use these 5 French catheters actually. Before you have these newer catheters available, 5 French catheter in right coronary artery down to the lesion. Just take it down to the lesion, right? And that gives a very good support, very good support. And then a 0.75 balloon or something, just push it, it just goes. If nothing else is available, do that next time.
Yes.
5 French.
But I think, sir, I've done one more case. I saved that video also, but I removed it in last moment. There is one more RCA like this only. So again, we use the same technique. I think this technique works if you don't have any good side branch where you can park your wire and you can do anchoring with balloon. Because in the second case, the guide was AL also. Still balloon didn't went.
But this will definitely in the future can be tried by everybody simple.
Thank you.
Thank you, Dr. Pavan. Now, invite Dr. Samatya.
Request is please use the mic, sir. We cannot hear your words.
Hello? There was a term called oculostent reflex. That is, you are doing an angiography, and wherever you see a lesion, quantification of the lesion even today is you may call it 70%, other person can call it 80%. This is practical. And therefore, you stent it. I think that thing has not yet gone. Wherever you see a lesion, you stent it. For example, this lady had inferior MI. Now, inferior MI, what is the natural history? Natural history of disease we have forgotten. Way back in 81, 82, we were told by our professors that before taking a decision, you must study the natural history of the disease. Professor Bidwai used to always ask, I have seen MR. Those days we had just got echocardiography. He said, do nothing. Because natural history of mitral regurgitation is very different. It lasts for many, many years. Like that. So is the coronary disease. It's a disease, no doubt. But this is the problem that those days nothing was available. Today you have got very strong armamentarium in the form of beta blockers, calcium channel blockers, antihypertensive, ARB, ACE inhibitors, platelets inhibitors of different kinds, and statins.
Very true, sir.
These are properly used. I can assure you that many cases will go normal life, still having an
Yeah.
my summary.
Dr. Samit, can I suggest something? We should have a panel discussion on this. Let's have all the viewpoints on a one focused topic.
Yes, sir.
Conservative medicine.
Bilkul, sir.
On debatable issues.
Because, sir, we are in a transition zone, I feel, where we are actually thinking of doing a TAVI when we have asymptomatic patient, because it would prevent fibrosis of the left ventricle and further complications. So it's very, two spectrums where we can just let the patient go on and develop symptoms.
Samit, the bottom line is that over the years, Dr. Sahi is absolutely right. We treat with the intervention or surgery if the risk of surgery and intervention is lower than the normal natural history of the disease, right? That is why asymptomatic mitral regurgitation were not taken care by. Surgery was the treatment of choice at that. We were talking of a surgical risk versus a conservative natural history of treatment. Similarly, we have a situation where there is a small VST. Okay, small VST was never managed by surgically because the surgical natural history was such that the surgical risk was higher than treating a. But over the years, the treatment options have improved so much better that the risk of doing intervention or surgery is much lower than the natural history. So we are not talking only of mortality, we're talking of quality of life, we're talking of effort tolerance, and all those factors. When we see that the risk of procedure is far less than the natural history, that is why we start off. So
I think,
therefore, last point, we started by beginning that mitral regurgitation and aortic regurgitation should be intervened surgically if there is a left ventricle dysfunction and patient is in class 2 functional class or beyond, right? Or the left ventricle volume is increasing periodically, echocardiography over a period of 6 months or so. But now we know that the surgical technique has improved so extensively and the quality of life can be offered much better. So therefore, and we also know that earlier these patients are operated, the surgical risk is far lower than when they're operated when their mitral regurgitation has caused to a left ventricle dysfunction. So it is an evolving science.
Yes.
And in every patient, we should be considering what treatment I am offering to and what is the natural history of that patient.
I think I take, nectar from both of them. That today we have to compare between the natural history and modified natural history. Which one is better? We have to opt for that.
Yeah, Sumit, this is very important. I think one should, this is a new discovery that 100 patients which were being operated for surgery, only 5 need surgery. Because I will tell Dr. Gujral in my office when we discuss over a period of 1 hour. Nowadays in PGI, acute MR, severe MR, LV dysfunction, ejection fraction 10%, they are improving to 45, 50% in 1 week. In 1 week, the thing is, this HB factor, cardiac output, is so important. If somebody is being operated at 10 or any intervention, angioplasty or something is being there at 10, the mortality is double and the benefit is not there. If you raise it to 15, the MR, everything comes down, ejection fraction becomes 50, 55%. And Dr. Rana, Dr. Gujral had a very severe, this one in the gold market when he was purchasing medicine. See, Dr. Rana brought him while doing CPR and he remained in CCU for 1 month and was given this, I think you were there, these residents, those at that time. When he was just trying to get up, he came very slowly in my office and he asked me many questions. Dr. Yashpal, you are giving me proteins. My creatinine is 6. Dr. Chug has said that you don't take any protein. His hemoglobin was 6, creatinine was 8, and he said, no sir, these books are wrong. Whenever there is serum albumin is low, you have to take high protein. You have to give an iron. His hemoglobin raised to 11, creatinine became 2, and he said, I will go to Dr. Chug and tell today only, because he was my classmate in medical college, Amritsar, 23 number, where I also stayed. So then when he came to know, if I would have known this, I would not have operated. I would have played golf. My condition would not have been like this if you had told me. The blood which we were giving, 6 blood we were taking. If I would have given 4 blood before, there won't be any need for surgery. This is his burden.
Yes, sir.
Although he passed
Sir, let's not keep the only lady in the house waiting, otherwise she'll also walk away and we'll be left with nothing.
There will be this one benefit of $3 trillion. Next 10 years, if hemoglobin, every procedure is done, and this is calculated, $3 trillion. India will become a developed country by 2032. This is
Sir, please. Go ahead.
it will be done. Even Prime Minister started saying that hemoglobin is 14. If you see that on this.
A very good afternoon to everyone. Firstly, I'm very excited and at the same time very nervous to present in front of such dignified teachers. And I'm the junior most, so I would pardon your any lapses in my presentation. So I'm going to talk on central venoplasty. It's a case series. These were the cases done in the last 1 year by me. And this venoplasty was done because these patients were actually high bleeding risk subsets. So we did not want to give them full dose of anticoagulation or aggressive anti-thrombotic therapy. So I'll begin with my first case. She was referred to me by a nephrologist. She was a 71-year-old lady, CKD on continuous ambulatory peritoneal dialysis. She had bicytopenia. She had vitamin B12 deficiency and superimposed anemia because of CKD. Her hemoglobin was 7.7 and platelet counts were 80,000. She had recurrent admissions because of lower respiratory tract infections and accelerated hypertension in our hospital. So during her last admission, she developed acute upper limb swelling. Over the course of 48 hours. Gradually increasing, but like she developed it during her ICU stay in the last admission. So first of all, we got a USG Doppler done. The nephrologist actually investigated with a USG Doppler, and what they found was only chronically occluded brachiobasilic fistula, which was created long back. That's why she was on continuous ambulatory peritoneal dialysis. So we actually, because she's on dialysis, so we took her up for an angiogram to determine the anatomy and the cause for this acute left upper limb swelling. So as we can see, the shot which is taken with an MPA catheter, that there was an almost total acute thrombotic occlusion of the left innominate vein. So at that time, I was not able to negotiate the wire across the innominate vein because it was, although an acute swelling, but the nature seemed to be quite, it was not soft. So I was not able to negotiate a routine thermo wire and took a proper shot. So I was not sure about what to do because I have never encountered a central venous occlusion before. So I decided to do a catheter-directed thrombolysis for time being with a low dose of alteplase, 0.5 mg per hour for 24 hours. And then I went across literature and I got to read 2-3 case reports. One was published from PGI by Dr. Rajesh Vijayvargiya sir. So it was a similar case of a young lady, CKD, with acute left innominate vein occlusion, and they stented it. So I actually took the patient for a venogram, check venogram after 24 hours of low dose alteplase, and there was not a satisfactory resolution in the thrombus burden. And clinically also, it did not translate into a very obvious decrease in the swelling of the left upper limb. So I decided to go ahead with angioplasty. My apprehensions before taking up this procedure was I did not want to manipulate the thrombus much because it could lead to acute pulmonary thromboembolism, though there is not much data about it, but it is a documented adverse event. So I took a 7 French 90 centimeter destination sheet for a better support because during the angiogram I was not able to negotiate the simple thermo wire, and then crossed the lesion with a stiff angle thermo wire. After that, I took a distal venogram to determine the landing zone of the stent. So as we can see, the superficial drainage was okay. Basilic and cephalic veins, the cephalic vein was okay, but the basilic vein was occluded and it was draining through various collaterals into the axillary vein, and the subclavian vein was fine. So, because of my apprehension of manipulation of the thrombus leading to acute pulmonary thromboembolism, which is a theoretical but very bad catastrophe if it happens, I went ahead with direct stenting so as to plaster the thrombus. And I took a Boston Epic 8 into 80 millimeter self-expanding stent. So actually it is an arterial stent. The case report that I went through, they had used a similar stent platform, and off-table, it has shown good results, good midterm results in patients with venous stenting also. So this was the result after stenting, and then I post-dilated it with 8 into 40 Mustang non-compliant balloon. And this was the final result. So we can see on the right side, this was the pre-angio and the post-angio, and the swelling decreased within 12 hours. And this patient is in my follow-up for 8 months now. She's doing fine. Although antiplatelets have not a great role in venous thrombosis, as we know, because it is fibrin-rich thrombus and not platelet-predominant thrombus. But because of her high risk, high bleeding risk, according to Bar classification, CKD itself is a very prothrombotic state. So I just kept her on clopidogrel, and she's been doing fine till now. So this was the second case, 68-year-old male. He presented to our hospital as a out-of-hospital cardiac arrest survivor. So he was a known case of CKD, diabetes, hypertension, but never received any treatment. And he came to our hospital in shock. When we evaluated further, it came out to be UTI, sepsis, septic shock. He was intubated. Over time, the course was improving, but over a period of 2 days, suddenly respiratory distress started happening, and also acute onset swelling of his face and bilateral upper limbs. Left was more than right. Right was fine, but the left upper limb was quite swollen. So first we got a HRCT scan done for this patient. The radiologist reported that there was a filling defect in the left innominate vein, and they could not visualize the SVC. So looking at his face, we thought that this might be an SVC obstruction causing facial and upper limb swelling. But when I took the patient for an angiogram, because the CT was not very clear, they could not properly comment on the SVC. The SVC drainage into the RA was fine. The drainage of the right innominate vein was also fine. However, the left innominate vein was 100% occluded, and there was diffuse thrombotic occlusion of the left internal jugular vein as well. So again, defining the distal landing zone, which would be free of thrombus, we can appreciate that the subclavian vein just before the venous valve looks okay. So I decided to place the stent distally at that point. So till now the summary is it was a left innominate vein, 100% thrombotic occlusion with diffuse thrombotic occlusion, thrombotic segment in the left internal jugular vein, and the distal landing zone has been defined just prior to the venous valve. So first I tried to do balloon angioplasty of the left internal jugular vein. First I used an 8 into 40 Mustang balloon. But after ballooning, the result was not satisfactory. As we can see, still thrombus is there, and the filling is also not very good. So I decided to upgrade the balloon size to 14 into 40. However, the result was not very satisfactory. So I decided to address the left innominate vein first and then go ahead with the catheter-detected thrombolysis of the left internal jugular vein. So this was the pre-stenting venogram. Another challenge that we faced during this plasty was This stent platform that I had selected based on the size of the subclavian artery, it was 14 millimeter in diameter, and it required a 10 French sheath to be introduced. So we exchanged the 7 French sheath, femoral sheath, to 10 French. However, the stent would not negotiate past the right atrium. So there was a loop and it could not negotiate, and we did not have a dedicated 10 French delivery system. So fluoroscopically, we determined the adequate length using an AST LifeTech sheath and then cut it accordingly and use it as the delivery system. After that, we deployed the 14 into 60 Boston wall stent. This is actually a dedicated venous stent. So it is also used in peripheral arterial diseases as well, but this can be used in venous plasties. So it is actually indicated for both. After this, we went ahead with post-dilatation, and this was the final result. On the right-hand side, we can see this was before the angioplasty began. After that, I took the left internal jugular vein axis and decided to do a low-dose catheter-directed thrombolysis with altiplase at a dose of 0.5 mg per hour for 24 hours. So this was the result. The first image shows the patient that there is obvious venous congestion seen and swelling, although the patient was obese himself. After 24 hours, there was a significant reduction, and after 48 hours, he came back to his normal contour. This patient belonged to Gurgaon, so he went to Gurgaon. He received care there as well because he was started on dialysis, maintenance dialysis. And for some reason, the cardiologist there checked the patency of the stent, although the patient did not have any recurrence of the swelling. And then they reported to us that the stent was patent and the left internal jugular vein also was patent. There was complete resolution of the thrombus from the left internal jugular vein as well. So this was the final case. He's a 66-year-old male with acute onset facial and bilateral upper limb swelling, which increased gradually over 2 weeks. He actually came to us with shortness of breath and recurrent hemoptysis. He was referred to me by a physician. The physician already got a CCT chest done, which showed CA lung and possibility of SVC syndrome. So he was also high bleeding risk substrate because he's got recurrent hemoptysis. And so I don't have the cine images of these. I've made a collage of it. We can see in the first image that there was a huge chunk of thrombus occluding the mid SVC, almost 100%. And the junction of the left innominate vein to the SVC also has a large thrombotic burden. The subclavian vein is fine, so if I had gone for left innominate vein stenting, I could have used that as a distal landing zone. But I decided to do only balloon angioplasty of the left innominate vein because these venous stents are actually a costly affair. This is the Vinovo stent that I have used, 16 into 80 millimeter. It cost around 1.25 lakh. So the patient could not afford another stent for the left innominate vein, so we just did a routine balloon angioplasty for the left innominate vein and put a Vinovo dedicated venous stent for the SVC. And this was the result after 12 hours. Now, this patient again came to us after 1 month. We referred the patient to oncology, but they did not consult an oncologist. And the patient came to us in acute respiratory distress. Although there was no facial swelling, the stent was obviously patent, but the patient succumbed to his primary disease, that was CA lung, and he died during the course in the hospital. Otherwise, the last 2 patients, they are in my follow-up for more than 6 months, and they are doing quite well. In this patient, we gave him 2.5 mg of apixaban follow-up twice daily, but in the first 2 patients, because they were high bleeding risk substrates with anemia, thrombocytopenia, and the second patient had sepsis, DIC, he had a borderline INR of 1.5, so I just kept him on clopidogrel, though not theoretically sound because antiplatelets have not much role in venous thrombosis, but till now they're doing well, and we do not actually have a very robust long-term data on anti-thrombotic therapies for venous stents. So my learnings from these cases were, these are the only 3 cases that I have done. I'm the junior most here, so I'm ready for all criticism. So these are my learnings. Central venous angioplasty is a feasible and safe option in acute thrombotic occlusions, especially in the high bleeding risk groups, including cancer-associated thrombosis. Every case is unique in terms of patient demographics and anatomical challenges, thus demanding tailored approaches, spontaneous thinking, and on-the-spot decision-making. Thank you for your patient listening. Thank you for the opportunity.
Thank you. I think it is something different we have tested. In your first case, you did a catheter-directed thrombolysis. The first
In
case, the lady.
in the second case, yes, sir. Before taking her up for plasty, I did catheter-directed thrombolysis, but the result was not good after
Okay.
CDT.
So I thought probably the cannula was on the left arm for thrombolysis. That is a small minor thing. We avoid cannulas where you have a dialysis AV fissula
So it was
because that
super.
sometimes can become a reason for thrombophlebitis as well as thrombosis.
The CDT catheter was by the femoral vein, so I didn't.
So she had a
She had
cannula
a
on the
yes.
left arm, on
Yes,
the fissula.
Yes.
Very nice case. In fact, I don't do these cases, honestly speaking, but I have seen my peripheral interventionist using angiojet for the lower limbs.
Yes.
Any experience of using angiojet in such a situation over here?
No, sir. I've used it for lower limb DVT.
Yeah.
But not yeah. It's also a costly affair. So I think it costs around 2.5 lakh if I'm not wrong.
So is the cost only consideration, or I mean,
yes, sir. I think
I want you to teach me
yes.
whether it can be used in these systems also.
Yes, sir. In ideal setting where financial constraints are not there, I think we should first go ahead with thrombus aspiration because these were all acute thrombosis. Maybe after thrombus aspiration and followed by CDT with a low dose of altiplase, we would not have even needed doing the stenting.
Right. And the other thing which I have seen, at least in two cases, I mean, two cases will probably not count as the gospel truth. Two of these patients who came back with these venous stents, they constantly complain of pain right in the chest. And when I asked my peripheral interventionist who has done these, he says, sir, these stents, they keep on expanding in the vein, actually. These are used to be, they are for arterial system. And so they have a lot of peripheral force. So they keep on expanding and they give a lot of pain to these patients for maybe a couple of weeks or months together. What is your experience?
Sir, actually, there are 3 stent platforms which are dedicated venous stents. So in the last case, I used Vinovo. It is by Bard. It is a dedicated venous stent. And Bard also gives Fluency. That is also a dedicated venous stent. The Epic by Wall stent by Boston, that can be used for both venous and arterial stenting. But the first stent, the Epic, was only is only indicated for arterial stenting. I have experience of only these 3 patients. They did not. The 2 of them, they have not complained of pain yet.
How much post-dilatation do you do? This is a venous system, so
Yes,
I'm
sir.
not sure.
I was not aggressive. I just went ahead with the nominal that was 6, both for Mustang and Atlas balloons, although the rated burst pressures are 24 and 18 respectively, and they are non-compliant balloons.
I think these venous interventions are very emerging new in cardiology. The cardiologists at the present are not taking too much interest because of these two there. But all cardiologists should have good knowledge and this intervention of venous, because venous intervention is equivalent to arterial intervention if you see the volume the patient has. Sometimes these are done by surgeon or radiologist where the results are not good because medicines and other things matter a lot. So
Yes,
if
sir.
venous are done, the life expectancy of patient and this will become much, much better.
So, have you ever considered leaving these after thrombolysis? Have you considered leaving them with the balloon angioplasty alone?
So in the first case, the result was not optimum. Clinically also, it was not good, and angiographically also, there was no proper recanalization. So maybe we could have just left them on medical therapy.
None of us, I don't think we have a lot of experience with these
Sir,
venous cases.
because of the venous flow is slow, usually it's again unforgiving. You have to stent it. The thrombolysis leaves.
Dedicated catheter with multiple holes.
Sir, that is catheter-directed thrombolysis. Even if you do that, you clog the distal most end and you do a shower of thrombolysis. In venous system, thrombolysis does not have the same result as it has in arterial system.
In couple
probably you cannot just do away with a plain angioplasty. You have to stent these systems.
Pictures also, venous pictures along with
So
in couple of cases which I have done.
That is why I think she was right that antiplatelets do not have any role in venous system for the same reasons. It's a slow.
I think what we are missing is we are taking all venous obstruction as one entity. We need to understand what is the etiology of blocks. Is it fibrotic occlusion? It is thrombotic occlusion? It's a mixed occlusion? What type of occlusion is? How long the occlusion is? What is the vessel size? All those factors have to be taken into consideration. Now here in dialysis-induced, fistula-induced occlusion, usually they are fibrotic occlusion. On top of that, there is a thrombus formation. So initially the approach is to do a balloon angioplasty. And sometimes you may require a very high pressure balloon dilatation to be done. You use a smaller balloon and go at a high pressure. You may have to keep the balloon waste for a long period of time. Sometimes the balloon inflammation have to be kept for 4, 5 or 7 minutes for the waste to disappear, or even use a cutting balloon. If there is a recurrent obstruction in this type of a venous obstruction, dialysis directly, then a stent is required. Stent as a primary modality is probably not as good because the occlusion is high.
Yes.
And that is the one part. There are venous disease of all types. And in PGI, since probably 70 or 75, Budd-Chiari was a very important cause of problem. And IVC angioplasty was done. It fell out of dispute because one patient had a mortality when it was being done in radiology, and we started doing it 15 years later. So we have to understand what is the pathology of the venous obstruction. So all cannot be same. If there is a thrombotic occlusion, we were mentioning about catheter aspiration, and we have multiple types of catheters now available. Penumbra is one, Irani is another, number of them. And they depend on various sizes. Unfortunately, the price of the catheter goes geometrically high as the size increases. If you use an 8 French, it may be costing about 1.5 lakh rupees or so. But if you use a 14 French, which sometimes you have to use in large venous obstruction, it may be costing 6-7 lakhs. So that cost is a very huge consideration. And the other consideration was because once you suck it out, a lot of blood loss used to happen. But now the newer devices which we have, which is AI-directed venous aspirations, the blood loss is much less, and sometimes you can do an auto transfusion also. So wonderful job done, yes. But all venous occlusions are not same, yes. And all venous occlusions don't need stenting.
In my cases, I have not stented any of these. They are all dialysis related. And
so they are CKD and cancer patients?
CKD and cancer, of course. And all of these central venoplasties, as sir said, high pressure balloon, and they were 6 or 8 mm, not 10 or 12. You know, it's too dangerous. None stented, and they are all doing well. They did well for at least 6 months. Not
Sir, stents to be avoided for the same reason that it's a slow flowing system. So stents have a higher chances. Sir, we'll close. We have a new entrant, Dr. Dheeraj Garg. Nahi. Bhupinder Garg. Pushpinder Garg, sir. Sorry.
You don't know Pushpinder Garg?
No, sir, I know. No, I know. Because the call came two presentations before, so and I got so engrossed in the discussion. Wait, last case. Sir.
Namaskar, my all teachers, colleagues and juniors. So, sir, इस प्रेजेंटेशन की जो स्टोरी है वो 2006 में शुरू हुई थी. मैं डॉक्टर राजशेखर और बाली सर हम लोग असिस्ट कर रहे थे. सर एक RCA CTO खोल रहे थे, and during that procedure patient had stroke, and sir did immediately that carotid angiography, and the patient was recovered subsequently. So after that, I have never seen, after doing a lot of procedures. So this patient first time presented to me in 2016. I did initially plasty of left circumflex artery, and then third day I did plasty of LAD and RC. That time it was a lateral wall MI, so primary PTCA of LCX was done at that time. And day 3, after the plasty of LCX, or day 2 of plasty of LAD and RC, he had stent thrombosis of LCX, and I did the POVA to LCX with high pressure balloon. So this was the first time when he presented to me, and this time he presented, this was 2 years back, so he presented with ISR of LAD, and I took him for plasty to LAD ISR. So it is proximal diffuse LED stent ISR, and after ballooning, a long stent was placed at ostium and to mid LED, and we inflated the stent. This is a very good result, and we came out, and immediately what we see at end of procedure, patient developed seizure, bradycardia on monitor, and he became unresponsive, followed by aphasia and dense right hemiparesis. So we took him to for CT scan. CT scan was normal, and we intubated the patient. There was a progressive hypotension, unresponsiveness in the patient. So what I did as a life-saving procedure, I did carotid angiography of that patient. So carotid, this is carotid DSA, which is normal. Another side. When I was doing the carotid angiography of this patient, I noticed he had again ST elevation on monitor on LAD, and there was a LAD stent thrombosis. This is LAD stent thrombosis. So before anything for CNS, I did this, and I again did the POVA of LAD ostial stent, and finally we could achieve a flow in LAD. So the story of coronary is complete here, and then I did the angiography of CNS vessels. So this DSA showed the both carotids were normal, but there is a ostial left vertebral artery stenosis. We can see here, and so we went to other side and we tried posterior circulation also from the right side, but right side was very much tortuous, so it was, we were not able to perform posterior circulation DSA from the right side. I again came back to left side, and I crossed the wire, and what we can saw, basilar artery thrombosis, 100% basilar artery thrombosis. It is easily here, and there is a clot is there in basilar artery. So we reached by simple JR guiding to axillary artery, vertebral artery, and first we crossed the wire across the vertebral artery, and we put a stent in vertebral artery here. And surprisingly, by crossing of wire and balloon in the vertebral artery up to basilar artery, the basilar artery opened immediately. So one can see the basilar artery is opened here, and what we can notice, that patient started moving his head immediately, opening of the basilar artery. And this is the final scenario of basilar artery. Whole of the posterior circulation is now flowing well. So what we did here, stent to origin of left vertebral artery, and just ballooning and like rotring of the basilar artery system. Same day patient extubated. Day 3 he was moving, little bit limping also, but for 2 years he was perfectly okay. Limping was also removed, and today morning he again had stent thrombosis of LCX. For that I did in morning plasty for stent LCX today also. So this was the 4x5 power on table and 5x5 power at time of discharge. So what are the risk factors associated with uh, stroke during the cardiac procedures. So advanced age, associated cardiogenic shock, carotid artery disease, presence of atrial fibrillation, and radial access. Radial access is more commonly associated with stroke, and when we use newer thrombus extraction devices, rota and everything, they also causes more chances of stroke in such patients. And what are the approach we can discuss whenever there is some kind of thrombosis, acute thrombosis? First approach is always thrombolysis. But difference between the during procedural stroke is the majority of are the atheroma debris. So they never or they give little response to thrombolysis. So mechanical thrombectomy by any method is better for such patients. Early diagnosis and early treatment, the patient can recover. Otherwise, our good plasty, our best efforts, they go waste. Thank you.
Thank you, sir.
So I did 7-time angioplasty of this patient. Last is today only. And I don't know what is the reason. And
sir,
yes, sir. Yes.
So, if you have a fourth part of vertebral artery problem, and you have an ostial vertebral artery, it is better to tackle the distal first, and on your way back, stent the ostium of the vertebral. Because once you do the stent of ostium of the vertebral, you're using a balloon expandable stent. So you'll have to take one stent at least into the subclavian artery. So it will alter the angle. So therefore, it is you only taking 2 minutes extra. So tackle the distal first, and it is desirable that you go with the same technique by which mechanical thrombectomy is done these days in stroke patients, solitaire or whatever technique which you use it. And that would be very useful. But please investigate this patient for a thrombotic disease. It's probably not atherembolic. It's thrombotic.
Thank you. Well taken, sir.
We also witnessed.
I think you deserve a standing ovation for such a wonderful case.
Thank you.
Most of the people would have left it.
Sir, वो आपकी प्रेरणा थी.
So we also, during my training days also, we witnessed one such case where we were doing BMV with Dr. RV. Patient developed stroke on table, and the next thing he did was that he took a guide to the carotids, saw the obstruction and did a thrombolysis on table, and we saw that patient recovering in the next 5 minutes. So only 5 or 10 minutes was the response time that he realized that probably we have thrown a thrombus, and therefore the results were very good. And
Sir, how much time did you take to take the patient to the CT and bring him back?
so
I thought you should have done it
He has a
immediately.
hybrid cath lab, sir, where CT is inbuilt in his
Okay,
cath lab.
that I didn't know. Sorry.
Sir,
But generally, I mean, this is the
system at my center is very fast.
Okay.
Within minutes, we can do.
Sorry.
Doctors determining the outcome, we should also add who owns the cath lab at the hospital.
Good.
Thank you, sir.
Excellent case.
Thank you, sir.
With this, we conclude our first session. Thanks to all the dignitary on the dais. So moving ahead to our next session, which is very interesting scientific session. For conducting this session, I would like to invite Dr. Vijay Patak sir on the dais, Dr. Ratnani sir, and Dr. Ashwini Sharma. And first speaker is Dr. Professor Amuthan, who will give presentation on 3D echo evaluation of the tricuspid wall. I would like to request every speaker that please be sincere with the allotted time, which is 15 minutes for a given topic. Thank you.
ये भी हटा लो, ऐसा ही करना, ऐसा ही करना इनको। Pointer will be there. So, pointers. Should I start? Should I start? Shall I start now?
Respected Chairman, shall I start? Respected professors and my dear teachers and colleagues, it's a great pleasure to stand before you to give a talk on this. And the most important point which I would like to emphasize is that in the day-to-day practice, 3D echo adds to make a diagnosis, and it adds to your perfection of the diagnosis. That is what I want. And it has transformed the evaluation of the tricuspid valve. Most of the cardiologists, the interventional cardiologists are now doing intervention of the tricuspid valve. So I thought it would be an apt topic for the interventional cardiologists as well as the echocardiographers, overcoming the many limitations of the conventional two-dimensional echocardiography. There are these are the assessment of the tricuspid valve anatomy. Usually has 3 leaflets, and that can be multiple also, depending upon that. Then you have to assess the papillary muscles. I will show the importance later, and the tricuspid valve annulus, and you can see every bit of anatomy in this 3D. First of all, the scanning table should have a cut in the bed. To have this, patient should be in the steep left lateral position, and then go for the tricuspid valve acquisition. Slightly, you have to take the transducer slightly superiorly and tilt it downwards so that you get the RV focused apical four-chamber view and the view of the tricuspid valve. The tricuspid valve can be rotated to the standard position which was initially described by ASC, that is in the 6 o'clock position. But now routinely this view is used, and this is the ventricular view on the right hand side. You see that this is a septal leaflet, and this is the anterior large, and this is the posterior leaflet which can be seen, and this is the atrial view. Here it is just opposite. Here is the septal, and this is the anterior, and this is the posterior leaflet. And you can add so many factors which are available with the 3D machines. This is one important thing, that is the dual crop. You can have a initial site in the RV or in the array, then put the cursor and then do this crop. This is a dual crop. So this is the ventricular view which you see here, and this is the septal leaflet, anterior leaflet, and the posterior leaflet. This is the standard format which you have in 58% of the cases. It is trileaflet, the tricuspid valve. This is a view from the other side also you can have, and the current classification is that type 1 is the 3 leaflet, and type 2 is 2 leaflet, and type C is 4 leaflets. Either one of the leaflet is bifid. So, and type 5, type 4 is more than that. So, normally it is 58% of the cases it is type 1, and here you can see this is a patient who has a septal leaflet, anterior leaflet, and the posterior leaflet. You can see here the posterior leaflet is bifid. This occurs in 32% of the cases. So these two are the commonest.
and you can have the variants of the bifid and other things. And you have so many advantages now. You can add the photorealism, and you can add it in the cath lab, the fluoro echo, 3D echo fusion echocardiography. And this is image acquisition, which I was telling you. This is a fourth chamber. You have to go slightly superiorly and turn the transducer downwards towards the tricuspid valve. That is how you acquire the apical RV focused apical four chamber plane, where you can do the RV calibration. This is LV volume analysis by 3D, so that you have the 3D acquisition. Now, this classification of the tricuspid regurgitation is one of the most important thing, which can be primary or CAD related TR, secondary, which may be ventricular or atrial. Primary, you have the congenital, infection, infiltratory process, and other things. So, and this is the case 1. I will show some of the case-based discussions. The case 1, you see here, this is the tricuspid valve, which is in the systemic circuit. Here, the systemic ventricle is the RV. This is most commonly happens with corrected transfusion of the great vessels. So this is a tricuspid valve in the systemic ventricle. You can see that. You can see the tricuspid leaflet, the septal papillary muscle you can see, and the moderator band in the systemic circuit. This is the morphological left ventricle is in the venous circuit, that is in the other side. This is a triplane view TE done for this patient. You can see here, this is the morphological left atrium connected to the right ventricle, and then it gets connected to the aorta. So corrected transfusion. So all these things can be easily identified by 3D echocardiography. This is the one of the commonest manifestations. This is the apically placed tricuspid valve, and the septal leaflet, which is more apical, more than 1 centimeter below the annulus, you can see here. And by just cutting at this level, this is called as translation, you can identify the septal leaflet appearance. Just this is a translation line, and you can move it from apex to base, or from the annulus to the more apical views, so that at what point exactly the septal leaflet appears. So that can be identified, and you can exactly calibrate that. This is another patient with Epstein's malformation, and you can have that. And these initial days, when my pre-DM days, we had more incidents of tricuspid stenosis associated with mitral stenosis. I had presented that time in one of the API conferences, tricuspid stenosis complicating around 20 to 30% of the cases. This is one of such cases where there is very tight tricuspid valve stenosis associated with mitral stenosis. But what we see commonly now is mitral stenosis with organic involvement of the tricuspid valve, which is associated with both tricuspid stenosis and tricuspid regurgitation. You can see here massive tricuspid regurgitation, and the 3 leaflets can be seen. This is the septal leaflet, atrial leaflet, and the posterior leaflet. And you can use various, this is called as flexi light. You can place light inside the place where you want to see, and you can add the photorealistic images. This is a photorealism, where it just looks like the surgeon when he opens it. And you can have the calculation of the tricuspid valve area, as well as the regurgitant volume also can be calculated in the same sitting. It's called as anatomic regurgitant orifice area calculation. So it's very easy, just planimeter that, and you can have that. You see this, you can just planimeter this area instead of the very complicated analysis which is done in 2D. This is easier. Here, this is the fluxy slice view where you calculate the tricuspid valve annulus area. This is 2.3 here. Normal tricuspid valve area is 6 to 9. And this is another case where you have this is a patient with a 29-year-old patient, drug abuse. He had the vegetations. You can see here the vegetations and the TR, GLS and other things. This is the vegetation which is seen in the 2D. This is the 3D. 3D gives you the exact appearance, the surface of the vegetation and the multinodular pattern which is seen there. This can be seen, and this is the TE patient, and this is the SVC. You can see again there is a mural vegetation in the SVC or a junction there. The large vegetation. See the surface can be easily marked by this thing. This is another girl who had undergone surgical closure of the ventricular septum, who had a vegetation there, where there was a ventricular septal rupture, as well as there is a large vegetation there, you can see here. And this is viewing of the tricuspid valve in this patient. There was also involvement of the tricuspid valve in this patient. You can see here the nodules over that. This can be clearly seen over the anterior tricuspid leaflet in this. This is one good old case. Any talk of tricuspid valve is not complete with carcinoid syndrome. This is a known case of carcinoid syndrome who had undergone pneumonectomy, right lung, and this is 6 years after the pneumonectomy. See the large mass which is seen in the right atrium. You can see that. And see also the tricuspid valve which is markedly thick in this patient, and the associated TR. So the 3D easily says, when you have a long axis view, you can easily diagnose that this mass is originating from the other side, right atrium, and pushing on the left atrium. This can be easily seen by using the 3D echocardiography. This is the MRI of the patient, and the patient had the TE probe could not be crossed, so we did the surgical gastro opinion, and they diagnosed that there was an ulcerative lesion, and biopsy was done for that. Now coming to secondary TR, these occupy more than 80% of the cases of TR. And for these interventional cardiologists usually go ahead with their tricuspid valve clip. So this is a 69-year-old male alcoholic. You can see here the clot in the RV apex. This is a tricuspid valve and massive TR in this patient. You can see that. And this is the tricuspid regurgitation jet, which you can see here. This is what I was telling you. This anatomic regurgitant orifice area can be simply planimeted by this method. And this is a tricuspid valve quantification tool, which can be used to calculate the coaptation point height. When it is more than 10, you can have that is an indication for clipping and other things. So tenting volume and other things you can have, and this tricuspid quantification can be done prior to the intervention. This is another case who had undergone mitral clip, and patient developed severe TR, for which evaluation was done. You can see here, and this is the tricuspid leaflet which is seen. And this is another case who had undergone tricuspid clipping. This is a post clipping image which is seen here. This was seen, and this is another case of this is precapillary, where you can see here this young girl. This is a large thrombus is seen in the main pulmonary artery and in the RV also. The TR jet, you can see the P gradient is more than 5, indicating the systemic pressures in the And this is the tricuspid valve, septal leaflet, anterior leaflet, and the posterior leaflet. And you can see that this is the TR quantification, which is done here. This planimetry and anatomic regurgitation are these are large thrombus in the RPA. You can see that. So this is another case. This is a very interesting case where there is calcification of the anterior tricuspid leaflet papillary muscle, papillary muscle calcification. This usually happens in EMF cases. And this is the TAPSE. RV ejection fraction was 44. And this is the GLS, RV GLS, and this is a free wall strain, which is minus 22 in this patient. This is atrial functional TR. It is most commonly due to atrial fibrillation, associated atrial fibrillation. This is a 76-year-old guy. And this is CID related TR. This is most important, which is coming. This is a young doctor who had undergone pacemaker after mastectomy surgery. And she had this pacemaker insertion. And you can see here the movement of the tricuspid, the pacemaker catheter, which is in the center. This can be identified, or whether it is attached or impinging upon. This is another case of pacemaker. She had a pacemaker done 30 years back. She had pacemaker syndrome, and you can see here the pacemaker wire slightly impinging over the posterior tricuspid leaflet. This is a pacemaker syndrome patient. Thank you for your attention. Excellent demonstration, sir. I just want to know whether transesophageal echocardiography, if we do routinely whenever we are in doubt, that over it, how 3D helps in management of this tricuspid valve disease? 3D actually gives the all the end-phase view of the tricuspid valve is not possible by 2D. You cannot see all the leaflets in a single plane. This end-phase view you can get only in 3D, where you can see the septal leaflet, posterior leaflet, and the anterior tricuspid leaflet. And especially when you want to do tricuspid clipping, you must identify which is the leaflets which you are going to clip. So in that area, only this will help you. With the 2D, you cannot identify that. You have to do 3D. And 3D is very easy now. Transthoracic echocardiography, 3D echocardiography, you can identify you can get the end-phase view in 90% of the cases. You don't require a TE. Transesophageal again, the end-phase view will be obtained only in 60 to 70% of the cases. So transthoracic echocardiography is very effective, and you can do that. And additional identification of the nodules or the infection over the tricuspid leaflets I showed you, that is possible only by 3D. Excellent, sir. House is open for discussion.
So the wonderful demonstration of the evolution of a right ventricle as well as tricuspid valve. One important thing is that we need to set the gain settings while you are making the 3D views. Otherwise, what happens that the orifice area or the false appearance as if there is perforation or cleft in the leaflet might also be possible. So the adequate gain settings are really important while you are going for 3D reconstruction. You very well demonstrated rare entities in the form of carcinoid syndrome, EMF, regarding CIED. One important thing is that whenever you put a device and leads are going through the commissures, these are associated with least possibility of regurgitation. But if these are in the main orifice rather than commissure, then more chances of tricuspid regurgitations are there. And now we have dedicated sheets also, so that we can push the lead into the one of the commissure, so that in future they won't have more tricuspid regurgitation.
So, transthoracic 3D helps you to identify whether in a pacemaker patients, to identify whether the pacemaker wire is, lead is freely mobile, non-impinging on particular leaflet, other things. I showed you the second case where it was impinging upon the posterior tricuspid leaflet, leading to the gross TR and pacemaker syndrome in that patient. Probably it was a older type of pacemaker, VVI pacemaker, and she went into the pacemaker syndrome.
So thank you, sir. If there is no more comment, we'll move to the second presentation by Dr. Gurnath Parale.
Thank you,
It was
sir.
really a wonderful presentation. And now, as we are diving in more and more with artificial intelligence, in the era of artificial intelligence, the talk is on AI in ECG.
Thank you, Dr. Ram. Really good to be here, the colleagues, friends, and my teachers. Now, away from the hardcore cardiology, slightly a lighter topic. Now, as you know, the EC has been here for more than 100 years, and it has still retained its relevance, significance, despite onslaught from all modern gadgetry. And it has, with AI coming in, it has reinvented itself. Now, many things a simple 12-lead ECG can do. None of the sophisticated investigations that we have today are able to do. This I'll just demonstrate with a few examples, some from the literature, some from my own experience. Now, basically, whenever I talk about AI in ECG, the common question which a general practitioner or physicians ask me, see, we always get some interpretation from the modern ECG machines, Philips G, and how does the AI differ? The basic difference is computer-generated interpretation is on predetermined rules. For example, RV6 plus SV1 more than 35 millimeters. That is LVH. So the computer will say LVH if this rule is observed. But however, we know that a thin chest wall person can have this and yet he may not have LVH. Similarly, a thick chest wall person can have this and can't have this but will have LVH. So there are many false positives, many false negatives. Similarly, a computer is fed with the information if ST elevation is more than 1 millimeter in consecutive leads, then that is infarction. But you know, there are many false positives like early repolarization and pericarditis, and that can be misinterpreted as infarction by a routine computer interpretation. But AI interpretation is different. What AI does? In AI, you give the ECG with a proven left ventricular hypertrophy. So eco-proven left ventricular hypertrophy is given to the model. It learns the patterns. And these patterns are different from this formula which we feed. And then it itself learns. And then it interprets whether it is LVH or not. It interprets it is myocardial infarction or not. So the false positive or false positive with AI ECG is much less. It is more likely to be accurate than a computer. And how does AI do it? Now we interpret ECG on PQRST waves. How does AI do it? Now every digital ECG machine today, the sampling frequency which ranges from 5,000 to 10,000, meaning that every lead has minimum 5,000 points. So 12 leads has 60,000 points on basic ECG, and modern ECG machines have 10,000 sampling frequency, that is 1,20,000. So AI looks at 60,000 to 1,20,000 data points. and we look only at PQRS waves. So what we cannot see, AI can see, and that we will see. Now the first application of the AI came for left ventricular dysfunction. This is for early detection, and it was basically only on ECG, and that naturally it will improve outcome. Just to give an example, this is the most of the data or the trials are coming from Mayo Clinic. Now this is a one trial AIM ECG study that showed that with a very high accuracy, very high sensitivity and predictive specificity, you are able to detect whether the patient has low ejection fraction or a normal ejection fraction. Just to, and even in a trial in periphery, they shown that the diagnosis of picking up left ventricular dysfunction in peripheral centers, it got improved just by using 12-lead ECG. And there is still a long Eagle trial going on, and the results are expected soon. Now, just to give you an example, if we are given this ECG and asked whether this patient has left ventricular dysfunction, I don't think we will be able to tell with the certainty whether he has LV dysfunction or not. What we can look is whether there is P-terminal force, LVH, and that sort of a thing. But with certainty, we will not be able to tell. But when AI model was given, it said that the probability of low ejection fraction is 76%. And this patient had an ejection fraction of 18%. So a simple 12-lead ECG can tell you whether patient has the dyspnea is because of the heart failure or not. Now going a step further. Now this example, the patient on the left, the ECG looks normal, but the AI model said that this ECG is positive for low ejection fraction. And when the actual ejection fraction was 50%, so it was labeled that this is a false positive. It has a wrongly diagnosed low ejection fraction. But few years later, this same patient went on to develop left ventricular dysfunction. So a thought was whether it predicted left ventricular dysfunction. Now many such cases, in a long trial it was found that when AI predicted left ventricular dysfunction, although patient did not have left ventricular dysfunction at that point of the time, 30% of them over the next few years develop left ventricular dysfunction. So like an astronomer, you are predicting what will happen in future. AI is just predicting. So a previvor concept came. So you can actually predict few years before whether this patient, see, imagine if we know beforehand, we can prevent with our current medical treatment, we can perhaps prevent future left ventricular dysfunction, a significantly comorbid condition. Next is atrial fibrillation. You know, atrial fibrillation carries a tremendous morbidity, mortality, and stroke. Now, routinely, most of the times, the atrial fibrillation is intermittent, and a routine ECG is a normal sign ECG, and you miss many young strokes or many patients with stroke. The underlying cause is atrial fibrillation, which is missed because a routine ECG or a conventional investigations like a Holter, prolonged Holter, does not pick that arrhythmia. Consider this example. The ECG here on the left lower, this ECG was recorded in 2008. It was sinus rhythm, which occasional ectopic. AI model was given this ECG. It said no silent AF. So it was sinus. Few years, 5 years later, the same patient, ECG is sinus, AI model given this ECG, it said silent AF present. Okay, it is sinus rhythm ECG. And this patient later on went on to develop atrial fibrillation. Okay, so now just imagine this is a real life patient. Now, so this is again a data from Mayo Clinic with a very high sensitivity and specificity. It has shown with a large number of patients that AF can be, the silent or intermittent AF can be diagnosed on a routine sinus rhythm ECG using AI model. Just the real life example, sorry, this real example is lost. Sometimes we have a patient who has one episode of stroke, second episode of stroke investigated with extensive investigations, TE done, long-term monitoring done, and you don't pick up AF. But if you have this model and if you can pick up that AF, perhaps anticoagulation can prevent subsequent strokes. In fact, there is a study now just been undertaken called as a Beagle study, which is looking at this AI model diagnosing atrial fibrillation. These patients have been put on anticoagulations, and these patients are being followed up and will say whether this prevents the stroke compared with those patients who have stroke, but the AI model has not shown atrial fibrillation. Now, another important is for detecting hypertrophic cardiomyopathy. Though we have a very classical features of hypertrophic cardiomyopathy and ECG, around 10% of the patients don't have ECG features of hypertrophic cardiomyopathy. In fact, we have seen many times when a person who is going to undertake any physical activity, maybe military personnel, police personnel, we just do ECG and make them fit. Maybe put them on a stretcher and make them fit. But many of them have underlying hypertrophic cardiomyopathy. We have seen sudden deaths after marathon. We have seen maybe the silent hypertrophic cardiomyopathy, because we don't do routine echocardiography, might be missed. Now, just imagine if you have a 12-lead ECG, which is diagnosing hypertrophic cardiomyopathy with a very high sensitivity and specificity. Now, consider this young girl who had syncope. And I don't think we will be able to diagnose the cause of syncope with this ECG. We might look at what ARs we see, we might look at Brugada, nothing is there to say whether this patient has any cause for sudden cardiac death or syncope. But when AI model was given this, it said there is a 73% chance of having hypertrophic cardiomyopathy. No fancy investigations. Just AI non-invasively with a basic ECG tells you cause of syncope. No EP studies. So this is how it can transform the way we are going to go about diagnosing and predicting future conditions. Now, very important. This we know echocardiography, when patient of echocardiography, when we have a thickened ventricle walls, we will not be able to distinguish. This thickening of ventricle walls is because of hypertension, aortic stenosis, physiological or infiltrative disease like amyloidosis and so on and so forth. Echo is not able to distinguish, but ECG is able to distinguish whether these thickened ventricle walls are because of infiltrative disease, is it physiological, or it is because of some conditions like hypertension or aortic stenosis. Only on ECG you will be able to tell with a high sensitivity and specificity. Now, another very important concept, AI, ECG and biological age. It has been shown with ECG alone, you are able to diagnose patient gender as well as patient age. And this, they say, is different from your chronological age. The age from your birth date, that we say is a chronological age. So this is a biological age, tissue age. To give you an example, and in fact it has been shown that if the difference between the chronological age and biological age is more than 7 years, then these people have a higher mortality. This has been shown in 2 large trials. Now consider this lady. She had a high BMI of 39. Her weight was 106. 35-year-old lady. Her actual age was 35-year-old, but ECG age, biological age was 40 years. Next 2 years, she lost weight. She lost 10 kg weight. So her BMI came down after 10 years, 10 kg weight loss. Over 2 years, so she went to 37 years age. Now her actual age was 37 and ECG age was 36. So there is no gap. Just see that the tremendous motivation you can give to the patient, lifestyle modification. For us, our eyes, both ECGs are same. The upper ECG shows the biological age as 40 and the lower ECG shows the biological age as 36. So this ECG to our eyes is the same, but AI looks at it differently. Another interesting example, this is a slide given by Dr. Friedman in one of his presentations from Mayo Clinic. Now, on the x-axis is the real age, chronological age. On the y-axis is the biological age. This patient, as the chronological age increased, the biological age increased till the point of 53. And then suddenly the biological age decreased. And the question was asked to the audience, what might have happened? And he got funny answers. Someone said he got married. Someone said he got divorced. But what actually happened, that he got a heart transplant and he got a heart of a younger patient. That's why his biological age decreased. Now, till now, I was talking that this ECG tells you about biological age. After this news report came in, I thought maybe ECG age is different from the mental age. Perhaps it may not go parallel with mental age, because this shows that Mr. Trump is 14 years younger. I doubt when we see his actions. Now, of course, there are challenges and limitations. Most important is the quality of data. The AI all is data. It is both quantitative and qualitative. The quality of data is very important. Now, if you see this ECG, it is not a single ECG. It is an overlap of two ECGs, one in blue and one in pink. The one in blue, when one was given to the AI model, it said this is a male. When one in pink was given, it said it's a female. Just little vibrations are introduced and the diagnosis is totally opposite. So the quality of data also is very important. Now there is no Indian data. This is most of the data is coming from abroad, and most of the data is coming from my clinic. So I decided to venture into AI ECG. I have over 1 lakh patients in my EMR. I have raw digital ECG of more than 2.5 lakhs with their clinical diagnosis echo. Incidentally, also I have a large data of echocardiograms and more than 35,000 angiograms, their CDs and angioplasties. So I decided, why not try something myself? The first thing I did was for diagnosis silent AF, similarly to what the Mayo group has done. My patient subset was different. They had non-valvular AF. I had around 30% of them, they were rheumatic. So I developed a model differently. And this is a paper which I presented in APHRS. Again, can I continue for 2-3 minutes? If you are just overstepping my time, can I continue?
Please, please.
Okay, so this is a paper I presented there. In fact, this came as a full page article also, full paper in this journal. Now, just to give an example, this is my patient who has been on my follow-up for last 15 years. This AI model which I developed, this is sinus, and when I applied that model to this patient, it said this patient has intermittent atrial fibrillation. I was surprised. He never had any symptoms. It's routine ECG I subjected to AI model. It says 76%. I got curious. So I subjected him to 7 days Holter. And this is what? I subjected him to 7 days Holter, and it picked up that one episode of atrial fibrillation. Of course, it was not a persistent AF, not lasting for 24 hours to warrant anticoagulation. But it showed that, yes, perhaps this patient is having intermittent atrial fibrillation. Now, this patient, this is the ECG in July. The AI predicted atrial fibrillation probability as 49%. He came to me with angina, acute coronary syndrome. AI said AF probability is 74%. His troponin was positive. ECGs are both nearly normal. I admitted him, did his angio, he had circumflex lesion, fixed it, did angioplasty. And in December, his AF probability again went down to 53% from 74%. So during acute coronary syndrome, his AF probability had gone up. All ECGs are looking same sinus rhythm, nothing on ECG to human eye. So this is the architecture which I have developed with the help of PhD students from IIT Roorkee. I have applied for patent for this architecture. Now, Mayo Group has developed an AI model for ejection fractions. I thought I'll do AI model for GLS. GLS, as you know, is a more objective marker for left ventricular function. It is operator independent, load independent. So I thought, why not give a try? So this I collaborated with IIT Jaipur And with my ECG data, I developed a model for GLS. Now give an example. This is a patient, post-heart transplant patient. He came to me. His GLS was in May 24, minus 16.7. He came to me with dyspnea 6 months later. He had stopped all medicines. The ECG, except for slight amplitude changes, was same. But my AI model predicted that GLS was minus 6. So his EF had gone down. I was surprised. 6 months, only 6 months. And then I actually measured his ejection fraction. His ejection fraction and GLS, when the predicted was minus 16, the actual GLS was minus 19. When predicted GLS was minus 7, his actual GLS was minus. So the AI model was quite right in predicting this thing. Now, it's another example. This is a patient who came to me in January. This was her ECG, and this was her GLS. This was the GLS. 6 months later, this was the echo. Usually, I labeled her as a dilated cardiomyopathy, explained to her prognosis, started her GDMT. 6 months later, ECG had changed marginally. The T wave inversion was slightly less. But my AI model predicted the GLS had normalized. I was surprised. In 6 months, your GLS cannot normalize. I was surprised. Really, I was surprised. I thought my GLS model is not predicting well. So I did her echo. Normally, I would not have done echo. I did her echo. And in fact, her GLS had normalized. The actual predicted GLS was 18. So this model is performing very well. Now, this is just a recent case. One patient was referred to me by a general practitioner for dyspnea for stress test. Suspecting angina, but a routine 12-lead ECG showed me GLS of minus 9. So I thought I should not do a stress test. GLS was minus 9. I thought I should not do a stress test. Although he was referred for a stress test, I thought I'll do echo. And when I did echo, the actual GLS was minus 4. Good that I did not subject him to stress test. So he had a severe LV dysfunction, normal looking ECG, patient walking, no resting symptoms. And this is how AI could bring out this. So I have formed a registry called as a parallel registry, prospective and retrospective all come registry for ECG algorithm predictive evaluation. I have registered it with CTRI, and I am entering all my algorithms predictions in my EMR, their actual values and predicted values, and have collected data of over 5,000 patients now. And in fact, I published this paper presented recently in ACC, and with further validation of, this was with 1200 patients validation, then with more than 3,000 validation, I am going to present in EPHRS Busan now. And I have GLS, nobody in the world has done so far, so I have filed a patent for it. The other thing is, this is a patent which I already got for this, my ECG. This is my ECG machine which I have. This is a mobile size ECG machine which I have in my hand. This is that ECG machine for home recording of 12-lead ECG in patients of acute coronary syndrome. And this I have got a patent with the help of these people. I have developed this patient, and I am integrating my AI algorithms into this ECG. So when I record the ECG, you will see my AI predictions. What is whether it is normal sinus, what is the AF probability, what is likely to be ejection fraction, and what is likely to be GLS. So I am integrating this into my this model, and which I intend to bring out in the market soon. I have just got the test license. It is undergoing approvals, regulatory approvals now. Now my next project is now biological age prediction, infarction or no infarction for basically periphery, predicting CAD progression from initial coronary angiogram using AI model, and differentiating of true positive from false positive stress tests using AI models. This is, I am a PhD co-guide for one of these projects.
It was really a wonderful presentation, but because of the constraint of time, I would request that.
This is the last slide. Okay. That's all. So this is, I am a PhD guide for this. Thank you.
So So it was really a wonderful presentation, and we know that an image gives us data much more than numerous sentences and words and pages, and that's probably AI is doing. Obviously, it has lot of baseline memory, then it has learned a lot, and it's integrating that. But right now we are in learning phase, probably to translate into the clinical practice. Sooner or later, we will see that we will integrate AI with the ECG machine rather than with the ECG strip also. But how and when it will happen, yeah, it's really a great topic for discussion and learning and investigating.
This should be different talk to all DM students and all doctors. Long back, about 8 years back, starting something A to BA, they said that we have a theory of 40 facts, and we will have a paper in your department, and all things will be collected, and with the immediate diagnosis, so we are not going to run from here and there, lot of. But that was, I think, thinking. China has this ECG data of billions of.
Yes.
You have done a great work, I think. What all should contribute is what you history.
Thank
And that is data of last period, maybe not in.
So, coming to the third presentation by Dr. Anurag Sharma, left main crossover. We'd also request you to let us be in time and on time, so the next presentations can be done. That was an excellent but a bit prolonged presentation.
चल रहा है आवाज आ रही है तो गया आवाज आ रही है So my computer is going to start very slowly because, yeah, now it's.
Sir,
So,
that's
good
a
afternoon,
old
everyone.
excuse for during morning presentations that the CD will not run and the computer won't stop. So we are used to it that also. So thanks for giving the same experience again.
I used to come always 10 minutes late and slowly पीछे जाके बैठ जाता था. So I'm presenting very commonly done stenting which we do, left main crossover, because many times there is a ostial LED and angle is not good, and we know that we have to go from left main to LED. It's very commonly done and usually we do very fast, but I think what's important is that what I saw in many cases from my side and from other cardiologists also, that I'm going to share, that what are we missing and how we can make it better for the patients, because when we do LED, I think we are opting or hoping that we are giving very good results like Lima or somewhere, and patient doesn't have any other illness, other only single vessel disease. So I think it's very, very interesting to see that. Okay. So basically we are doing stent from left main to LED and doing the pot, and now we have a lot of imaging available. So side branch assessment, what should we do? Usually we do maybe angiographically that side branch TIMI flow is very good, and sometimes we means all of us including me, we think that patient will do continuously well, but usually many patients will come back within 1 year, 1.5 years with the ostial circumflex. And how we can prevent it, because that osteal circumflex is really pain in the, you can say anywhere. A patient does not get better and it keeps on complicating. So this is one of the cases done by in the other center, basically, and ostial LED lesion, typical, and then basically stent deployed, and then post dilatation done, and then again pot done. So I was done here, and this is the last shot of that angioplasty, March 2024. So this patient comes in next year, December, and unstable angina. And now you can see it's a dominant circumflex, and you can see that the circumflex ostium, ICG had typical changes of ST depression in V1 to V6, and you can see that now we have to do something. LED is good, and obviously patient is having unstable angina, so you have to tackle this patient. So we did ballooning of this, and it was very tight blockage. So we did a culotte. You have only two choices: either you do culotte or you do tap. But usually I prefer to do culotte in this setting because of the anatomy and better coverage of that circumflex, because we don't want to again have problems and then we again do kissing and then again pot. So basically this patient is doing well. So this is one of the patients where angiographically it was looking that nothing was going to happen. So this is another patient from other center who had this ostial LED, and again the left main crossover stenting was done by the other center. And look at the circumflex. You looked in the last view, it was looking very good. Normal circumflex, very large diameter. And now this was the final, I mean to say, left mento LED last shot you can see. So the patient did well, but after 7 months, patient had again unstable angina, and they reported to us. And the patient, now again you can see the thrombus and unstable angina. So again, we had to do a culotte in here, and again patient became all right. What is the problem is that even if you do, so but that is what I wanted to show you, that this, when we did the intervention of this patient, our IVUS catheter was not going and through these struts. So basically struts are very much, when we do a lot of big pot, the what happens is there is a basically density of that strut is coming there, and you are shifting carina too much. Specifically when after pot we do, then higher the balloon you go and more carina shift you do actually. So that is what now imaging studies have shown. So this is what we did. Patient is doing all right. We could manage this patient. So what is this mechanism of LC exclusion in this setting? Carina shift is very common, and we may not see in the angiography. We just see a nick in the circumflex, and we said TME3 flow, no thrombus, nothing, no dye hanging. So that is, I think, the old thinking. In present era, we must do the imaging of circumflex before and after, even if you are thinking it's a normal, to read about the distal left main plaque burden, because that is going to shift. So there can be carina shift, especially when we post dilate, and especially when the angle is acute, it shifts more. And plaque shift if it is having thrombus, or many times I have done now many around 100 cases like this, and I've seen that if you do study the circumflex beforehand, you come to know that circumflex ostium is having plaque which is not, and calcified also sometimes. So there will be plaque shift and thrombus formation because of lack of laminar flow, platelet aggregation and thrombus formation. So we routinely do the IVUS of the ostium even if it is looking healthy. Other mechanisms are tear at the ostium of LCX, specifically when you do 4.5 and when the left main is 5, or you do with 5. And then that leads to delayed stenosis, sometimes neo-intimal hyperplasia also, and local shear stress because of the some struts are over the circumflex, and chronic carina microdeformation. And stent strut density happens when you, so we also, whenever we want to do, we also look at the ostial of the left. We suppose there is a very long lesion in the LED, we don't cover that stent up to the ostium. Don't try to use single stent, try to use a second 4 millimeter stent which easily comes into the ostium, so that the side, the window of that stent is always larger. So then again chances of that's a more dense area at the circumflex is less. And you must do the imaging before and after, and strut malapposition should be known, and minimal luminary area should be less, if it is less than 4 millimeter at the ostial circumflex, it signifies the late onset or early stenosis of the LCX ostium. So this should be the more important also as far as compared to the LAD and ostium. Usually we see the left main, the distal left main and LAD, but we don't see the circumflex ostium because previously it is normal or it is less than 50%. And if pullback from circumflex ostium shows the area just above the ostial LCX is smaller than the distal reference diameter, then the stent is underexpanded at that area, like at the circumflex area. So you must again do the kissing with the normal or the proper diameters. So use of imaging after the final part is mandatory for left main crossover stenting in the circumflex, and use of imaging of circumflex before the left main crossover is also mandatory. Because what we do is usually we put the wires both, we see the both plaques and we also see the distal left main, and then the strategy is made. Kissing balloon and MLA should be more than 4 millimeter. You may not dilate the circumflex. This was the acute coronary patient, sick patient, and left main and LAD is very bad. IIBP had to be inserted. So we went with this thing and then overlapped with a 3.5 and then we did pot. So I'll just show you what happened. Circumflex was normal in this patient. But after this was a final when we do the pot and everything. So you can still see a very good circumflex. It looks like it is not affected at all. But when we wanted to do the IVUS was not going. So this is where we have to understand that actually what you're seeing is not happening there. So we have now many cases, I can't show all of them here. So we always do, and if this, sometime it goes, the IVUS catheter, but the area is very small. So if the area is small, we don't go 1:1 in the circumflex because we don't want to dissect and we don't want any new stent putting there because basically we want single stent strategy, but we definitely open it properly. 0.5 usually I go down and then do a kissing balloon. Then again we opened, and after that we could do a very good IVUS, and you can see a very good flowing, so that these patients will not come back very early with the ostial circumflex occlusion, because you have at least removed the mechanical burden which you are giving by giving the left main crossover stenting. So that was a message of my today's talk. Thank you so much.
So you very well demonstrated the role IVUS for left main propagation. Yes, it's true that for acute compromise of the ostium of side branch in crossover stenting, we need to know about the distal and proximal main vessel reference diameter, so that we can very well predict that whether there are chances of carina shift or plaque shift. In all of these cases, what we are looking is that after some time we had the progression of disease at the ostium. In second case, in epicaudal view, we can see that radio opaque bar is there halfway, as it was in the last case. So that signifies that significant number of struts are across the ostium of the LCX, and over the time new endothelialization will occur, and then one fine day there will some event where there will be plaque rupture and presentation in the form of MI or unstable angina. So very well taken point. The similar points we have in OCT, where we can see it in 3D reformation. So the carina shift and plaque shifts, these are important for acute result. But for long-term results, we want to see that how many studs are going there. Yes, angiography also gives us a clue. If you think that there are significant studs are there, go for kissing balloon inflation.
Correct. Even if you see small pinching, you should still do open the circumflex. So that my message is that only. And now we have done so many cases, and we do try to cross with the IVUS catheter, but we are not able to. Why? Because its density, the strut density is so much there, and that is going to produce the new onset of circumflex lesion when the patient is absolutely having normal. So you saw the previous all these cases, the ostium was looking very healthy at the beginning, but that's what is happening, that the patients are coming back with that. Otherwise, left main crossover stenting is like very, very proven and the very good way to do these ostial bad angle bifurcation of distal left main.
Should we not do in dominant circumflex whenever it is there, you are doing crossover stenting, you should open the struts in all big LCX.
Correct.
Smaller can be left, but the bigger should be opened.
No, I think just not a problem
Final kissing
point
balloon.
of small or everything. You have to see that area of 4 millimeter has to be there minimum, more than that area. So I think that in today's era when we have imaging and I think IVERS is available everywhere, that I think should be the included. That it should be there because you are looking at area of left main, distal left main, hostel LED 8, then 8.1, 9 point whatever, but you are not looking at the circumflex. So I think this should be the new guidelines because patients are coming back, there's no doubt, because we don't follow them sometimes and they go here and there. Yeah.
So your point is very well taken. As the diameter and perfusion area of the side branch is increasing, probably we need more and we need to be more proactive for opening the stents. As in the definition criteria also, in non-left main 90% stenosis, while in I mean for LCX osteum we are taking 70% stenosis. That fits with the same theory that if larger is the side branch, open the stents.
Correct.
So point very well taken, and now we are moving to the next case by Dr. Rohit. Next talk by Dr. Rohit Manoj Kumar on the left bundle branch pacing, that is physiological pacing.
So, good afternoon. I advocate pace when we do all of us do pacing, and I'm very sure all of you know that all of them don't require a left bundle pacing. But I'm here to share some cases where when you do pacing, we should also know left bundle pacing. So I just run through some cases rather than the lecture to emphasize that when you do pacing, we should also have a concept understanding, and probably we should learn left bundle pacing along with the blood vessel. So here is a 15-year-old girl who had a CHB presented to us, our department, and two standard dual chamber pacemaker are implanted. So we do see occasionally patients of there are various case reports and various experience of different between 20 to 20% of the patient presenting with cardiomyopathy, pacing-induced cardiomyopathy. This is one of the example, unfortunate child who came to us very rapidly within 3 months of pacemaker-induced cardiomyopathy with a rapid deterioration of ejection fraction of them. And this is what her echo came after this one. You can see that she has deteriorated significantly and become symptomatic. So this is her native rhythm was right bundle branch block with a QRS duration of about 160 with escape rhythm of 40 beats per minute. So we couldn't switch off the pacemaker and say, okay, we can switch off the pacemaker and get away with it. We needed a pacemaker for her. So we took her for the left bundle pacing with you can see that her dual chamber pacemaker is still there. And we introduced the Medtronic. In this case, it was used Medtronic lead was implanted, And we were able to achieve good, you can see the RBB morphology coming up in lead V1, and the LVATs, both high and low output were equal, indicating stability of the lead and good thing. Threshold was checked in this, and which was fairly good, and the RV lead was withdrawn after that, and after that we were able to give a good and loop was given. This case was written about 1.5 years back, and this is the post pacemaker ECG. You can see good RSR pattern with a very narrow QRS section. This was done about 1.5 year back, and you can see the gratifying result with this girl, young girl, that she has improved ejection fraction. She is currently only on 2 drugs, AC inhibitors and carvedilol, and her rejections are 50%, and she is doing very well. She I was able to withdraw diuretics and all the other drugs, and she's fairly doing well on that. The second case is a 34-year-old lady who was implanted pacemaker in our institute maybe about 2017. She was diagnosed and she came for PGR, and as a part of routine echo, she was symptomatic, so a part of echo was done, and she has a severe LV dysfunction was there. This is her baseline rhythm. The HV, in initial cases, we use HV catheter for left bundle pacing. Routinely, we currently don't use HV catheter for that. But in her case, this was one of the earlier experience of learning in our left bundle. So HV catheter was used, and which is normal. Temporary pacemaker was just for the HV was there, so we wanted. Again, we achieve a good left bundle pacing within. In here, in her case, we used Abbott left system, and we can see the QRS gratifying and significant markedly improved QRS with RBB morphology. And you can see the old lead, because the old lead was very old, and she didn't have any finances, and we didn't have any, we were not very, we were comfortable leaving the cap, the RB lead, use the RA and a new left bundle, Abbott left bundling, and then again, this patient is doing very well, and she has removed ejection fraction back to normal, and we are still, again, she's only on 2 drugs of AC inhibitors and carvedilol. This also was done about almost about 1 year back. And the third case example, it is worth learning lot CRTD. I continue to implant only CRT as a primary therapy, but there are occasional cases it is worth learning and understanding that lot CRT is a better option than simple CRTD. 15-year-old male presented with the heart block with the low ejection fraction with LVV morphology. We initially implanted the Medtronic left bundle lead with a good parameter, and then we also implanted this one. So you can see native QRS was on 150 millisecond. The only bundle pacing was QRS had come down from 150 to 125 millisecond. So that's fairly good option. But patient anyway had prepared for the CRTD. So we, in addition to left bundle, we also did LV lead placement. Combination of LV with the bundle placing lead resulted in 110 millisecond with excellent. You can see the lead V1 showing very good narrow and RBB morphology. So and parameters are doing well. He is also doing very well. It's not every patient who requires CRTD requires control lot, but then select cases, if feasible, one should attempt lot CRT. Why? We know that only CRT or CRTD has an improvement only in 75% of the cases, while almost 25% of failure is there. If you have an additional left bundle, you are able to convert LBB into RBB, there is a definite data that additional improvement is there in injection fraction. Also, there are data to say that reduced hospitalization is there, and the lot CRT has an above shown compared to CRT, more 10% improvement is there. So there are, it hasn't come into guideline, but there are encouraging data that lot simple CRT should be converted into lot CRT. Is it possible to in all cases? There are 2 cases where you will not be able to convert them into that. One is the septum is thin and very thin, then it's very difficult, or very old cardiomyopathy, fibrosis there, that you are not able to do that. Here is an example where we failed to convert CRT into CRTD. This is a 50-year-old lady, severe LV dysfunction with a dilated heart, very severe, poor ejection fraction. we had a good morphology, good placement of the left bundle lead. Unfortunately, whenever we try to do achieve the good parameter, it is simply would cross over to LV, and we simply wouldn't get a good stability of the lead. So we abandoned this approach to the left bundle and simply went into the CRT. So plain CRT was there, and she did well. Fortunately for her, the CRT did very well, and she is stable. And there has been class symptom has been improved significantly. Is there? Uh, so I just would wish to say that uh, uh, some patient will benefit from CR bundle, and if we have a facility, if we have a technique, we should learn left bundle, and we should use left bundle whenever feasible is there. Thank you.
So, sir, what is your opinion regarding the young girl having CHV at the age of 15 years, some secondary pathologies in this group
No,
of the patients?
Dr. Ashwin, we have worked up for the vasculitis workup. We have worked up for the anti-autobody. They're all negative. She doesn't have anything. Idiopathic. We couldn't find any cause in her. We
Yeah.
have done extensive workup
Yes,
for her.
yes. And second point which I want to know is that previously we did his bundle pacing in an attempt for physiological pacing, but the long-term data was not good. What about the LBV pacing over long time?
Sorry?
His bundle pacing over long term, we didn't have good outcomes. So what about the LBV pacing over long time?
Left bundle pacing. There are encouraging data. There are encouraging data that there are we simply guidelines don't recommend that we should only left bundle pacing for the heart failure. But there are centers who in India who patient cannot afford CRT P. They do only left bundle pacing, and there are encouraging data is there. Sorry, we attempt. It just additional sheath cost is there about 50 to 70,000 rupees. That's all. I think the septum is borderline, and then we prefer to do Medtronic because it's more tested, it's more proven, it has a more data, and then and if the septum is a little bit more thicker, then even the Abbott system works well. We have a both experience that, but I prefer to do a Medtronic system if the septum is slightly borderline case, maybe 9, 10, something like that. If septum is more thicker, then I'm not sure how the Medtronic system will penetrate. So I use Abbott. We can go more deeper into it.
So the problem of sometimes anodal capture is difficult to identify when you go from high to low, whether it's anodal capturing going on or whether it's a selective pacing. Have you found that?
I think annual capture can be tested on table. You can find out whether you have annual capture or not. That I don't. That's remains.
And difficult CSPs where the support is not adequate. What do you do at?
So you are absolutely correct. Then you should be prepared that you will not be able to achieve in 100% of the lab like the normal pacemaker. You will put a pacemaker and come out for no doubt, no concern. In a CSP, you should be prepared that in not every patient will be able to do left bundle pacemaker. Almost about 8 to 10% failure rate will be there.
Thank you, sir. So it was a wonderful session where we started from the ECG to ECO to devices to coronary interventions, and now with this excellent discussion, we'll wind up this session, and I hand over Dr. Ram for the. So now we'll proceed for lunch. Thank you all, sir.
Respected teachers, see, PGI Connect is a very extraordinary event, where the people who have moved from white aprons to white hair and people have moved from freshers to mentors, they connect. A union like this reminds us that cardiology is not a profession, it's a shared journey. So let us laugh out loud about our old days, remember our unforgettable characters who were there during our times at PGI. Let us revisit those corridors and those wards where we shared long duty hours in the humid nights of Chandigarh, and also the classrooms where we came up with very embarrassing answers to very tough questions. A great effort has gone in by the organizers of this event, where they have tried to curate the program as such, where we'll be delving into certain academic programs, academic discussions, and also we'll be able to unwind ourselves through the extracurricular pursuits which will be brought to you by our PGI alumni. I'm sure that this reunion shall be a memorable and a very special experience, and you'll be able to enjoy both the culinary and the cultural delights of Rajasthan. I welcome you all for this special occasion. Thank you. So we go ahead for the lamp lighting. May I now invite Professor Bali, Dr. Amuthan, and Dr. Bhupen Desai to be on the stage to light the lamp. Dr. Shahi is probably out. I mean, he's out of the room. We could have called him, but please come. शाही साहब बोला आ जाएंगे
You have to remove the issues.
Just light the lamp.
Remove the issues.
Yeah, so no, it's okay. आ रहे हैं सर, आ रहे हैं. I think शाही साहब आ रहे हैं. अब शाही आ रहे हैं. People know otherwise they will bold numbers. Just waiting for.
Thank you.
Ram, अश्विनी आपने मैं तो
Do myself.
So post lunch, now we are moving towards our third scientific session, and for this session, I would request Dr. Rohit sir, Dr. Pushpender Gag, and Dr. Sojate sir to come on the dais for moderating the session. Our first talk will be by Dr. Anshul Jain, sir, on the nasty osteal LCX. Over to you, sir.
Thank you, sir, so much. It's a pleasure to be here, and it's like visiting 1996 again. I joined PGI in 1996. Dr. Bali was my guide, and Dr. Kapil Bhargav, Dr. Sudhir Saxena, Dr. Vijay Pathak, and Dr. Yashpal. They were just, Dr. Saxena was already in faculty, and others were just passing out. And Ramesh, he's just left. He was my batchmate. So happy. And Dr. Ratnani, of course, was also passing out that time. So happy to be here. They were very nervous days for us because I was new to concept of PGI and extremely nervous in those days. And lot of support from Dr. Saxena and Dr. Pathak. Surviving Dr. Sapru. So, sir. Yes, sir. So, Dr. Anurag was my JR that time. He's just covered something on circumflex. So I thought I will just show you another case, more for discussion's sake. So this was a 61-year-old gentleman, very active, returned from mountaineering a couple of days back and had profuse sweating and chest pain. Trough was positive. ECG was not very suggestive. Echo showed ejection fraction of 45%. And we did see there was no PFO-ASD or no evidence of DVT. So this was the finding on angiogram, and this was a case done late in evening. So you see pretty much the vessels are pretty much very clean, and there's a thrombus which is abutting the distal circumflex, LAD and circumflex. Distal left main, yes. Otherwise, the vessels were pretty clean. And I was not very sure whether we are dealing with the atherosclerosis or something, some embolic disorder or something. RC was also very clean. So, question here was, what would you do for this patient? With this thought, I thought I would show you this case. This is 2021. Any suggestions? Sorry? Thrombus aspiration, yes. So I did think that this is not atherosclerotic, so I suggested the family that we should do thrombosuction and keep him on heparin and tirofiban and other things. Since he was influential, he took multiple opinions there and then. It's so easy to have opinions nowadays. Just throw a WhatsApp video and opinions come. So the family decided to undergo CABG. So because we told them that there could be distal embolization, which could have its own complications. So they thought CABG is a better option because surgeons, they were very sure they would not have any complications. With this thought, the surgery was undergone. I mean, he underwent surgery and he did very well, discharged. Lost to follow for next 5 years. Just a couple of days back, he came to me. And again, some chest pain. Again, being a VVIP sort of a fellow. Yes, sir.
No imaging was done. Nothing was done.
Sir, this is 2021, no imaging.
Nothing. He went for CABG.
Yes, sir.
Straightforward.
Yes. This is a family. When you have too many connections.
As was intervention cardiologist, I would have walked out of the hospital.
Sir, there's no way you can walk over these people if you have to stay in Delhi. So couple of days back, 1 month back actually, he came to me and he again had chest pain. So I said, let us do echo TMT for you. You look pretty healthy otherwise. Now he's 66. He said, Doctor Sahab, TMT, nahi mera angio kara do. So I got a CT angio done for him. All grafts were occluded and the native coronaries were normal. No. Because I had hectically looked for ASD, PDA, because I was very sure that these clean arteries cannot be from atherosclerosis. But I don't know what is the source of thrombus actually. He was a non-smoker, doesn't have any risk factors. So this was just a case which I thought would be worth sharing and taking opinion.
Why the chest pain, sir? The second time around?
I think it's non-specific. Just thinking too much about everything. He walks, he's a very, active gentleman. So with this, I come to a second case, which is a disaster, which I had to, manage. So I'll show you first part, where the gentleman underwent angioplasty in a different city. I didn't have the angioplasty images from that, intervention, but this was the angiogram in the index case. So you see that the gentleman, he's got a distal left main and a thrombotic LED. Circumflex ostium looks clean. There is a OM1 which has 60-70% disease and a OM2 which is again disease at the ostium. After this procedure, the patient within 3 months came back with chest pain. I'll show you the result because I don't have the CDs for that. So I could have the WhatsApp video of the final result from the previous doctor. So this was the result of the index procedure. I'm sorry about this because these are images which we couldn't get, the proper CDs. So he had implanted a stent from left main to LED, which was 2.75 into 33, and then blown it up to 3.5 probably. The first stent was put in this OM, and the ostium was missed. And after putting a LM to LED stent, he had done a T2 circumflex. So I'll just show a schematic diagram of exactly what was done. So this was done. First stent went into the circumflex, into the OM. The ostium was missed. The second stent went from LM to LED, which was a 2.75, dilated to 3.5. Then the third stent came into the circumflex, which was 2.523, expanded to 2.75. So I didn't really understand because it was little funny to me, but it was done. So this is what the patient came to us with the anastomie after 4 months. So you have a tight ostial circ. This ostium was missed anyways, and this stent also has ISR. LED is reasonably good, some ISR here. The apical views looked okay for the LED. So this was the view which shows the disease clearly. Ostial circumflex, there is a 90% ISR here, and this lesion was missed there. So patient came with anastomie, so I had to do this. So I tried my best to wire into this OM, but the wire could not negotiate there just because of the, I think the way the ISR had occurred. So I did a QLOT, and I did not image because I didn't have anything that time. This is, I think, 3 or 4 years back. So you deployed a stent from LM to circumflex and then just did a kissing balloon in proper fashion, and this was the result. We lost the OM1. So patient did well for 1.5 years or so. This was the final result for the first time. After 1 year, after 8 months, the gentleman again came in with chest pain. Now he continued to smoke. He was a bad diabetic. Now I spoke to surgeons whether they would like to do something, but then remember, we did a FFR on LED, which was fine. OCT was done, which was good. I'll show you the images. So I tried to pass in the OCT catheter, but it would not go. So I did the balloon inflation. Initial balloon was done, and then I did the OCT. Now this is the OCT. So you can see a lot of neointimal proliferation, which is fibrotic, and some calcific spots within the ISR. The stent is underexpanded. You can see 2 layers of stents here. There is some calcium down below. Yeah, you can see some. This is at the distal end of the stent. And just beyond the stent, it was all reasonably healthy. So the mechanism was underexpanded stent and in neointernal hyperplasia, which was calcific and fibrotic in nature. So I did a cutting balloon first. So we did, sorry, this is just this flip side. So this is a cutting balloon, which was 3.5 into 15. And then, 3 or 15 OPN followed by a cutting balloon, because we did the OCT images again and again to guide us. And then this is what we ended up. So we did, this is left main into the circumflex. So you see this, curtain-like thing within the circumflex stent. The LED was pretty good actually. So I tried my best to open this, but this is what, this was the initial distal end. This is the ostial circumflex, and you see this is what we could get maximum after trying our level best. Again, this was the distal stent, we could open up slightly better. But this proliferation, I think, required ELCA, which we did not have. So I think if the initial case is done reasonably, this is the final result for me. But you can see that we had a lot of tissue into the circumflex. The LED was looking very pretty clean. This is the LM, but circumflex, as I showed you earlier, it still has a lot of proliferative tissue. And I'm sure this is about, I think, 1 year now. He is still doing reasonably okay, but he is due for checkup. But this circumflex, if you don't do it well in the first time, it's very non-forgiving. Thank you.
We can have 1 or 2 short questions if possible. Okay, so the second talk is by Dr. UP Singh. Sir, he'll be speaking on diastolic dysfunction. So there is a short announcement that during the tea break, we'll also be having the GB meeting also. So we'll have a simultaneous tea break and the GB meeting as. Okay.
Thank you very much. I think this is one of the very wonderful meetings I've attended, and such a well organized, and this goes a lot for the organizers, those who were able to do it so nicely. I am going to start with something absolutely different than what we've been discussing since morning. And the roadmap is that I would discuss what is the relevance today of doing diastolic functions. As we know that about 50% of the patients of heart failure are diastolic heart failure. So if we are not doing the assessment properly, then maybe we are missing that 50% what we otherwise would have been treating. So these are the recent guidelines 2025, which were actually published. Why should actually we be doing diastolic functions? One is that the dyspnea diagnosis, and let me tell you, there are categories of patients of heart failure with preserved ejection fraction which have normal NT-proBNP, particularly the obese kind of a category of patients. They have a normal NT-proBNP. You would be looking for a BNP for a diagnosis of heart failure, and that also would not come to your rescue. So then you need to prognosticate many, even in reduced ejection fraction, valvular dysfunctions. These days we do diastolic functions in heart failures with preserved ejection fraction. One thing which I want to tell you that diastolic dysfunction is not equal to heart failure. They are two absolutely different things. Diastolic dysfunction, yes, is a component of heart failure with the preserved ejection fraction, but you can have diastolic dysfunction without heart failure, which is clinical syndrome. So that's the problem. You guys are good interventional cardiologists working in a high-end institute. You would have a high-end machine, but you don't have time to do diastolic functions. But those who have plenty of time, they cannot afford a high-end machine. So this is the paradox. So to remove that paradox, I'm going to tell you absolute basic things which we need to make in the assessment. What Dr. Sheriff Nage from Methodist Hospital, who is written the previous guideline 2016 also, and current guideline also is from his group only. They actually conducted a study first on about 950 patients, and they tried to assess those whosoever was referred for a cath lab. They did an echo and they did a cath and they did the LV and diastolic pressures, and they wanted to know what is happening. And based on that, they found that the current guidelines which they suggested after a month later after this study had a very higher accuracy than the previous ones. So these are the parameters we commonly use, and you all must be using those, but these are infrequently used. LA strain, LV inflow velocity propagation. So these are not the things what you are able to. I am able to do diastolic functions and the global longitudinal strain in every patient who is referred to echocardiography. How? Either I'm not very busy or I'm managing time. There are non-productive things in echo lab which you can bypass. What? When the patient is lying down on the machine, you are now entering patient's data. I can bypass that. I have an echo pack where all patient data is entered first. There's no data is entered on the machine. It automatically reflects on the machine. You pick up that patient, what you decided. You do a blood pressure measurement there, that's also fed there. You do a body surface area, that also mentions there. So when one patient walks out of the couch, the other patient comes in, you don't have to punch anything. Few seconds saved. Next, we just scan the patient there. No measurement, no calculation, nothing. We just do a parasternal long axis view, one video, we put it into AI, and it gives you all those diameters and dimensions and RV and LV. And we do an aorta and LA, everything on the single video clip, one clip. We go to measure, when we take an aortic valve, we say measure. You don't have to say that this is at the place of an aortic valve. It automatically know you are at the aortic valve and this is an aortic valve, would put it into your software. When you do an mitral inflow, you just take the inflow, you don't have to tell him anything. Press the measure and it knows that you are at the mitral valve and this is ENA. Same is true for all those dashes. So you save a lot of time which you otherwise would have wasted in doing all those calculations. All those imaging, annotation, printing, everything is done offline. One person is parallelly working offline, one machine. So now you have a capability of acquiring LA into 4-chamber view, 2-chamber view, and then you can take 3 views for apex for the global longitudinal strain. You don't have to do anything. Acquire the image, 2 beats each. That's it. System, now system, the side-by system is exactly like a replica of your echo machine. It'll calculate everything. So that way you don't end up spending extra time for an extra information you are getting. Now LA enteroposterior diameter, most of us are doing. How many of us doing LA volumes? Should I give you an opener? LA volume, there was a study, meta-analysis showed, which are the parameters for mortality on echo. Clinical parameter, 3 vessel, 3 TVD, ejection fraction low, diastolic dysfunction, diabetes, all those parameters. LA's volume was the most important predictor of mortality of future. Odds ratio of 8. Right? So, and we are not measuring LA volumes. So LA volumes can be easily measured on, if you acquire the volumes, and you must remember that when you take an apical 4-chamber view, you're a little off axis. You have to change the axis so that you are in the axis of LA rather than axis of LV. And there are again the softwares available which can actually do LA. TR velocity, another catch most of us what you are doing is once you do not have a good TR velocity, you just kind of make a guess. TR is 2.5, 3, or please, the recommendation is don't do it. And second recommendation is do not measure the beard, measure the chin. Okay, so the median velocity. So I am going to cut short all that and come to the most relevant component, that is how do we make an assessment of, because I understand this is absolutely post-prandial period, and now you have a four-chamber view, and in the four-chamber view, this is the left atrium, and this is what you need to acquire. You need a four-chamber view, and you need a two-chamber view, and once you've done that, the machine would automatically calculate for you the strains and the volumes together. That's a 2D volume. I don't do a 3D volume, it takes a lot of time, but 2D volume is good enough. But you can take 2D volume and strain, and it takes less than 15 seconds to do that. So LA volume is given in almost all patients, and LA volume is represented in meter per square. So we have to write height and weight to take a body surface area. So every patient's height, weight is recorded, put it in the machine, because and this is how it is done. And these are the LA strain values. Less than 18 is considered to be very severe. Let me tell you, we now have an entity what we call as an atrial cardiomyopathy. Yes, we can have an absolute only atrial involvement and without any ventricular involvement for a early cardiomyopathy, and the commonest disease which can do it is amyloidosis. So I have 2 or 3 patients of atrial cardiomyopathy where atrial strain is something like 3 or 4. Atria are hardly contracting. Over a period of time of doing this LA strain for the last about 3-4 years, I can make up, okay, this is LV which is contracting, this is LA which is expanding. If I don't see LA expanding, I know this is the strain is down. It's your visual impression. We are focused visually on the LV. We never look at the LA movement. So if the LA strain was 3 and 4 and other all parameters were normal, you end up with the what we call as atrial cardiomyopathy, and one of the patient had atrial fibrillation recurrent, cath ablation was done, again had a recurrent atrial fibrillation, and one of the markers for recurrent atrial fibrillation is poor LA strain. And this patient has amyloid, which is just come positive. One day before I was coming, I'm going to work up that patient. So amyloidosis is a thing which you should think about. So very easy. I think let me focus on there are few things which you can actually pick up when you're doing a diastolic function, LV inflow, and if in case you have an L wave which is more than 40 millimeter of mercury, centimeter per second velocity, then you can say this is a raised LV and diastolic pressure. B hump is a very old thing which you all used to do when the M mode echocardiography was very, very popular. Okay, so how do you, in your clinical practice, how should you do diastolic function assessment? Step 1, we initially had E and A of mitral inflow. No, that's not a thing which we now do. The recommendation is that we assess E prime. Okay, E prime from what? E prime of septal, lateral, both, and a mean. So E prime, septal less than 7, lateral less than 6, and lateral less than 7, and average less than 6.5, either of them is abnormal. Number 2 is the 3 parameters what we do. We do LE and A ratio, we do LA strain, and then we do the LV volume, and then we do a tricuspid regurgitation. Based on that, we would make an assessment of diastolic function. How? Now, let us see that you have a diastolic function. This is step 1. 3 parameters, E prime. These are the normal values 6, lateral 7, and mean of 6, any one of them present. So let us presume if all are absent. Okay. If all are absent, that means there is absolutely normal, everything is normal LV and diastolic pressure. Now, number 2, if all 3 are present, then it's raised LV, LADP. If any one of second and third is present, or any 2 are present, then we follow something else. Let's presume first thing, do only E, just a reduced E. Just a reduced E, these 2 are absent. You don't have to do anything more than that. If E and A ratio is less than 8, this is normal LAP. So that's done. That means A is more than E, you're out. Nothing. Number 2, if you have reduced only E wave is reduced, and you have E which is more than A, then you do these parameters. If you have any one of these present, this one or this one present, then again you follow and do these parameters: strain, pulmonary venous flow, and left ventricular internal LA volumes. Any 2 present here with 1 or 2 present here would give you an increased LAP. So there are certain other situations where the diastolic functions can be done. Mitral annular calcification, the parameters are very different. I suggest you to go to the guidelines and see. If you have atrial fibrillation, the parameters are very different. We do not follow those things. Hypertrophic cardiomyopathy, the diastolic function assessment is different. Mitral stenosis and regurgitation. This is what again I want to tell you. When you do a diastolic function assessment, this is a recent study which published that in case you do a diastolic dysfunction, you must first do a heart failure score, because accuracy of diastolic function depends upon the heart failure score. Time is too short actually to take you through all that. But heart failure score, if it's low probability, you need not do any diastolic function test. And how do you calculate heart failure score? This is the HFpEF score which you do it. If it is low probability, don't do any diastolic dysfunction. If it is intermediate probability and high probability, then you do a diastolic dysfunction assessment. Thank you very much.
Thank you, Dodo UP Singh, for a wonderful illustration. This is upcoming. We see more and more patients in elderly with unexplained dyspnea, where often patient come with a CT angio or some normal LV dysfunction, and he went to chest vision also, he doesn't find anything. Then we probably need to look into deeper aspect of the more upcoming LV dysfunction. That's a very important topic to understand and read about it. Unfortunately, as you said, the machines are available, patient doesn't have time and all this thing. But yes, we need to understand it.
Yeah, I was very clear that in case you do a proper diastolic assessment, you need a lot of time. So that's why I spend time saying that, and I was left less time for my talk. Right. That's something very important. And secondly, in case you're not sure whether you're not getting diastolic dysfunction and you're still getting patient with the dyspnea, in all those situations, you have to do an exercise diastolic stress test. This is called a diastolic stress test. You make the person run and do, and then all those parameters, because when the diastolic dysfunction starts, patient starts dyspnea on exertion, not at rest. So diastolic dysfunctions manifest on exertion and not at rest. So what you have to do is you have to do a diastolic. Very easy diastolic stress test is you just raise the legs and keep the legs raised for about 15 minutes. You would end up sending about 200 ml of blood into the circulation, and that would actually manifest the diastolic dysfunctions. So that is an easy bedside thing which you can do.
Any quick one or two questions, please? Okay, thank you. And we are in postprandial mode, I think.
Thank you, sir.
Yeah.
See, this is one of the conditions, vascular dysfunction, heart failure, pressure, LV function. This is one of the conditions even today where diagnosed we often miss it out because echocardiographers like him are not easily available. And then this is one situation where we still need hemodynamic cardiac catheterization when in doubt. And we hardly do cardiac catheterization hemodynamic study these days, but this is one of the conditions. Thank you.
Okay, thank you.
Thank you.
So we have next.
So next is Dr. H.K. Wali, sir. He will be talking about transition from PGI to private practice.
Very good afternoon to all of you, and it is an absolute honor and pleasure to be here today. And I'm very happy to see this conference organized meticulously, wonderfully by our young colleagues, headed by Ram, with his team of wonderful colleagues. And I must congratulate Dr. Samit Srivastava for setting up this academic forum for PGI. For years, PGI has led the baton of academic excellence in the country and set the bar for many countries in the world. And we were not able to collectively elevate that at the international level. But I am very happy that this PGI forum here and the discussion which happens in that forum is able to raise the bar and set the bar for others to follow. I'm more happy to see our seniors here. Dr. B.N. Sahi is here, and he was there before I had even joined PGI. And seeing Dr. Somaraju, a doyen of cardiology here, speaks volume what respect all of our seniors give to this forum. I was in PGI from 1982 to 2007. I started my career from PGI. In fact, I was doing internship when I got selected in PGI, became a resident, senior resident, DM resident, and a consultant. And I've seen the growth of cardiology department in these formative years. In fact, I say that I am a destiny's child because when I entered cardiology department, there were very few options available. Coronary care unit, mortality to the tune of 14 to 50%, 15%. Acute myocardial infarction, Lasix, morphine, bed rest, oxygen. And then this thing started happening. We started understanding more about diseases. In 1988, when I was passing my DM, we have the ISIS-2 trial showing thrombotic treatment has a lot to offer to these patients. And then came acute coronary, understanding of acute coronary syndrome and primary angioplasty. And since that time, interventional cardiology has not looked back. So, in a way, I have seen the growth of interventional cardiology. Am I the right person to comment on academic career in PGI and corporate world? I would say yes and no. I would say no because I was a reluctant entrant to corporate sector. In fact, I had not thought about it. I had not imagined it. I did not know how the corporate world would be. It was like a non-swimmer entering a sea or an ocean. And I needed to first float and then start learning swimming. So I don't know whether I'm the right person, but I am the right person because again, I've seen the corporate world grow. from 2 to 3 large corporate centers. Now, corporates have engulfed, I'm using the word engulfed specifically because the entire cardiology world, if not the entire medical world, has been taken over by the corporate world. So the first questions first. Should one leave PGI and enter the corporate world? I think it is no more in our hands. PGI is one of the many public sector institutes, prime institute, the flag bearer of public sector institute. But there are hundreds of other public sector institutes. And corporate world also, there's a variety of organizations from single operators, single owner centers to multiple centers. So what do we see? Because PGI cannot offer job to all of us. So there is very small minuscule of cardiologists who would get a faculty position in PGI. A large majority of people would have to go back to either the state service or to the corporate world. So I'm using PGI as a synonymous with public sector, and then we say whether one should be staying in public sector or going into corporate sector, and if deciding to go into corporate sector, how can we plan to go into corporate sector? The next 10 minutes I will take to only give my perspective. This may not be tubular vision, but this is not the holistic vision also, because there are multiple other views also to look at. First and foremost, if you have decided that you want to go to corporate sector, the breakup must be complete. The umbilical cord must be completely disrupted. Why that is important? When I started my corporate world journey, the initial about 2 years, I was wondering, should I go back to the public sector because corporate doesn't belong to me, or I don't belong to corporate world. So that was the time when I was reminded of a very famous story of a Punjab Chief Minister, Pratap Singh Karu. Once Pratap Singh Karu was going along with his then Home Minister, Darbara Singh, on a rural side in his white ambassador car. And a rabbit came in the way, and the rabbit died because it met with an accident in the car. The rabbit was struck and the rabbit died. And Pratap Singh Karanji asked Darbara Singh, why did the rabbit die? And he offered all the aspects. The driver was careless, he didn't know how to drive, the rabbit may be sick or something like that, it may have suddenly come out, and all sorts of reasons he gave. But Pratap Singh Karanji said, he died because he did not know whether to cross or not to cross. If he had decided not to cross, he would have survived. If he had decided to cross, he would have survived too. But because he was indecisive, so he was neither here nor there and dead as a block. So that is the first foremost principle. That is true internationally also. When Montgomery was attacking Burma and they landed at the coast of Burma, the first thing he did was he burnt all the boats which had come to drop them, so that the soldiers had nothing to go back. So that is important. Once you know and define your career very clearly and focus at hand, that is 50% of your battle is done. As Amitabh Bachchan would say, "Ab hum aa gaye hain." Now it is for the world to see how to respond. So give your full 100% commitment to any job which you take up in life. And professional journey is one of them. So this is an interesting, a photo which is very close to my heart. And I see many of the stalwarts sitting in the audience today. This is at the time when our respected Professor Bidwai was retiring. It's retirement party of Dr. Bidwai. We see our teachers, Dr. Sapru, Dr. Bidwai, Dr. Khatri, Dr. Jagmohan. On the left corners, we see Y.C. Chandrasekhar, Anil Grover, and then we see Miraji Rao. I thought Miraji Rao would be here. He's here. Miraji, you recognize yourself? Then we have a very good batch of Bhupen Desai. You are here? Dr. U.P. Singh, we just heard his talk. Dr. Amuthan, you recognize yourself? Dr. Parley. Dr. Parley, Amuthan, these are our senior technician, Kol Saab, Charan Singh ji, Sharma ji, J.K. Sharma ji, U.P. Singh, Bhupen. And then I was wondering if I apply the AI which Dr. Parley was talking about, to this photo, would we be able to predict that what Amuthan and U.P. Singh will go on to become and what Parley ji will go on to become? But this is a photo which is very close to my heart. न था कुछ तो खुदा था, न होता कुछ तो खुदा होता, डुबोया मुझको होने ने, ना होता मैं तो क्या होता. This is the dilemma of an interventional cardiologist. If you are in the cath lab, the problems are because you are there. You are at the site where you can actually make a difference to a life of a patient. So अगर तुम ना होते तो कुछ ना होता. So इसलिए it is important to understand that how we carry ourselves further, because we can make a difference to the life of people. Now let's talk about PGI. What are the ethos of PGI? We have enormous clinical volume, uncompromising clinical volume, holds true for most public sectors. We have most patients who are referred from outside. In fact, when I was doing my residency, they used to say that all patients are referred to PGI, and the only place where we can refer the patient is to the 6th floor. So therefore, that is the term where we look for tertiary care patients. And it is a research-driven autonomy. So these are the 3 pillars of PGI. And we need to remember them, because that's what we don't find in the corporate world. So if we compare public sector, PGI, and a corporate private sector, high academic research output, very volume of patient volume, tertiary care. In the corporate sector, in a tertiary care corporate sector, it's a premium patient experience. Patient experience is premium. Operational speed and efficiency. We'll talk about it a little bit. Patient-centric clinical output. Not research, not academics, not discussion. Patient-centric clinical outcome. Resource flow. When I was in PGI, I was made in charge of ECG lab. And in those days, we had 2 BPL ECG machines. And I thought we should use computerization of the lab. So I made a proposal that let's have 18 machines which have a central hub and then go about acquiring the data of everybody, because the digital world had started. So I gave a proposal to the PGI administration through my head of the department. I did not get an answer for 6 months. After 6 months, the FA called me, why do you need 18 machines when 2 are good enough? I said, I am okay. In 6 months, I have learned enough. Please give me 2 machines, only BPL. At least we have to do emergency ECGs. I was called by the director. The whole world is progressing. Why do you need 2 BPL machines? So I said, I can't go anywhere. And this is only the prototype of what happens in public sector. It is an elephant. It moves slowly, but moves definitely. So you get a cath lab, you get a CT scan MRI, it will be state of art, ahead of anywhere else. Every package included. But then for 10 years, you won't get anything. So where we start initially at the beginning, at the forefront, we fall back. So things don't get changed, it doesn't evolve. So it is a system constrained infrastructure. Resources are few to come back and they are limited because they're dealing with high load, there are procurement delays. I'll just give you another one example. 1986, we were getting a color Doppler for the first time. So PGI, along with All India Institute and Sanjay Gandhi Institute, ordered an ATL 6 machine. So all of three are ordered, and the machine was supposed to come. This machine came, and they said the color Doppler will be added in 3-4 months' time. In 3-4 months' time, they said we can't order color Doppler in this ATL 6 machine. What we will do is, we'll take up back ATL 6 machine, and we will give you ATL 8 machine, which has a color Doppler. They made this offer to all the three institutes, PGI, All India Institute, and Sanjay Gandhi. All India Institute and Sanjay Gandhi accepted the proposal, got an ATL 8 machine. PGI procurement had said, you can give us an ATL 8, but you can't take ATL 6 out of the building. For the next 5 years, we did not have a color Doppler. So that is what happens in PGI. Similarly, you look at cath lab or wherever, the procurement is a huge, huge bottleneck. In the corporate sector, you have no such constraint. If you are able to justify the utility of an equipment, you will get it in the shortest possible time. So no constraint, rapid hardware and device access is available. Decision dynamics. In PGI, there's a head of the unit, head of the department, institute head, a huge hierarchy. Hierarchy is great, but for patient care, academic, procurement, it's a long process. In corporate sector, there is no hierarchy. You have to justify a particular thing and acquire that. So decision making is much faster. Patient relationship. Why do patients come to PGI? They don't come because Dr. Bali is here or Dr. Yashpal is there or Dr. Rajiv Bagrata is there. They come because of reputation of the institute, which has been built over by years. So the entry of the patient is not a problem. They are going to come, irrespective, kal tha main jahan koi aur hoga. So therefore, they will keep on coming. But in a corporate sector, they come because of an individual. They come because of a person. They don't come for a reputation of Care Hospital. They come by the reputation of Dr. Somaraju. So therefore, it's important to understand that we don't have the reputation of the institute in the corporate sector. So I was in Colombo on a sabbatical, and first day I did the first carotid angioplasty there, put in the first ICD there, did the aortoiliac angioplasty stenting there, and then a patient came who required a pacemaker. Simple, straightforward bypass pacemaker, dual chamber pacemaker. And I had left doing pacemaker during PGI because I thought it was the job of the senior resident. There was nothing academically challenging in putting a pacemaker. So most of my senior resident would do the pacemaker. So here in Colombo Apollo Hospital, I was called on to do the pacemaker. I did the puncture, I made a pocket, put in a pacemaker, and when time came to close it, I said, give me the subcuticle suture. And the sister looked at me. I said, give me the subcuticle suture. He said, which one? 40, 50. So I didn't know. Because for 15, 20 years, I had not done a pacemaker. Even if I was doing it, my resident would be doing it. So it struck me like lightning. that in corporate world, I am all alone, on my own. There is no safety net whatsoever. My younger colleagues are not there. My most brilliant senior resident, DM residents are not there. So therefore, I have to take responsibility at each step, right from entering the patient, admitting the patient, to the time the patient is discharged. Single point responsibility. So safety net is no more there in the corporate world. Personal brand building. As I said, PGI and public sectors have their own brand value and an institute value. In the corporate world, we have to do a personal brand building. You depend on the marketing. First of all, I don't approve of the word of marketing as a component of such a pious profession as health, but then that has become part of life. If you depend on marketing, marketing will get patients for the organization, institute. But you need to develop your personal branding and personal reputation so that patients come because of you. So there's a huge difference between these two. Today's corporate want doctors to become cheap labor. So if A doctor is not there, B can compensate. If B is growing too big, C can come in. If C also start doing very good work, then a number of 2 other consultants can come on. So slowly and steadily, whereas we feel that AI is crowding us out, I feel corporates are crowding out doctors and making them irrelevant. We need to have a personal brand building. So irrespective of the fact you are in corporate A or corporate B, you have your own branding, personal reputation in the organization which gets the patient. The other thing which I learned is, in PGI, I would advise people to get admitted, get an angiography done and intervention done. 30 seconds stuck. In corporate world, your communication is the most important thing which will get you patient, make the patient stay with you, and then have very little problems as far as medical legal is concerned. So communication becomes very important. So I'll just take 2-3 minutes more. So what I would suggest to you is your survival, success will depend in the corporate world on your academic integrity, which is your primary asset. Whatever the pressures may be, there would be multiple pressures, financial pressures, peer pressures, industry pressure, and you don't lose your focus of academic integrity. If you do a quality ethical work, guideline directed medical practice, don't lose the focus. You will have a long-term successful career in corporate world. That's the first thing you need to. Your work, clinical work, must always be ethical and academically oriented. Number 2, patients come to you because of referral by other doctors. So you need to have a transparent referral doctor interaction, not on financial basis. That is a short-term gain. But if you develop a long-term relation with doctors, explain to them how their patients have been taken care of and return patients to them, you build up a very good referring doctor base which will stay with you for a long-term time. And they will also bail you out if you ever land in trouble. This ethical practice is also your sheer shield going forward. In PGI or other academic institutes, you have colleagues, younger doctors, residents, which are your team. You hardly pay attention to your technician and nurses. In the corporate world, 95% of your work is done with a technician or a nurses. So you need to invest in building a relationship with a technician and your team. So team building is extremely important. So integrity versus as brand, high touch communication, and cath lab teamwork. I was giving a lecture in Patiala to doctors, and somebody raised serious question that there is ethical practices problems in medical profession these days, and procedures are done and not indicated. All of you have faced them. So I was reminded of Rahit Andori, and I want you to remember that. आहिस्ता आहिस्ता मेरे अंदर से सब कुछ हो गया खत्म. आहिस्ता आहिस्ता मेरे अंदर से सब कुछ हो गया रुखसत, एक चीज बच गई है जिसे ईमान कहते हैं. So in corporate world, whatever the pressures, don't let your iman dagmagao. So because the time is short, what I would say is that because of my experience, what I would like to say is that there are some pearls which I'd like to give at the how to succeed in corporate after having decided to go to the corporate world. Integrity. Second pearl, high touch communication, both verbal and written. Spend time with patients. Explain everything, even the simplest of procedure. Build a cath lab team. Respect referring doctors. Meticulous documentation of everything you do. The procedure, why a particular procedure was done, how it was done, and what is the outcome expected. You must be governing that system. Don't leave it to anybody else. Whatever may be the pressure of recent advances in different techniques, explain to the patient how does an OCT, an IFR, or whatever procedure you want to do is going to benefit him in the long run. Business acumen is important. Corporates look at your EBITDA. They look at your ALOS, average length of stay. They look at RPOB, what is the average revenue per occupied bed. So we need to understand that. And they look at the cost of the consumables. So this is bare minimum we need to understand so that you are at the same page as the corporate. Full ownership of preparedness, direct responsibility. Responsibility is yours. Bring academic discipline. Hold conferences. Write papers. Present paper in peer-reviewed conferences. That is what will build your reputation on the long term. And protect your personal longevity. Have a very good professional personal equation. Take care of your health. Avoid burnouts. Cardiology is great, but cardiology is not life. We see so many young doctors in the corporate world losing out. So if you want to live longer, live quality of life, and do service to humanity, take care of your health first. So I would say it is possible. There are two terrains, corporate world and private world, public sector, but they can meet. They can meet somewhere if you can have the academic ethics of PGI and the professional efficiency of the corporate world. That is where we should be heading out. नई सुबह पर नजर है मगर आह ये भी डर है वो शहर भी रफ्ता रफ्ता कहीं शाम तक न पहुंचे. I am hopeful, but don't expect too much. All of you must take care of these factors for a long-term, professionally satisfying corporate world journey. Thank you. Thank you very much. If there's any query, I would be very happy to answer. But that was my thoughts, not the ultimate truth.
Thank you, sir. It was a nice presentation and eye-opener for all of Sir, request actually that was here. So that was when in the translated we started at 100 Excel in class 2.
I would like to have a word from him as well.
Nice presentation, sir. You brought out the issues related to practicing in institutions like PGI versus private practice today. So then, one thing I wanted to tell you, that Meraji Rao joined Nizam's Institute of Medical Sciences after I left. A pacemaker. We didn't have that even in private sector, in care hospitals that time. We always worked as a team. Our team was one of the largest in the country that time. We used to be around 25 cardiologists. So, but the team, we used to have significant respect for each other, and we took help. Even echocardiographer in the team, an expert echocardiographer in the team, is paid equally well as an interventional cardiologist. So that's how we practiced it. And having said that, I'll take it further. You brought out the problems related to corporate sector and advantages of private sector, but also problems related to private sector you didn't highlight. The issue is it has become so much commercialized and so many unnecessary procedures are done. Not some of you, but if you look at almost 40% of bypass surgeries and angioplasties were unnecessarily done in private sector. It's happening. It is commercially oriented, investor oriented, and you have targets to fulfill every end of the month. So in other words, we people like us, one of the things I may point out later when we talk is, let us see whether all of you sitting here from PGI, we are different from others. All of us agree, no? That PGI gene continues in us. So having said that, let us establish a model of doctors without hospital borders, between private and public, between in private across the public. We'll highlight that issue some other time, and let us establish a model of doctors without hospital borders and doctors without regional, even state borders. It can be physical, like for example, somebody as good as you can do a procedure in your hospital plus some other hospital doesn't have it, private or even public. People like you should continue to teach and mentor even residents in PGI. So that borders we have to break now. Let us see how it can be done. Thank you.
Chairman. Suppose if you are given a choice, including you have a second birth, and you are given a choice of permanently working at PGI or in a private sector, corporate sector. Which one do you choose? Those who want to become a permanent faculty at PGI, please raise your hand. That he given the choice that there is money is not the parameter. Well, 70 to 80%.
Can I say?
Please, sir.
And then money is extremely important. I won't say adequate money is fundamental. It's something like not to have adequate money. I'll equate this issue something like money is like glucose in the body, but excess of it is not good also. But you should not be hypoglycemic. So in other words, you should create a models where models where, like for example, I'll put it. I'll add something more. People like you, Ramesh is also here, and we should create a models of redefining retirement. Namely, beyond a point of time, we continue to teach, mentor, and create role models across the organizations, both private and public. And don't retire until what time? Until you die. Thank you.
A warm good afternoon to all. First of all, salutations to my teachers who made me what I am. Salutations to all the doyens in cardiology who are here. Greetings to my seniors who taught me all the basics of cardiology, my batchmates who really gave me the most memorable experiences that I carry forth in my medical career. And this is actually one of the happiest times we spent during all our cardiology meets. So happy coming back to among you all. And the next 15 minutes or so, I'll be talking about an area which is close to my heart, that is leadless pacing. So this picture put forth what leadless pacing has made a paradigm shift in the management of bradyarrhythmia. The first picture is of the person who received the first pacemaker. This is how cumbersome his life was. He got this pacemaker in 1958. Annie Larson. This was his life. He had all these hardy equipments wired to him with a nurse moving around. This was how cumbersome his life was, but he survived with this device, which lasted, the first device lasted for about 2 hours, the second device lasted for about 3 days. From 1958, he survived on till 2001, surviving about 26 battery changes, even outliving the surgeon who implanted the pacemaker, the scientist who invented the pacemaker. He survived more than the people who actually made him survive, and then went on. But now at this point of time, nobody wants this cumbersome life. This is what we conventionally put, a dual chamber pacemaker with the conventional transvenous pacemaker. And leadless has been the paradigm shift in the management of bradyarrhythmia, where everything is miniaturized to the size of a vitamin capsule. So I'll put forth, starting with the case scenario. A 72-year-old diabetic, recent NSTEMI, gets a stent from LM to LAD for the non-ST elevation MI. 2 weeks later, comes back with unexplained syncope. ECG shows complete heart block, unstable escape rhythm, patent stents. So this guy with an LMCA stent, 72-year-old diabetic, has a need for a permanent pacing. With dual antiplatelets already on board, he would require a traditional transvenous. If you go with a traditional transvenous pacemaker, there's always a risk of pocket hematoma, and you would want to avoid that. So in this kind of scenario is where you really think of leadless pacing. So lead-related complications happen in about 5.5%, pocket-related complications happen about 4.7%, and at this point of time, nobody wants a chest wall scar, visible bump on the anterior chest wall. Everybody wants fewer post-implant active restrictions. So leadless pacing is the way forward, because studies have shown that it leads to almost a 56% reduction in complications. And this has been the evolution. So from this bigger device in 1958, now it has almost miniaturized to the size of just a 1.1 cc device, 2-gram device, which can be put in and can pace for almost about 15 to 20 years. The first generation device, which came in from Medtronic, gives you only pacing, a single chamber pacing. So it was only indicated in patients who had need for pacing in the presence of permanent AFib and who had high grade AV block. Micra AV came in next. It could give you a VDD pacing, but again could maintain AV synchrony in only about 70% of cases. Abbott came in later on with AVIR, the mnemonic AVIR stands for A, stands for the capability to pace and sense the atrium, B stands for the capability to pace and sense the ventricle, E stands for the extended longevity it has, I stands for the implant-to-implant communication, and R stands for the capability of retrieval. So this is the device that I'm talking about. This is the device which is almost the size of a AAA battery, 38 mm in length. There's a dedicated catheter and there's a link module for programming it. It actually is an active fixation device. So it's a screw there, and this is the pacing electrode which is away from the screw. So it has thresholds which are supernormal or very low, and it has a retrieval feature which gives you the capability of retrieving this any point of time in future. They also came in with the first atrial-based leadless device, which was never there in the before generation. It is slightly smaller in length, but it has dual helix. It has one more screw inside. So there's 2 screws, which allows you to give a very stable atrial-based pacing as well. And all of this is done with one single venous puncture. You have a 25 front sheath which goes in, and it is through this that this delivery system is taken in. And this delivery system, compared to the Micra or the Medtronic device that it has a protective sleeve. So it makes transition between chambers very safe, reduces risk of pericardial effusion, and it makes procedure very almost quite safe and lesser chance of having a pericardial effusion. The beauty of this is almost akin to your transvenous spacing. So here, like unlike Micra where you put the device and check and see whether it's all good or not, here there's no trial and error. You would actually have the electrical parameters mapped. It's like exactly like a conventional pacing lead. You would map the site. If you find that the site is good, you would fixate it there. And all the fixation is based on electrophysiologic principles. You look at the electrogram, how healthy the electrogram is, how good is the current of injury, which indicates whether your screwing is done properly or not. And the beauty of this device is the R, the end of it, it stands for retrievability. So at the end of life of this device, you did not dump it inside the heart, you can retrieve it. There's a dedicated snare for retrieval of it, and you can retrieve a device even as long as 9 years. So the retrieval success rate is phenomenal. Studies have shown a retrieval success rate of 92%, and devices as long as 9 years have been safely retrieved. You also have capability of upgradability. It's MRI compatible as with any of the pacemakers now. You can upgrade it. So when you say that it has an dual chamber expandability, what I mean is, suppose a person at this point of time has 6 sinus syndrome. He has good AV conduction. You just need to put an atrial based device alone. And at future point of time, AV block would happen in only about 1% of cases in this follow-up. In that time, if you develop an AV block, you can always put in another device later on with one more venous puncture, and you can program it a dual chamber pacer. A person has intermittent AV block, you can just put in a ventricular device alone to start off with and upgrade to a dual chamber any point of time. It just requires one more venous puncture, and so you have a pacing capability which caters to the patient's need. Longevity is another highlight because the battery longevity of this device is somewhere like 70 to 25 years for ventricular device, 10 to 15 years for atrial device. So if you look at the elderly patient, this is almost one device a lifetime for most of the elderly patients. And these are not what studies say, this is what we also see. You see the longevity is 23 years, 20 years, more than 25 years, 22 years. So these are the battery longevities of this device, which is never seen with traditional transvenous devices. These are dual chamber longevities, also quite good. Once you have dual chamber, slightly the battery comes down, but it still has good longevity. It also has rate responsive function with any of the traditional pacemakers. So this gives good amount of AV synchrony. It gives you the capability of upgradability. It gives you the capability of retrievability. So now with all these features, now I would say that you can actually in fact offer leadless pacing, not only for those niche kind of patients who have permanent AFib but AV block, you can actually offer it for any kind of patients. In our journey, we start off with these kind of scenarios. An infected pacemaker. This happens as you do generator changes. By second or third generator changes, a lot of patients get infection. So we used to do it for those kind of patients who had Tudler syndrome, who would come with these kind of devices out. Elderly patients who would have eroded devices. Patients who had endocarditis. So you can see this is the vegetations on the lead. So these are the culprit is always the lead. You take the lead out and put a leadless system. Some of times it's actually a thrombus on the lead, and if this person has a PFO, this is actually a time bomb sitting for the patient. So once the thrombus goes into the cerebral circulation, it's a massive stroke. Leads also have fractures, insulation breaches. Sometimes you have venous access issues like this kind of scenario. You can have central venous occlusions. You can do an angioplasty and put in lead, but at this point of time, the best is to offer a leadless base system. CKD patients, cancer patients have long-term ports, chemotherapeutic ports. You don't want to damage the central venous axis. You can put a leadless system. A person who has a severe pre-existing tricuspid leak, you don't want to put a lead across these kind of scenarios. You would actually offer them a leadless base system. So now, moving on from complications to transvenous system, patients who have higher risk of infections, patients who have vascular issues, we now are even offering them for younger patients because you want to preserve the central venous axis, you want to preserve the tricuspid valve, and it's very cosmetically appealing as well. The beauty of this is the communication. So when you put two devices, so you have two devices, one in the atrium and one in ventricle, the way it communicates is actually it sends subthreshold impulses. And this is actually the study data from the evidence. It says a 98% success rate, very stable electrical parameters on follow-up. You can see the electrical parameters are quite stable on follow-up. How it communicates is just like as like your FM radio. It sends some impulses from the first device to second device to the blood pool. The second device gets this information and then again communicates back to the device. So it is just some impulses sent through the blood pool, and the communication is phenomenal because the success rate of communication is almost 99%, and it maintains AV synchrony in almost 95% of cases. So which is very phenomenally high compared to the Micra AV that we have. The adverse events is again a concern, but the adverse events in the data as well as what we see in literature is less than 1%. Serious adverse events, most of them are vascular issues. And it does not look a lot of learning curve. What study says after 9 procedures, your implant time comes less than 1 hour, your fluoroscopic duration comes less than 15 minutes, and your complication rate free procedure is almost 98%. So coming back to our first patient, which I alluded to, we took him to the lab. So this is setup which we put. We have 5 electrodes placed in. The RV device is typically placed in the RV apical septum. And the RA device is typically placed in the base of RA appendage. You never go deep in the appendage, because when you go deep in the appendage, your chance of perforation is high, your implant to implant distance is higher, your communication becomes difficult. So you don't go on the septum, you typically go at the base of appendage. So this is typically how the procedure is done. Just a single venous access. You would actually have this 25 front sheath taken in. We do an RV angiogram to understand which is the target site. So this is the apical septum that we try to target. So the apical septum in the RA and LAO view, this is the RA appendage appendogram. The base of the RA appendage is where we typically try to target this. So this is the 25 front sheath taken over the standard ultrasound guided venous access, and then you take it over suprastiff wire. This device, you need to load it on your delivery system. So this is a device which comes with, this is how we load it. And once you load it, you actually cover with the protective sleeve. The device is covered with the protective sleeve, and you would actually take it inside. So this is actually how the device is taken in through the protective sleeve into the system. So you have the animation on one side, you have fluoroscopically what happens in real life on the other side. So this is the protective sleeve. This is in the IVC, you would expose the device for the first time, and you would get some basal measurements, like the basal impedance of the blood pool impedance. You would activate this device in the IVC as well. And once that is done, you would actually have the device covered up. So at no point of time the screw is left exposed. You would cover the device and you would take it inside from the right atrium to right ventricle. There's a deflection button there, which allows you to go from the right atrium to right ventricle. Inside the right ventricle, we would give some shoots of contrast to see whether we are the apical septum or not. These are the these are the RV angiograms through the protective sleeve. And once you find that you're on a good site, you would actually expose the device here. So we would pull back the protective sleeve and expose the device. So this is the device getting exposed. You would ensure that the device is stable there, the deflection buttons are released, and you have a screw there. So here you have a chevron marker. The chevron marker tells you how much rotations you can go. So typically we would fixate it at about 1.5 rotations. So that's how we would typically fix this device. And this is the electrograms that we see throughout the device implant. We also look at the impedance as well as the electrograms. So as we are successfully implanting it, the ST elevation goes up on the electrogram, the impedance goes up, which indicates that your device is getting screwed in. It's about 1.5 rotations that is required for this successful implant. And once you're done with that, you would actually go on what is called the tether mode. So here we are going on the thread-based mode again. And here we would actually check for the stability of the device. So what we would do is we would deflect the proximal end of the device and see whether the tip or the screw is stable or not. And then if the electrical parameters are also good, you would actually have this device released actually. So once the electrical parameters are good, you would release the device. And then subsequently you would actually go on the atrial device, so the same delivery system itself. So you have the same delivery system taking in the atrial device as well. So he would take it to the base of appendage. So here you would expose it, get an angiogram done to see whether you're at the base of the appendage, and then you would fixate it again with 1.5 rotations, and then would go on the tether mode, look at the electrograms, how healthy it is. It's mainly based on the electrogram as well as the impedance. And once it is there, to check for the anatomical stability in the RA appendage, you would actually do what is called a tuck test. You would pull the device and see whether it's anatomically stable or not. And once it is stable, you see this is the injury current that is there, you would release the device. So in fact, this was the first dual chamber leadless pacemaker done in the whole of the country. And this patient recovered well. You can see the AV synchrony is quite good. You see a DDDR pacing with the leadless, which was happening first time in the country after that. And we also have, you can program the devices separately. Sometimes you have patients who have CKD, you want to limit the contrast. We use intracardiac echo in these kind of scenarios. I wouldn't go into the case, but this is an intracardiac echo which shows the RA appendage. And this was a patient who had pure six sinus syndrome. You can see 82-year-old pure six sinus syndrome, good AV, he had a requirement for a single dual chamber device. And again, we would actually implant it entirely with intracardiac echo guidance. So this is again an intracardiac echo guidance guided implant. And these are the parameters. Sometimes you also have difficulty entering from RV to RV because of a very hostile anatomy. Sometimes you would find that this is the anatomy. So it's a very vertical heart. You find it difficult to enter from the RA to RV. So in that kind of scenario, we use actually a combination of what is an agilis and snare. So whatever you do, actually it wouldn't work. We use actually innovative stuff. What we do is we actually try to hold this tip of the device with the agilis and actually have a snare at the tip of the device and then pull it along with the agilis and snare and pull it to the RV and then do a conventional implant. So even in hostile anatomies, we have innovations which I've worked in. We have done it in difficult scenarios. This is a post-MVR who required a dual chamber pacemaker. We didn't want to interrupt anticoagulants. This is a person who had 4 failed leads. We were able to get this leadless device through this all 4 failed leads. This is a young lady, post ICR for TOF, who had a pulmonary valve percutaneous pulmonary valve implant, a failed transvenous lead. We were able to do a dual chamber leadless. This is actually a tri-clip. So this was actually a tricuspid clip put for a failed tricuspid RV. Again, this was never experimented earlier. So this was actually, in fact, the first implant in the Asia Pacific region. So we were able to go in between the clips with this device and implant it. So till now, my personal experience has been close to 140 devices in about 114 implants. So majority have been ventricular implants. About 25 have been dual chamber implants. Most of them we have implanted for failed transvenous systems or patient preference. Average procedure time you can see is about 30 minutes. Very stable thresholds. Longevities are phenomenal. We had only one major, during procedure, only one TPA-induced pericardial effusion that we had. We have done sometimes even through the IG axis. We had one mortality which happened later on because of VT in an elderly person, and then he had DC cardiovertigo and aspiration sepsis. But although I've done about 140 of these devices, the life came a full moment to me when Manoj sir actually invited me for being the first for dual chamber implant in my own alma mater, and I would thank Manoj sir and Ankur for this opportunity for being part of this procedure. And it was a failed transvenous implant, and we were able to do a dual chamber implant. And my colleagues have also visited me. Pavan visited us to see how our system works. In future, we will have wireless CRT as well. We will have leadless CSP coming in. But till that point of time, I would conclude that leadless pacing has really revolutionized care by redefining patient experience, leaving no physical reminders, eliminating pocket or lead-related complications. The current leadless system is really unique because you have dual chamber upgradability. So suppose a person has 6 sinus syndrome, we only implant an atrial device. Suppose a person has very paroxysmal AV block, we only implant a ventricular device. We can upgrade to a dual chamber system any point of time. The longevities of 15 years to 25 years is phenomenal because in elderly, it's clearly one device a lifetime for the person. Retrievability is also a promise because you don't have to leave anything gadgets behind. At 9 years or 10 years, you can retrieve the device and put a new device. Ability to map, having an active fixation helix, having a protective sleeve, ability to look at electrograms while the deployment is done. It's actually it is a boon for implanter because you are doing nothing in a trial and error. You are really mapping and understanding what is going on, and then you would fixate it. In fact, this is the first dual chamber leadless based system. And once we have these two distinct devices, so the way with leadless CSP probably coming in next couple of years and leadless CRT also coming in couple of years, once we have these two devices which are placed, one in the atrium and one in the ventricle, we would actually gradually be looking at a point in future we would actually be abandoning lead-based therapy altogether. Once it really becomes affordable with these two distinct devices, one in the atrium, one in the ventricle, and probably for leadless CRT, one in the LV as well, we would have devices which is just the size of a AAA battery or a vitamin capsule implanted inside the chambers by single venous punctures with about a 30 to 40 minutes procedure, patient going home next day, longevities of more than 10 to 15 years, we would probably translate into an era where we have MRI-compatible leadless devices, really making a paradigm shift in the management of bradyarrhythmia, and probably it will be a leadless pacing for all in future. Thank you.
Thank you, Arun. Arun, is there any data regarding the pacemaker-mediated cardiomyopathy in these leadless devices?
Yeah, so that's a wonderful question because with transvenous system, that has always been a concern. There have been studies on transvenous pacing devices which have shown an increased incidence of pacing cardiomyopathy when you are placing the RV myocardium. Here you would see that we are specifically trying and mapping the septum, both anatomically based on the contrast as well as the electrogram based. And because of trying to get to the septum, what studies have shown is the incidence of pacing-induced cardiomyopathy with a leadless system is less than 2%. They have systematically followed up all these patients who have received almost full percent RV pacing from leadless device, and the pacing-induced cardiomyopathy is less than 2%. For the conventional transvenous, it is 15 to 20%. So here it is less than 2%.
Thank you, sir.
So one reason for less cardiomyopathy in these patients is that many of these patients were previously on transvenous pacing, and there was no cardiomyopathy. Otherwise, they would have gone to the CRT. That's also one important reason.
Yes.
Thank you so much, Arun sir. Yeah. We are short of time, so maybe I can invite Dr. R.K. Gokru sir to come and present his talk on the ISC classification of coronary lesions.
At the outset, I would like to thank the organizers Cardio Connect Jaipur team and the PGI alumni. They have given a chance to meet two generations from our respected senior Dr. B. Soma Raju to Dr. Pulkit. I wanted to see face of Dr. Raju in 2008 at Nalagarh when we invited him for ISC oration. But because of his prolapsed intervertebral disc, we could not see him. And today, after 18 years, I have seen you, sir. All my charan spurs aapko. Gene of PGI in all of us. And that gene has given a chance to be in touch with academics. And that gave the genesis establishment of Indian Society of Cardiology, which I founded in 1996. And its first official publication, Indian Journal of Cardiology, we started in 1998. And it's a 29th volume is in press, and Walter is publishing it. Because of that PGI gene, we had this Adular study. This is a famous Adular study for ulnar intervention in the world. We had this SWIMI study for sweating in myocardial infarction. It has a 12,000 patients data, which says that if patient has a pain chest, classical of angina and sweating, it predicts 99% positive predictive value of acute MI, even in absence of the enzymes. Then we had the coronary sinus, it's not working. Coronary sinus anatomy classification has been given by our group, Ajmer working group classification, then Palmer arch anatomy classification, and what today we'll be talking of disconnect. What we'll be talking of coronary artery lesion description. I will be talking in detail. And then we have given the first Z score in Southeast Asia for infant from our institution. So, actually, Indian Society of Cardiology has given a classification of coronary artery lesion description called code. And our hypothesis was to create a mathematical correlative lesion description model to express coronary angiogram in a form of code. And we produced this called code and presented at ACC in 2017. And after that, we have many amendments and updated this called code, which we will be discussing right now. And that was to remove the shortcomings of the existing called code, adding more information about the lesion description, maintaining a uniformity and making a code which is easily acceptable to all the physicians. This was published in Indian Journal of Cardiology as a new proposed comprehensive expanded coronary artery lesion description code system and coronary artery angiographic segmental classification, a mathematical model, Indian Society of Cardiology working group code for physicians is. So we will be talking, there are many shortcomings in the existing classification of coronary artery lesion description. So the journey is, the coronary artery tree segment has been classified by different associations in different number of segments, 16 segments, 27 segments, 29 segments by different associations. So it's a really very difficult to remember which segment is located at what place. And due to these limitations, currently existing lesion description does not give instant anatomical virtual image of the lesion location. To overcome these lesions, this code was developed. And the another limitation was because side branches are variable in number and location. So there is no equidistance between the two vessels. And these existing system divides the vessel in proximal, mid and distal segments on the basis of origin of the side branch. So if there is a variable distance between the two side branch, then the length between the two segments, proximal, mid and distal, will be unequal. So to overcome this, a mathematical calculation of individual segment is to be made. And for this, you can understand this with this example. This is your D1, D2. Then this is your proximal segment, this is mid segment, this is large distal segment. So mathematically, you cannot imagine virtually where is the lesion and what is the length and what is the amount of myocardium at risk if the lesion is situated at proximal, mid and distal segment. So for this, we have developed this code system. It has got two parts, segments. The coronary arterial tree, all three vessels divided into three segments. So three segments of all three vessels, 9 segments in place of 16, 18, 21, 29 segments. So it's easy to remember those 9 segments. So it is a caste classification because the coronary lesion classification that was a part of segment classification and another part of lesion description. And the lesion description in last 50 years from different associations, 1980 to 2005, they have given different names, different modes, and they have made the basis of these description at their own will, which is having many limitations. For example, ACC has given type ABC lesion on the basis of their success rate and this, what is the amount of this, or SKY has given its type 1, 2, 3, 4 lesions, or Syntax has given its own. To overcome all these limitations, and what were those limitations? The different associations have defined different modes to classify coronary arterial tree is one part, and lesion characteristics description differently, all association. And these classifications do not address the magnitude of myocardial ischemia threat with lesion characteristics. They only correlate clinical relevance to lesion characteristics only. In the current reporting system, coronary angiogram does have a paucity of documentation of epicardial blood flow and microcirculation characteristics. What we report, we do not give much emphasis on the TIMI flow or MBG gradings. So there will be anatomical limitations because of variable number of side branches, variable site of origin of these side branches, variable sizes of these side branches, and the variable anatomical segmentation of the vessel. Vessel LED is type 2, type 3, type 1. So therefore, all these features leads to incorrect mathematical depiction of the actual anatomical site of the lesion virtually and imaging. Secondly, the existing system does not give any importance to epicardial blood flow, microcirculation status, and no consideration of quantitative assessment of myocardium at jeopardy. Therefore, this existing system does not define coronary anatomy in toto, lesion characteristic description, and quantity of myocardium at jeopardy more objectively. To overcome this code we have developed, it defines coronary artery lesion features more objectively. Just like pacemaker, we have DDDR. We have every word at every same location gives defined information to every observer and maintain uniformity in expression. So we should develop such a code which gives all these features. So can we have a code for coronary angiogram? Yes. And then what should be the objectives of coding? The coding should be such that it brings uniformity in expression of a coronary angiogram and gives at a glance detailed information of a given lesion. So of course, the code should be simple, which is easy to express and understand and able to define various features of coronary anatomy, physiological aspects of coronary blood flow and pathological abnormalities. So this code has got two parts, coding of coronary arterial tree into 9 segments and coding of individual vessel, left main and all 3 vessels. So we have a code for left main 4 positions and 4 words, and code for other vessels 9 positions, 9 words. So caste classification 9 segment mathematical model of coronary arterial tree on coronary angiogram. So segmental code for caste is every artery divided into 3 segments, each segment of 40 millimeters proximal, mid and remaining distal as segment 1, 2, 3. You can just write. 40 has been taken as a criteria. Most of the stents at the time was 40 millimeter long. Second was this is how the segment can, mentally you can prepare first, second, third segment in all three vessels. And second was lesion description code. Coding of individual vessel lesion description. Left main, we have 4 words and 4 positions, and for other vessels, 9 words and 9 positions. So we talk of left main. First position, you just write the word left main LM. At position 2, you just locate where is the lesion located. Whether it's a normal, you write and if it is a short left main short, left main ostial, left main mid, left main distal, and left main bifurcation. So you can locate the lesion where it is present. And what is the degree of obstruction? And fourth position, it's the most important. All characteristic features of the lesion is included in this Z. So you can just easily remember calcification, thrombus, dissection, stent, whether stent is patent, restenosis or thrombosis, or none of these features present in that segment. You can just remember CTDS, CTDS, Z, none of the features present. So at fourth position, you write one of the word. For example, this is the first, this is left main ostial. If you see the code, left main ostial 70% with calcification, left main mid 90% lesion, but there is no CTDS, no calcification, no other features, dissection or stent. And if it is a bifurcation, left main bifurcation 70% with calcification and thrombus. So in one word, in one line, you can write the whole coronary artery lesion description, and you need not to see the coronary angiogram. Before you see the coronary angiogram, you can find it out that you can write in a single line, you can code the coronary angiogram. This is a table where the all 4 positions, position 1, 2, 3, 4, and most important is 4th position. Likewise, the other vessels can be divided into 9 segments, 9 positions, 9 words. The first position will tell you the vessel name, second position will tell you the lesion location, third position will tell you the degree of obstruction, fourth position, what is the lesion length. This is the most important part of this positions, and fifth position, what is the side branch anatomy, and sixth position, the lesion features, most important of it, and then seventh position, TIMI flow, eighth position, myocardial blush grading, and the ninth position will tell you what is the dominance of the vessel. So in first position, you can write left main, LAD, LCX, RCA, or OM1 diagonal. In second position, whether segment is first, second, third. In third position, degree of obstruction. In fourth position, most important, what is the type of lesion? All association divided the lesion type A, B, C. Here we have divided the lesion into 5. A, B, C, D, E. Each segment 10 millimeters. E is more than 40 millimeters, which involves more than one segment, and diffuse, and it's graftable. If the vessel is, the lesion is more than 40 millimeters and vessel is not graftable, it is E0. And if the vessel is 100% obstructed, then it is a type U, unpredictable distal length lesion in 100% obstructive cases. So only after recanalization we can know what is the length of the lesion. At sixth position, most side branch, fifth position, if the vessel is more than 2 millimeters, you write capital word, and if the vessel is less than 2 millimeters, write small. So you will have an idea whether you have to put a stent or you have to put a drug-eluting balloon. You can have your mind set up. At sixth position, which is most important, at sixth position, various features will be depicted, whether the lesion is junctional, ectatic, calcified, thrombus, tortuosity, whether there is a myocardial bridge, dissection, stent, or none of the features is there. So you can just remember that this position, JECTO, JCTO, just like JECTO, MB myocardial bridge, DS double strength, or you can just remember, and Z. So at sixth position, you put all these features in a bracket. At seventh position, TIMI flow, eighth position, myocardial blush grading, and at ninth position, you can have dominance of the vessel. So this is the table where 9 segment, 9 position, and 9 words you can remember. And just to understand, if RC has a 70% 20 millimeter long lesion at 70 millimeter distance from ostium with TIMI 3, MB is 3, flow characteristic in right dominant circulation, you can just write RCA 70 millimeter distance, so it is a segment 2, 70% lesion, and 20 millimeter long, so it's a type B lesion. and the side branches are small, less than 2 millimeters. So it's a, if you see the side branches coming out of it, it is less than 2 millimeters. So you can write small words AM1, AM2, and the lesion characteristics are absolutely normal vessel. There is no, they are neither junctional, no ectasia, no tortuosity, no thrombus, no calcification, no stent. So you can write Z, and the Timmy flow 3, MBG grading 3, and it's a right dominant circulation. So in single line, you can describe your lesion. Similarly, this is the another example where the RCA lesion is in the second segment 80%, and the A is lesion is 10 millimeters or less. Side branches are small, AM1, AM2, and there is a thrombus, so you write T, and TME3, MBG grading, and the dominance. So you can describe like this. If there are multiple lesions, for example, this is the LED in first segment has a 80% lesion with type B, more than 10 millimeters long. Diagonal 1 is small, less than 2 millimeters, small d. Diagonal 2 is large, it's a large D2 capital, and there is a calcification and the thrombus, you can write in bracket CT, and Timmy flow and MBG grading and dominance. So in that, this way you can just write the single line description of the coronary angiogram. But this code has still limitations. It does not address abnormal coronary origins, angle of side branch origin, collateral circulation, and retrograde filling. This has got superiority over other classification because at a glance you can predict pre-procedural outcome of procedure depending upon the amount of myocardium supplied by the given lesion. So, Karl code it defines angiogram more objectively with respect to lesion location and site, number and size of the side branches from segment, more vessel characteristics. All features of the lesion are described as a Jacto MBDS-Z, which is easy to remember. And in this updated Karl code, we have included the left main description as well. And this predicts amount of myocardium under ischemic threat by virtual imaging of mathematically located lesion. So it has got advantage over other classification. It's a code expression, an instant visual virtual impression of coronary angiogram, coronary anatomy, and physiological characteristics of coronary blood flow and pathological characteristics of lesion without seeing a coronary angiogram at a glance. It's a simple, reproducible, easy to understand and remember, uniformity of expression, more informative than existing lesion classification. It has included left main. It obviates immediate need to look at angiogram, gives good semi-quantitative and qualitative assessment of myocardial at ischemic threat. So to conclude my talk, ISC classification of coronary artery lesion description is a better expression than the existing classification made by other association, and coding is a better form of expression of a detailed coronary artery lesion description to instantly imagine coronary angiogram virtually in absence of a stored coronary image file. So under the aegis of Make in India mission, India has the highest number of interventional cardiologists in the world. This Constituent Assembly of Indian Cardiologists at this PGI Connect Meet 2026 should adopt, enact, and give to ourselves this Indian Karl code to every coronary artery lesion description, and also present to the world's Interventional Cardiology Society as an Indian PGI contribution for better expression of coronary artery lesion description for physician is, I did my LLB after my retirement, so the language of constitution I just added. Thank you very much for patience hearing.
Thank you so much, sir, for that wonderful presentation. While we are having questions, maybe we can ask the next speaker, Dr. Deep Pant, to come up and get his presentation ready. Dr. Deep Pant will be talking about humor in medicine, heart to heart.
A very good afternoon to all of you, my teachers, my colleagues. देखो आज मैं आप सब लोगों के सामने खड़ा हूं तो ये प्रूफ है कि कार्डियोलॉजी सैचुरेट हो चुकी है. इंटरवेंशन में कुछ करने को बचा नहीं, लोग 150 लीडलेस पेसमेकर डाल चुके हैं. डॉक्टर गोपी इज हियर. रिसर्च में कुछ बचा नहीं, मरीजों का पसीने के ऊपर रिसर्च हो चुकी है। तो अब सिर्फ ह्यूमर बचा है, तो डेट्स व्हाई आई हैव टेकन ह्यूमर। आप सब लोगों का मेरा बहुत बहुत प्रणाम। पुराने जमाने में जब राजा होते थे उनके विदूषक होते थे, और विदूषक जो थे गुरुओं की और राजाओं की भी कभी कभी मजाक बना देते थे, तो उनको एक इम्यूनिटी होती थी। तो ये इम्यूनिटी आज आप मुझे भी देंगे। मैं थोड़ा कुछ बात करूंगा, पहले अपने पीजीआई के बारे में, फिर अपने पेशेंट्स के एक्सपीरियंसेस के बारे में। सबसे पहले मैं ये कहना चाहूँगा कि मैं बहुत बड़ा वाला हूँ जो आपके सामने ह्यूमर करने के लिए खड़ा हो गया। और सबसे पहले मैं अपने प्रभु श्री राम, डॉक्टर राम को धन्यवाद देना चाहूँगा और उनकी टीम को। उनका नाम राम नहीं, राम चित्त ले गया, वो हम सबका चित्त ले गया है। तो थैंक यू वेरी मच फॉर इनवाइटिंग मी। सबसे पहले मैं कहना चाहूँगा कि उन्होंने मुझे इनवाइट किया, वो मेरे से बड़े वाले हैं कि ह्यूमर के लिए, और सबसे बड़े वाले आप लोग हैं जो यहाँ बैठे हैं इस एक्सपेक्टेशन में कि शायद कुछ मैं कपिल शर्मा लाइक एक्ट करूँगा। तो आज एक बात तो तय है कि या तो मैं आपको हंसा पाऊंगा या आप मुझ पे हंसेंगे। तो इस संकट की घड़ी में मैं अपने सबसे पहले अपने पीजीआई के टीचर्स को याद करना चाहूँगा। सबसे पहले जब भी पीजीआई की बात होती है तो सबसे पहले क्या याद आता है? मुझे तो सबसे पहले बड़े साहब के पकौड़े याद आते हैं। आपको आते हैं कि नहीं आते मुझे नहीं मालूम। उनके पकौड़े बहुत फेमस होते थे, और आज जो कुछ भी मैं यहाँ पर हूँ उनके पकौड़ों की बदौलत ही हूँ। और जिसने जितने पकौड़े खाए आज वो उतना सफल है। मुझे लगता है सबसे ज़्यादा पकौड़े जरूर डॉक्टर स्मिथ और डॉक्टर अरुण गोपी ने खाए होंगे, तब तो इतने ज़्यादा फेमस है। तो जब मैं पीजीआई में शुरू से मैं नया नया गया था, तो उस समय मेरी यूनिट, मेरी जो पोस्टिंग थी किसी और के साथ थी। 3 महीने बाद मेरी पोस्टिंग बड़े साहब की यूनिट में लगने वाली थी, और मुझे पाल्पिटेशन 1 हफ्ते पहले से शुरू हो गए थे कि उस यूनिट में जाके क्या होगा। कोई बड़े साहब कुछ बोलते नहीं थे, सिर्फ बुदबुदाते थे, उसे समझ लेना पड़ता होता था कि क्या बोल रहे हैं। तो जब मेरी पहली बार उनके यूनिट में पोस्टिंग लगी तो मुझे बड़ा रिलीफ हुआ कि हमारे मनोज सर यहाँ पर हैं, शायद आपको मेरा प्रणाम, मनोज रोहित सर। वो आगे आगे चलते थे, सॉरी, तो वो स्ट्रेस बस्टर का काम करते थे, सारा शॉक वही ऑब्जर्व करते थे। तो हमारा एग्जिस्टेंस था या नहीं था मुझे नहीं मालूम, पर हम लोग तो कहीं पिक्चर में नहीं आते थे। एक दिन क्या हुआ, मेरी किस्मत खराब थी, मनोज सर छुट्टी पे थे और डॉक्टर महाजन छुट्टी पे थे, मैं अकेला पड़ गया सर के साथ। प्राइवेट वार्ड का राउंड था। सर ने मुझे ऐसे घूम के देखा ऊपर से नीचे तक, मेरे ऊपर ऐसा लगा जैसे कि फेल होने की तलवार लटक गई, पूरा पसीना पसीने। मैंने कहा सर, आई एम ए फर्स्ट ईयर रेजिडेंट, आई एम नादर फ्रॉम पीजीआई नादर फ्रॉम एम्स। उनका मुंह बन गया, कोई बात नहीं चलो। सर आगे आगे चल रहे थे, मैं डरते डरते पीछे चल रहा था, प्राइवेट वार्ड का पेशेंट था। सर ने हल्के से कुछ बुदबुदाया, मैंने कहा सॉरी सर। सब ज्यादा जोर से बोलते नहीं थे, फिर थोड़े से बुदबुदाए, कुछ बोले, मैंने फिर सॉरी सर कह दिया। तो उसके बाद पहला पकौड़ा मुझे मिला पीजीआई का, काका इसका पोटेशियम कितना है। उसके बाद कसम से मैं कभी भी अपने मरीज का पोटेशियम चेक करना नहीं भूला, चाहे पेशेंट की डेथ हो जाए लेकिन पोटेशियम उसका करेक्ट होता था मरने के टाइम पे। अब उसके बाद बात करूंगा हमारे आदरणीय बाली सर की, जो मेरे लिए हमेशा आदर्श रहे, हमारे गुरु भी रहे। और मैं इनको बाली सर नहीं, हमारे लिए बली सर हैं, जो हैवी वेट है कार्डियोलॉजी के। और मेरा दुर्भाग्य है कि सर ने मेरे ज्वाइन करने के 3 महीने के अंदर पीजीआई छोड़ दिया। इनको शायद ये लगा कि शायद अब रीजन की क्वालिटी काफी डाउन हो गई, तो इट्स नॉट गुड टू वर्क इन पीजीआई। तो सर सॉरी सर, आपने थोड़ा मुझे मौका दिया होता तो शायद मैं अपने को इम्प्रूव करता। लेकिन जोक्स अपार्ट सर, मैं आपको बहुत आइडलाइज करता हूं, और जहां भी आप रहे मैं हमेशा आपको फॉलो करता हूं। आपका बहुत बहुत प्रणाम और धन्यवाद। फिर मैं बात करूंगा हमारे बहुत स्वीट नेचर्ड वाईपी शर्मा सर की। 3 साल तो मैं यही कंफ्यूज रहा कि सर का नाम यशपाल शर्मा है या यशपाल शर्मा है। लेकिन जो भी था, सर बड़े स्वीट नेचर्ड थे, कभी डांटते नहीं थे। और लेकिन एक बात से बहुत नाराज होते थे, अगर एंजियोप्लास्टी के पेशेंट में हमने एनीमिया और उसका प्रोटीन बिल्डअप नहीं किया तो सर आग बबूला हो जाते थे। तो ये बात मुझे आज तक भी याद है कि मैं एंजियोप्लास्टी के पहले चाहे 99% आर्टरी ब्लॉक क्यों ना हो, मैं एनीमिया और उसका प्रोटीन बिल्डअप जरूर करता हूं। ये मेरी आदत सर ने डाली है, थैंक यू सर। उसके बाद मैं बात करूंगा मनोज रोहित सर की। सर के नाम में ही बड़ा कंफ्यूजन था, मुझे लगता था मनोज पहला फर्स्ट नेम है या रोहित पहला नेम है। एनीवे सर ने हमको पीडियाट्रिक कार्डियोलॉजी सिखाई, थैंक यू वेरी मच सर। लेकिन हमने हमेशा पीडियाट्रिक कार्डियोलॉजी उल्टी सीखी, क्योंकि जब भी मैं सर के पास जाता था हमें पेशेंट के इको की जो इमेज होती थी उल्टी होती थी। अब हमें भी उल्टी इको उल्टा करने की आदत हो गई है, जब पेशेंट को लेटाते तो उल्टा लेटाते हैं। तो अटेंडेंट कहते भाई साहब आपने, डॉक्टर साहब ने पेशेंट उल्टा क्यों लेटा दिया? भैया क्या करें, हमारी ट्रेनिंग ऐसी हुई है। थैंक यू वेरी मच सर। फिर मैं बात करूंगा अजय बहल सर की, जिनको देख के हमेशा मन बहलता था। कभी मैंने इनको गुस्सा करते हुए नहीं देखा, कभी डांटते हुए नहीं देखा। थैंक यू बहल सर। उसके बाद हमारे साथ आरवी सर थे, राजेश विजयवर्गीय सर, उनको भी मेरा बहुत बड़ा प्रणाम और नमस्कार। उन्होंने हमको कार्डियोलॉजी में पहला लेसन पंक्चर करना सिखाया, और जब पहली बार मैंने फीमोरल पंक्चर किया तो सर ने बोला देखा सीख गया ना पंथ पंक्चर करना। तो वो मुझे लेसन अभी तक याद है। थैंक यू वेरी मच सर। उसके बाद मैं बात करूंगा अपने पीजीआई के अपने जो कलीग्स की बात करूंगा। हमारा पीजीआई के ग्रुप है, उस ग्रुप में हमने देखा है कि मुझे वो लोग ज़्यादा अच्छा लगते हैं जो कुछ पब्लिश नहीं करते, अपना अचीवमेंट नहीं पोस्ट करते। मुझे लोग सबसे अच्छे लगते हैं, क्योंकि जियो और जीने दो। क्योंकि जब से डॉक्टर अरुण गोपी ने अपना पोस्ट डालना शुरू किया कि आज मैंने ये किया, तब मुझे याद है 2013-14 मैंने पहली बार एल्पेक्स खाई थी। और आज आलम यह है कि 2 एंटी डिप्रेशन खा रहा हूं, 3 बार एल्पेक्स खा रहा हूं, तब भी मेरी टेंशन कम नहीं होती। कुछ नहीं छोड़ा इन्होंने। जिस फील्ड में गए मैंने उस फील्ड में कोशिश की, और ये मुझसे 10 कदम आगे ही रहे हमेशा। और रही जो छोटी मोटी जो कसर रह जाती है वो डॉक्टर स्मिथ पूरा कर देते हैं। अभी 2 दिन पहले उन्होंने एंजियोप्लास्टी की, 5 ml में डाई में एंजियोप्लास्टी। भाई साहब कुछ तो छोड़ दो हमारे लिए, कुछ तो कैटेगरी कुछ तो रख दो हमारे लिए। हम 1 ml 2 ml में एंजियोप्लास्टी करनी पड़ेगी, तभी हमारा काम चलेगा। एनीवे जोक्स अबाउट, मैं आप लोगों के अचीवमेंट को बहुत बहुत एडमायर करता हूं, एंड आई विश यू वेरी गुड लक। उसके बाद मैं बात करूंगा अपने, अब छोटा सा एमबीबीएस का एक किस्सा बताता हूं। जब मैं 1991 में दरभंगा मेडिकल कॉलेज बिहार में एमबीबीएस करने के लिए गया था, तो हमारे एक टीचर थे मिश्रा जी, एनाटॉमी के वो हमारे लेक्चरर थे, और हम डिसेक्शन हॉल में वो मुझे हमेशा ऑब्जर्व करते थे। मेरी हिंदी कुछ बिहारी हिंदी से अलग होती थी। तो उन्होंने एक दिन आके मुझसे पूछा, पार्टनर आप कहाँ के रहने वाले हो? मैं आपको बता दूं आपकी जानकारी के लिए, उन दिनों मेरे फादर का नाम भी केसी पंत है, और उन दिनों केसी पंत जी जो है स्टील एंड माइंस मिनिस्टर हुआ करते थे कांग्रेस गवर्नमेंट में दिल्ली में। तो मैंने कहा सर मेरा नाम दीप पंत है, दीप चंद्र पंत। अच्छा पार्टनर, कहाँ रहते कहाँ हो? पापा की पोस्टिंग दिल्ली में थी। मैंने कहा दिल्ली में रहते हैं, साउथ दिल्ली में, सेंट्रल दिल्ली में। अच्छा दिल्ली में रहते हैं, वाह, दरभंगा आए हैं। अच्छा, आपके फादर का नाम क्या हुआ? मैंने कहा मेरे फादर का नाम श्री केसी पंत है। क्या आप केसी पंत जी के लड़के? जी सर, केसी पंत जी के से लड़के हैं। उस चेयर में खड़े हो गए, आप सचमुच में केसी पंत जी के लड़के? मैंने कहा जी सर, दिल्ली वाले केसी पंत? बिल्कुल सर, उन्हीं के लड़के। मैं समझ गया ये क्या सोच रहे हैं। तो बोले पार्टनर तुमने आज तक हमको 6 महीने में बताया क्यों नहीं? मैंने कहा सर सिक्योरिटी रीजन से नहीं बताया। तो उसके बाद वो 5 साल तक मुझे मेडिकल कॉलेज में जहां मिलते थे अपनी मोटरसाइकिल रुक के पूछते थे, पार्टनर कोई प्रॉब्लम तो नहीं है? हमने किसी को बताया नहीं, कोई प्रॉब्लम तो सीधा मेरे पास आना। उसके बाद मैं पीजीआई चंडीगढ़ गया। पीजीआई चंडीगढ़ में आपको मालूम है फर्स्ट ईयर रेजिडेंट जो होते थे मेडिसिन के, वो ज़ॉम्बी बन के चलते थे। उन्हें दिन रात का कोई आभास नहीं होता था। इतने वर्कलोड से ज्यादा, इतना ज्यादा वर्कलोड होता था कि वो रात में ऐसे घूमते थे, अगर एकदम से आप नाम पूछ लो तो एकदम नाम भी नहीं बता पाते थे। थोड़ी देर में पॉज के बाद बोलते थे रामाकृष्ण सर। तो ऐसे माहौल में हम जो रात में टेम्पररी पेस मेकर करने के लिए कभी कभी जाते थे, तो वहां आप लोगों को मालूम होगा एक हॉल ए होता था, एक हॉल बी होता था। हॉल ए में एक्टिव पेशेंट रहते थे, और हॉल बी में वो पेशेंट होते जो कल परसों नर्सों के पेशेंट रहते थे, कभी कभी वो इग्नोर भी हो जाते थे। तो एक रात में पीजीआई में गया, हॉल बी में गया, टीपीआई करना था मैंने कोई पेशेंट का। तो मैंने देखा एक सरदार जी अपने आप एम्बू दे मेरे को समझ नहीं आया ये कौन सा मामला है भाई। मैंने उसके अटेंडेंट से पूछा, कोई और बैठा था बगल में, उसने कहा इसका अटेंडेंट को ना वो सुसु आई थी तो वो टॉयलेट गया, इसको पकड़ा के गया है। तो वो पेशेंट भी कहीं फॉरगेटेड था, वो खुद एम्बू कर रहा था, कॉन्शियस हो गया था, कोई देखने वाला नहीं था उसको। एक और किस्सा पीजीआई का बताऊंगा। एक रात में मैं भी जॉम्बी की तरह घूम रहा था, एक टीपीआई किया, उसको पेशेंट को हमने रात में 2 बजे हॉल बी में छोड़ दिया। अगले दिन मैंने शायद ओवर दिया नहीं दिया मुझे मालूम नहीं, तीसरे दिन सुबह से मुझे स्ट्राइक किया, यार ये को टीपीआई किया था परसों रात में, वो कहाँ है, वो तो मुझे कहीं दिखा नहीं रहा पेशेंट। तो मैंने शायद ओवर नहीं दिया, क्या हुआ, फिर मैं दौड़ के हॉल बी में गया तो पेशेंट का बेड खाली था, उसकी वाइफ बगल में बैठी थी। मैंने कहा पेशेंट कहाँ है, बोला जी उनको पॉटी लगी थी, वो टीपीआई पकड़ के पॉटी करने के लिए गए। तो ये सच जो मैं किस्से बता रहा हूं, ये सब सच के किस्से हैं, कोई मतलब दे आर नॉट मेड आउट किस्से। फिर उसके बाद मैं बात करूंगा अपने एक प्रैक्टिकल्स की। जब मैं 2003 में नया नया असिस्टेंट प्रोफेसर अपॉइंट हुआ था गवर्नमेंट मेडिकल कॉलेज हल्द्वानी में, उस समय वो मेडिकल कॉलेज नहीं था, सिंपल हॉस्पिटल था। तो एक पेशेंट को हमने सीओपीडी टाइप 2 रेस्पिरेटरी फेलियर था, गैस्ट्रिक पेशेंट था, उन दिनों कोई वेंटिलेटर भी नहीं होता था, इतने एडवांस सर्विसेज भी नहीं थी। तो मैंने उनके अटेंडेंट को कहा भाई इसको घर ले जाओ आप, कुछ है नहीं इसमें, या तो कहीं हायर सेंटर ले जाओ। तो बहरहाल उन्होंने पता नहीं किया क्या, शायद वो घर ले गए। 3 महीने बाद मैं अपनी ओपीडी में बैठा था, मेडिसिन की ओपीडी में, पीछे से किसी ने मुझे नॉक किया ऐसे पीठ में। जनरली लोग पेशेंट आगे से आते, पीछे से कौन आता है। तो मुझे थोड़ा इरिटेशन में, मैं घूम के देखा तो कोई आदमी थे, 65 साल के बुजुर्ग थे, बोले डॉक्टर साहब पहचाना आपने मुझे। मैंने कहा नहीं 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 पहचाना, सामने आइए। तो बोले मैं वही हूं जिसको आपने 3 महीने पहले मरा घोषित कर दिया था। तो मैंने कहा अच्छा वेरी गुड, बहुत अच्छा, अगर आप ठीक हो गया बैठो, यहाँ बैठो। नहीं मैं बैठने नहीं आया हूं, मैं एक बात पूछने आया हूं आपसे डॉक्टर साहब। उसका बेटा बोला नहीं नहीं पापा कुछ नहीं पूछना, चलो घर चलते हैं। तो मैंने बोला नहीं पूछो। उसके बाद बेटा मना करे, वो बोले मैं पूछूं, वो फिर मना करे। मैंने कहा कोई बात नहीं, तुम चुप रहो, उनको पूछने दो, पूछना क्या चाहते हैं। तो बोले मैं सिर्फ डॉक्टर साहब ये पूछना चाहता हूं क्या मैं दूसरी शादी कर सकता हूं। तो ये सब किस्से हमारे साथ रहे, और मैं इसके साथ ही अपनी वाणी को विराम दूंगा। थैंक यू वेरी मच, नमस्कार।
Okay, sorry, we'll be concluding this session now, and we had planned for a tea break, but what we'll do is that we'll have the tea brought over. You can all bring your tea over here, because we also have a GB meeting which has to be conducted now. So Dr. Smith Srivastav can conduct the GB meeting. Thank you, sir.
Because PGI Cardiology Alumni Welfare Society is a registered society, so it's mandatory that we do GBM and EBM, Executive Body Meeting and General Body Meeting, once a year, every year. And then we have to send these reports to the Registrar Society of Chhattisgarh and India. So this is part of that. Basically, Dr. Sojatya would be telling us what we have done in past 1 year. And more importantly, we'll decide where we'll have the next meeting. Over to Sojatya.
So I think I would just want to request you all, rather than, so you all must be knowing, and I maybe call up all of you all the time. Many of you I call up multiple times and maybe disturb you a little bit. So I'm talking about the monthly webinars that we do. So it was started by Dr. Smith, and we are running it for 3 or 4 years now. I think the webinars are an important component of what we do as in our alumni society activities. and it's an part of the essence of what we are as PGIs. Sometimes maybe it becomes a little bit difficult for everyone to attend the webinars, and of course, it's also difficult to prepare for the webinars. But it will be my small request to all of you that after this alumni meet gets over, you just remember that the webinars continue throughout the year. It's a chance for all of us to present our work, and it's also a chance for all of us to keep the continuity going. So, if suppose we call you up, it's an encouragement for us also that we get new speakers to talk about their experiences, their work, and share it with all the others. It's we try to keep a catalog of all of that, and we have a YouTube channel also where everything is uploaded. And it will be a great encouragement for us if we can have new speakers, younger speakers, as well as experienced speakers as well. So I think that is something that we can, if you can help us whenever we call you up, that would be great. Anything else, sir?
I do not think that it is Sojata should be asking for the help. It's our own things that we are doing. So we should be coming forward and rather aiding Sojatya, because he has taken over and he's doing a better job than what we could do in last 1 or 2 years. Other thing is, Dr. Bali, we are still waiting for the quarterly journal. So that thing, Dr. Sharad Chandra is. So I think, sir, you can here today pick up people, make a team of 5, and then delegate few things so that like EP can be taken by Arun, structural can be taken by somebody else, and we can have one page dedicated to whatever we have done in that month or in those 3 months. Let's make a beginning. Let's make it a e magazine and then get it done. And then, sir, I think you pick and choose. It's that way. It's easier. Dr. Sharad Chandra is not here, sir. That one insurance thing is also left behind. That was, we were planning to insure each and our each member in a group insurance. So any has anything related to health or any accidental need, we can have a fund insured and given to them. So that's, you can take it whatever. Well, sir, this is just a platform, so you can add whichever way you want it to grow. We can add. Yes, sure, sir. Okay. So, Dr. Somaraju sir is, I think that is what the PGI Alumni Society also is wishing to have. The Baton Should Not Fall is the name of the book. It's an essential read for young medical doctors from a renowned cardiologist and educator, Dr. Somaraju sir. So he says, sir, we already have the addresses of all the persons in an Excel sheet. So I'll provide you that and it can be mailed to them. The forum is open, sir. Anyone can come and comment. Give us a direction, sir. Please. Suggestions.
Next 10,000 contribution. Voluntary.
So I would like to make it clear that there is no contribution needed for the Alumni Welfare Society. It's all voluntary. So if you want to contribute, there is no compulsion. There is no fee, anything. It is not required. Many have asked that whether we need to pay yearly. It's nothing like that. Don't have to pay any time. If you want to pay, you can contribute. One. Secondly, next time, where do we want to go?
Next stop.
So one is, we feel that Chandigarh is long due, or Assam. Assam would be nice. But no Assam people have come. I thought that one of them would come and we'll catch them. very well connected. But then, sir, the difficulty is, if it is well connected, people come and they deliver their lecture and fly off. If it's a place like Jaipur, people are staying for 2 days. Sir, I think you come to the stage and pass the baton. The baton should not fall down.
Can I talk? See, basically, this is a meet and greet type, no, not a learning. In fact, we have learned and we've taught people, so everything is over. So, work-life balance we have never been maintaining in our lives. So, थोड़ा sightseeing and enjoyment भी हो जाए, ऐसा location choose करिए, ठीक है? Not हैदराबाद, चंडीगढ़, मुंबई, ऐसा नहीं. चंडीगढ़ बोले तो यूपी सिंह करेगा, लेकिन ऐसा नहीं.
Talk will be from Dr. Sudhir Saxena, sir, on photography beyond medicine.
So, first of all, thank you, organizers. I mean, it is Dr. Bhagratta's probably vision that we should have some these kind of sessions also to lighten up the mahal, right? I think we have heard eminent speakers over here. So I'll discuss about what I do. Okay, I have been an interventional cardiologist for last 30 years now, more than that, right? And now it is something else for me. Start nahi ho raha hai.
For over 3 decades, this was my world.
Mike
Then one day, I discovered another way of seeing.
Mike. इसमें नहीं लगेगा. Okay.
I never stopped being a cardiologist.
Anyway.
I simply found another way to see.
So basically, what I'm trying to talk today is that I have moved on in life. I still do cardiology. I still do interventions. I still put in pacemakers. I still see patients. But I feel that there is a very important need that we all have.
For over 3 decades.
Sorry.
This.
So, no, it's okay. It's okay now, right? So I'll just talk about little about my journey as a professional photographer. Now I'm a pro photographer now, right? And I continue to be a cardiologist. So I have titled this From IVUS to IVUS, right? This is what I'm seeing now and what I see in the cath lab. So this is a journey over last 35 years. If Dr. Bhagratta and Dr. Bali would remember, we had a space lab, kind of a cath lab in PGI at that time, which was an analog cath lab. That was the time when I used to do angioplasty with a film camera. And there was a film which used to record the angiograms in the cath lab. Then we saw the hybrid era in which, although the digital recording was there, but the recording was still done on a film. So I had a hybrid camera at that point of time, which will still record digitally, but on a film. And now we have these Sonky cath labs and Sonky cameras, which are totally digital. And this is how my journey actually has evolved parallelly in both the fields where I have used the technology to the best of my knowledge. So this has been two worlds, one passion. These are the books that we read in cardiology. I do not know if these days the DM students read any books. I'm not very sure. But I was trained in an era when we used to read all these books and thoroughly. And when I moved into photography, I had to look up to some other people. For example, a person called Ansel Adams, if you have heard of him. He is the father of photography from America. Then Sebastião Salgado, who passed away last year, an eminent name. Raghu Rai from India. So I read up all their works. I saw all their works so that I understand the nuances of photography and how can I improve my photography. I have not had any formal training in photography totally, ever. And I have learned whatever I have learned myself. One important reality Dr. Bali also alluded to, somebody else also alluded to, is that work-life balance is very important. And I probably understood this about 10-15 years ago, that 63% physician burnout rate in the 50s. It should not happen to me. I don't want that. I want my life to be peaceful, right? So I continue to work, but I have to have a hobby or something which gives me a lot of mental relief and away from stress. And let us not forget, we have seen so many cardiologists pass away in the last 2-3 years, right? Very good friends like Bharat Bhushan Channa, who was my batchmate, passing away because of radiation, I guess. Then Dr. Mohan Nair, right? Then Dr. Hardas. And there are so many. Recently, one Dr. Batra passed away. Cardiologists have a 2.5 times higher rates than physicians, any other faculty, of passing away at a younger age. So that is very important, that we have to heal ourselves and not just work, work and work. What Tristan Bernard, who did the first transplant surgery, said that there is a circle of life which every individual should complete, right? And the circle of life consists of different phases or seasons of his age and the way he lives. And I felt that I had my season of the first part, which was pure interventions and heroics. And now I have moved on to another season, which is observation and integration. I observe a lot. And as a photographer, I can tell you, ever since I have taken up photography, I see beauty in every small thing. And I'm just looking for beauty everywhere in this world. So that has changed my perspective of looking at the world totally. So I'm trying to complete my circle of life. Over the last so many years, I have traveled across the world. I have almost done 25,000 kilometers on road in the last 10 years, whereby I have been photographing different areas of the world, different geographical areas of the world. I have a collection of about 15,000 photographs with me, 15,000, of which I can say that 5,000 would be very good. I will just present a couple of them, and just to give you the gist of what kind of photography I do. So first I'll talk about landscapes, because everyone who picks up a camera for the first time will do a landscape photography. Landscape has got its own challenges, like you have to chase the perfect light, you have to have an unpredictable weather which you have to take care of, then you have to wait for the right moment. And above all, the composition of the photograph has got to be very good. Otherwise, it is not a pleasing photograph. Anybody can click a landscape, but it may not be pleasing to the eye. So you have to make it a very, very pleasing photograph. Imagine if we are talking about a world which is a 3D world. I can see all of you in 3 dimensions. Photograph is a 2D phenomenon, right? It is not a 3D. So if I have to show you a picture which I want to visualize, or I want you to visualize in a 3D, I have to present it in such a fashion that you can make out that this is the foreground, this is the midground, this is the background of this picture, and this is a beautiful picture. So I'll just give you some examples. This is how I told you, this is how I've traveled almost 25,000 kilometers on road to capture these pictures. This is the first picture I'll show you. This I captured in Norway about 2 years back. This was in a freezing condition, -3 degrees Celsius, early morning. I knew that the sun is going to rise beyond those mountains and beyond this lake. I got up at 5:30. I generally get up, whenever I go for photography, I get up at 5 o'clock in the morning and try to get the morning shots. So this is at sunrise, and you can see it's a beautiful sunrise, and I could capture it because I was in time, and the perfection because of my timing as well as the camera. This is another picture which I had taken 2 days back of Aurora Borealis. So many people take pictures of Aurora Borealis. This was in the middle of the night. It was very, very freezing and windy conditions. But as I told you, composition is very important in photography. If I take away this tent, which is a red tent, from this picture, it becomes a very ordinary picture, right? So composition is very important in this picture. If you remove that tent, then the picture becomes very, very simple. So composition matters a lot. Sorry. This third picture, this again I had taken recently in New Zealand. This is called the Lake Wanaka, and this is the most photographed tree in the whole world. There is a single tree, willow tree, standing in there, and this is the most photographed tree. I reached there at about 5:30 or so because I knew that the early morning hour would be much better. But when I reached there, it was all raining. It was all dark clouds. Can't do much. Just wait over there and wait for the clouds to go. And lo and behold, after about an hour, the sun peeps out and you get this golden glow all over. And you get this magical picture over there. Waiting for 1 hour in the rain helped me. This is again another picture from Milford Sound in New Zealand. The cruise was over, people had gone. I waited for another hour because I knew that at Milford Sound you get very good evenings color, and took this picture almost all alone. There was nobody there. This is another picture which I took in Gulmarg. This temple, I don't know how many people have seen it, but this temple, you remember the picture of Rajesh Khanna, Jai Jai Shiv Shankar, right? That scene was picturized over here, but this doesn't exist because it got burnt down. So I went there 1 day prior to taking this picture, recceed the area, came back early morning at 5 o'clock again and took this picture. Fortunately, there was good cloud cover to give me a magical picture. This is again in Amsterdam, early morning, golden hour, windmills, reaching there at again 5 o'clock in the morning. This was taken in Spiti Valley. I think Yashpal would know it better probably. This is a place called Langza. About an hour earlier, there was a thundercloud. You can see the cloud behind the statue of Buddha. But within an hour, the scene changed. It became a golden light and the scene totally different. And this is a waterfall for which you have to get wet. You have to go behind the waterfall to picturize this. Everything gets wet. You get wet, your camera gets wet, everything. But then if you want a good shot of this, this is called Seldenafoss. This is in Iceland. So you have to get wet. Can't do much. Or else you go to another waterfall right at the perfect time because this is a sunset scene and you have to be there before the sun sets and take the picture. Sometimes there is no light or less light, and this is a place called the Glacial Lagoon in Iceland, where you get these kind of huge icebergs floating over there, and you get a good diffuse light. I time my flights also according to my picturizations. This picture, I had timed my early morning flight, and I set purposely on the right side because I knew that from the right side I'll be able to picturize the Alps in New Zealand. So early morning flight, sunrise, sitting on this side, I've taken an aerial shot from the plane. So this is how you have to plan your pictures also. For this picture, you have to climb a mountain in Scotland. You go up the mountain, wait for an hour, wait for the train to come. There is a specific time when this train comes, and you have to click this picture right when it is there. So this journey of landscapes will continue throughout my life. As Dr. Somaraju also said, don't retire. I'm not going to retire neither from cardiology nor from photography, sir. So I now take you to the most interesting part of my career, which is wildlife. I have taken up wildlife photography after seeing Dr. Ramakant Panda. Many people must be knowing Dr. Ramakant Panda, the eminent surgeon from Mumbai, right? He is an ace wildlife photographer himself. Ace wildlife photographer. So when I saw his work, I thought I'll start with wildlife. But wildlife is the most difficult genre because nothing is under your control. Your subject is not under control. Your atmosphere is not under control. Even you are not under your control because you are changing the settings of your camera every moment according to the scene. So this is one of the landmark pictures which I took. The colors are not coming so well over here, but this was a cheetah in Masai Mara, and we were chasing this cheetah for almost 4 hours. It's very difficult to shoot a cheetah because it is a solitary animal and it runs very fast. But fortunately, the skies actually gave me a very good backdrop of this cheetah, and this cheetah was sitting quietly, and so I could take some good pictures of this. And this has been appreciated in one of the wildlife competitions also, this picture. Sometimes you see the cheetah family, and it is so heartening to see the small cubs playing around with the mother. This is a leopard. I think some of you are going for a leopard safari tomorrow. Leopard is the most captivating animal I have ever seen because it looks right into your camera and right into your eyes. And it's a very, very small animal. It's not a huge cat. It weighs around 60 kgs. So when I took the pictures of this, initially it was looking at me with suspicion, and then it became relaxed, tail up, curled, relaxed. So the leopard can carry almost 2 to 3 times its weight on a tree. It can carry its kill and keep it there and then use it or eat it over the next 7 days to save it from other predators. That is the strength of a leopard, 60 kg leopard. Then the king of the jungle, the lion. This lion I photographed very early in the morning, just at the sunrise time. And it was taking care of its pride, which was having a breakfast around, right? So it was looking for any other predators coming in that region. It was a regal lion sitting over there. And you can make out the light coming from behind, golden mane coming up. And then I could see it in the afternoon also. It was shrugging of water after a rainfall. And sometimes these kind of shots you get, and these are very, they bring a smile. It's bringing a smile on your face also, Anshul. So you can imagine when I see this with my own eyes right in front of me, I mean, it is so heartening. You just forget about everything in the world. Lions, they kill in a pride. So sometimes you get these kind of shots where multiple lions will come in one shot. This I had photographed at about 7:30 in Masai Mara in the night, and this shot was taken in the headlights of my car. It was pitch dark, and they had taken down a huge eland, and all of them were busy eating. Only 1 or 2 are looking at me. Rest of them are busy. They were just about 15 feet away from us. And although I was quite scared to take this picture, but yes, it paid dividends. Next morning when we reached there were just some leftovers for breakfast of these lions. And I mean, just interesting. So talking about tigers, tigers are pride of India. We all know it. And I shoot a lot of tigers. You must have seen hundreds and thousands of pictures of tigers. But interestingly, this is a condition where I was waiting for almost 2 hours in 46 degrees in Ranthambore, 46 degrees, no cover on the head, nothing. Waiting for some action to happen in this picture, because these 3 sub-adult cubs were sitting on the top, and suddenly they saw a wild boar and they came into action, and this is how this picture emerged after waiting for such a long time. Sometimes the tiger pictures are, you can say, artistic also, like this one. I had titled this as Mujhe Jeene Do. And sometimes when you take a habitat shot, that just shows the regality of the animal. You have to wait for these kind of shots. This is the wildebeest migration. Again, waited for 4 hours to migration to happen, and then click these pictures. Incremental weather. We saw this rainbow. We got this elephant as the subject, and a beautiful shot. These shots are taken early in the morning, very early in the morning before the sun rises. You have to lie down on the floor literally loud and take these shots. And I mean, these are very pleasing shots. Maybe morning, evening. Just give me 5 minutes more. So after wildlife, I do certain candid also, but wildlife interests me more. The street and candid is when you are walking around. I'll just show you some examples from Varanasi, where I keep visiting. This is the cliche shot which everybody takes probably of the Aarti at Asi Ghat, right? But this is, I'm just showing because it is cliche. There are other things that you have to photograph. For example, just lamping of the diyas, or the fire which is coming out from the diyas. I mean, it is artistic. If you want to click these kind of photographs, there is plenty of options. Somebody looking in the mirror and with a mustache, or two foreigners with huge shadows walking across, or this person who was collecting coins from the Ganges, or this elderly person, probably impoverished, quite impoverished, right? And he's praying to the Almighty, I don't know for what, salvation. This, a temple where 3 generations are probably standing. One is sitting and 2 are standing, and they are all paying their respect to the rising sun. Then finally this picture where 2 monks I could see, right? Monks were carrying cameras, right? And they were clicking pictures in Varanasi. These are the kind of shots that I try to get. And this lady amongst the foreigner probably with the sadhus. And this is a cool stuff. I mean, somebody sleeping, and you get a placard over there which speaks about the picture. I don't have to speak anything about this picture any longer. I also do macro and bird photography when I'm bored, when I'm sitting at home, or I don't want to go out. That's it, because that is in my backyard. I can do most of these pictures. And some of the bird photographs I can show you. These are the birds. The problem is that they're very small. This bird is just about 3 or 4 inches in size, and to click such a picture is difficult. Actually, bird photography is also very difficult, and that is one form of photography you can't do with your phone camera, because they are so fast. The birds fly so fast. You have to have a very high shutter speed for that. You just can't do it. Birds, bees, you can't do it. This kind of pictures you can never take with your mobile cameras. For example, this Baya Weaver, this was taken in Jaipur only, actually, in, I think, Marriott. There's a lot of Baya Weavers over there, and these pictures I had taken over here only. Or this is in Bharatpur. I do what is known as a focus stacking also. You can see these are very, very high definition images. These have been created by using almost 50 to 60 images fused into one. Focus stacking. That is why they are very high definition, and each image may be of about 2 to 3 GB in size. GB, right? Not MPs. And this is the kind of pictures, again, you will not see or you cannot take with a mobile, because the bee is just flying from one place to another. This is a bumblebee flying away, and you can see the sharpness. You can't see much over here, but it is a very, very sharp picture. So this is how it probably ends. Dr. Bali had given us a lot of shares. So I can tell my youngsters that I'm also going to give you something. Life is short, make memories, no regrets. What Sahir Ludhianvi had said many years ago. Just replace the word शायर with a cardiologist. Okay? मैं पल दो पल का शायर हूँ, पल दो पल मेरी कहानी है, पल दो पल मेरी हस्ती है, पल दो पल मेरी जवानी है. मुझसे पहले कितने शायर, बिफोर मी सो मेनी कार्डियोलॉजिस्ट हैव कम, आके चले गए, कुछ आहें भर के लौट गए, कुछ नगमे गा के चले गए. वो भी एक पल का किस्सा थे, मैं भी एक पल का किस्सा हूं. कल और आएंगे नगमों की खिलती कलियां चुनने वाले. मोर कार्डियोलॉजिस्ट आर गोइंग टू कम. मुझसे बेहतर कहने वाले, तुमसे बेहतर सुनने वाले. कल कोई मुझको याद करे, क्यों कोई मुझको याद करे. मसरूफ जमाना मेरे लिए क्यों वक्त अपना बर्बाद करे. मैं पल दो पल का शायर हूं, पल दो पल मेरी कहानी है. Right? It's a very short life, very short life. Enjoy it. I spent first half of my professional career saving arts. The second half, I want to follow my own heart. Thank you so much.
Thank you. It's wonderful, actually. Just like I am also interested in photography, but the only difference between you and me is you are a good photographer and I am a bad photographer.
Not at all, sir. Not
So
at all.
then I just wanted you to tell me whether you try multiple exposure photographs?
Yes, sir.
Multiple exposures are
Multiple
extremely interesting.
exposures. What do you mean by that? There are three different kinds of multiple exposures. One is in camera multiple exposures, right? The other is a focus bracketing, sir, and the third is an exposure bracketing.
Yeah, that's also a very interesting area. Thank you.
Yeah. Thank you very much.
Thank you, Sudhir sir. It was very. You have shown that cardiologists have second interests, and we should pursue our own hobbies and interests, and we should reduce our stress. That's most important. And now we can. I invite Dr. Bimit Kumar Jain sir to tell about Varsugar beyond GDMT, the Victoria and Victor trials.
स्पीकर है ना इसकी क्या जरूरत है मैंने सुना नहीं Good afternoon everybody. First of all, I must thank the organizers and Dr. Samit to give me an opportunity to interact with all of you in a very picturesque environment of the Pink City. For next couple of minutes, I'll be taking you through the journey of Varsiguat beyond GDMT, Victoria and Victor trials. Barmen in Germany, a small industrial town. 163 years ago, Friedrich Bayer in 1863 set up a small industry of aniline dyes. And then he diversified into the pharmaceutical industry. Later on, this small town also merged with the bigger towns and make the city of Wuppertal in Germany. And this has given us iconic compounds like aspirin, which was given more than 130 years ago. We are still using it. Acetaminophen, phenobarbital, heroin, rivaroxaban, and many more, including the Varisiguat, which we are going to discuss today. And this city is famous for the floating trams. One of the city's greatest attraction is the globally unique suspended monorail, upside down. We are all hanging there. And Max Follmann synthesized Varisiguat in 2010, and it was subjected to the clinical experience in Victoria trial in 2016 and got FDA approval in 2021. If we have a look at the deterioration of the LV function, when there is myocardial injury, it leads on to the death of the few cells, and the other cells also make a program to die. This puts a lot of increased ball stress and myocardial hypertrophy because of the secondary neurohormonal sympathetic stimulation and the renin-angiotensin-aldosterone system. To some extent, it's helpful, but further deterioration, further ongoing process produces deterioration of the LV function. And then heart also tries to compensate its own health with the secretion of the various natriuretic peptides. All these things, they produce vasospasm and spoil the health of the endothelium and also the organs various at large. Now, the sympathetic system secretes the hormones which acts on the receptors to make the vasospasm occur and reduces the blood supply to the various organs wherever the supply is there. Now, this hormones, the catecholamines or the adrenergic hormones, act through the adrenergic systems and then they stimulate the adenosine cyclase to produce cyclic AMP, which produces further actions. Now, for this discovery of the second messenger, Sutherland was awarded Nobel Prize in 1971 through the cyclic AMP pathway. We have got a parallel system also through which the natriuretic peptides act. They stimulate the particulate or the membrane-bound guanylyl cyclase and produce cyclic GMP, which carries out the vasodilatory action. And the endothelial health is important, and Fushcott knew that the endothelium is very important for the maintaining the blood supply to the different tissues, and it was difficult to isolate. You can stop the light, please. Okay, you could switch off the light. And the endothelial, but so he named it endothelial derived relaxation factor. The reason was because this is the only gaseous compound which is there in the entire body, which acts as the signal transduction. So gas is not very easy to understand, but that's how he isolated it, and he was awarded Nobel Prize in 1998 for the discovery of this signal molecule. And Viagra is also an extension of this molecule because it takes care of the cyclic GMP and reduces its degradation. Now, this is how it acts on the released from the endothelium, acts on the myocard, on the smooth muscle cell, and produces relaxation and improves the blood supply. Now, we got three compounds. One, the natriuretic peptides, which are acting on the guanylyl cyclase, the membrane bound. So, end product is the same, the cyclic GMP pathway, the GMP molecule. The second is the nitric oxide, which acts on the heme binding component of the soluble guanylyl cyclase. And this is how it acts, and end result is again the cyclic GMP. And third is the molecule we are discussing is the vericiguat, which acts on the cyclase domain and produces cyclic GMP. So all these three things, end result is the same. And one more thing which happens with the vericiguat is that it after this nitric oxide has really occurred, and the vericiguat has produced its action on the guanylyl cyclase, it produces the transformation in the guanylyl cyclase so that it becomes more sensitive to nitric oxide. So two actions of vericiguat: one, direct stimulation of vericiguat, the cyclic GMP production, and second is the transformation so that it becomes more sensitive to nitric oxide. So this is nitric oxide is very important. Ultimately, GMP is important to take care of health of the tissues as well as reducing the reactive oxygen molecules and reducing the fibrosis and remodeling of the heart. Now, all the molecules used in the treatment of congestive heart failure have been stolen from the other fields. Beta blockers from the control of the heart rate and blood pressure, the ACE inhibitor from the treatment of hypertension, MRAs from the diuretics, and the SGLT2 accidental discovery from the CVOT trial and for the treatment of diabetes. And vericiguat is the only molecule which has been synthesized for the treatment of congestive heart failure de novo. And this is an only molecule because all these things are the blockers. This is the only stimulant pathway of the body's mechanism called the guanylyl cyclase pathway. So all these are inhibitor, and vericiguat is the stimulant molecule. Now, heart failure is associated with very bad prognosis, comparable to some kinds of cancers. Now, the various risk factors lead on to the congestive heart failure, which may be asymptomatic to start with, and after a variable period of few months to years, it becomes a symptomatic one. And there are then pauses where the worsening of the heart failure events occur. The patient becomes more sick, and then even with the treatment, some amount of residual risk always remains. So this adds on to the injury to the heart, reduction of the functioning of the heart. Ultimately, it may require hospitalization for more longer period of time, intravenous drug, and even the mechanical circulatory devices, as well as the cardiac transplant. So this is how the heart failure progression is typically punctuated by repeated worsening of heart failure events. Now, what is heart failure event? I think one slide it's got overlap. Anyhow, the very squad was put to trial in 2016 when the Dangal movie was released, and it is the biggest grosser of the all-time Indian cinema with the earning of 2,200 crores. And the very squad. Sir, can you move it? Can you help me, please? So it's not moving now. Correct. So it has got a very catchy figure of the number of patients it had. It had 50 patients, that 5,050 patients, and the mean or median age was 67. The age of the one of the biggest financier or the richest person of Asia, that's Mukesh Ambani, and 64% of the patients were white. 23% female patient and 22% of the Asian population is there. And the high-risk patients were included. The worsening of heart failure patients were there. That those patients who have been hospitalized in the past 3 months constitutes about 67%. So easy to remember the figures. And then up to 17% was within 6 months of heart failure hospitalization. And less than 3 months of these patients had required intravenous diuretics. So that makes the population of these patients as high-risk individuals. And most of these patients, that's up to 60%, had only triple drug therapy because it was in 2016, the SGLT2 inhibitors were not there. So 60% of the patients were getting some kind of treatment from the GDMT, and the ejection fraction was less than 45%, and NYHA class 2 patients were again 60%, and 40% of the patients were class 3 and class 4, and the BNP levels were 1,000 to 60,000. Actually, there is no limit in this, but in the next trial they had a limit. So any amount of anti-pro-BNP was taken, and the GFR was more than 15 ml per minute. And the NYHA class 3 and 4 patients were 41. So that makes it very high-risk individuals, because as compared to the paradigm heart failure, which has 25% of these patients high risk, and the 32% of patients were in the DAPA-HF trial. And the BNP level was also quite high in these patients, to the tune of about 2,800 or so. And the drug treatment was given 2.5 milligrams for 2 weeks, and then another 2 weeks 5 milligram, and then rest of the 10.8 months this figure was 10 milligram per day. And look at the results. The results were great. There was reduction of the events by 1%, 2%, 3%, and 4%. 1% was the cardiovascular death, which was reduced. This is absolute number of figures. The 2% reduction in hospitalization, 3% of all-cause deaths and heart failure hospitalization for the secondary events, and 4% of the events per 100 patients years. So the relative number was quite high, that's more than 10%, which is statistically high. Now, at 16 weeks, the BNP starts coming down, and it is maintained throughout the treatment part. And fall of blood pressure, because it's a vasodilator, fall of blood pressure was very minimal, 1 to 2 millimeter of mercury. And the safety profile, they had got a very good safety profile: nausea, vomiting, symptomatic hypertension, patients requiring IV fluids, or patients changing over to the renal failure, high potassium, were not seen in this trial to a significant extent as compared to the placebo, and the syncopal episodes were just 4% as compared to 3.5% in the patients who had placebo. So 2021, 1 year after the javelin throws Olympic gold medal was won, the Victor trial was started. It was started on a different kind of patient. That Victor trial was in the patients who were relatively stable before the onset of the Victoria trial patients. So it was in the stable phase the Victor trial was conducted to see whether this was really helpful in those individuals or not. And look at the results. The results of heart failure hospitalization were neutral. No benefit as compared to the placebo, but mortality benefits great. More than 2% of this mortality benefit was there, which is significantly high, and all cause death was also low in this patient. And this was a puzzling finding by John McMurray. He says that I don't think we have seen another pharmacological treatment that reduces the death to a greater extent than the heart failure hospitalization. But then this was the truth. Then the cardiovascular mortality was reduced, all cause mortality was reduced, sudden cardiac death was reduced as compared to the heart failure hospitalization, which was not reduced. So maybe the cause could be that 2016 very few GDMT were there, 3%, and then we had introduction of SGLT2 inhibitor, which was getting in 60% of these patients. So that could be one of the reasons. Then domiciliary diuretics were also there, so that could reduce the results of hospitalization. Then one interesting thing is that the BNP levels 1000 to 6000, this drug helps. Beyond that, it is neutral or it may be harmful also. And this is also a very unique thing because the natriuretic peptides also act on the same pathway. The vericiguat also on the same pathway. So why increasing the level of BNP was not giving good results? So then the exploratory data analysis was done, which showed that the neutral primary endpoints were there, positive mortality benefit is there, reduction in total worsening of heart failure events, outpatient versus inpatient burden was reduced, total reduction in the heart failure events when both the trials were together, and consistent benefit across all the subgroups. And Fias Zened was also the investigator for RALS trial, emphasis trial. So he analyzed this exploratory data. And then Professor Javed Butler, who presented these trial results, both trials, Victor as well as Victoria, put together the combined results in 2025, that's last year. He showed that Verisquat significantly reduced the composite endpoints of cardiovascular mortality and heart failure hospitalization versus the placebo. Cardiovascular mortality came down, heart failure hospitalization came down, and Vericiguat was associated with significant reduction in all-cause mortality. So simple dosing pattern and beneficial effects of heart failure hospitalization, cardiovascular mortality, simple dosing, and the renal preservation is there in these high-risk patients. So easy to take this medicine is the Vericiguat, which has given a new lease of life to the patients of congestive heart failure, preserving their kidneys as well as their heart. And it is virtually going on top of the, after you have treated these patients with the GDMT, this still has got a role in the treatment of heart failure, producing the heart reduction in the hospitalization, worsening of heart failure, heart failure with reduced ejection fraction, cardiovascular death. Thank you, sir.
Thank you, sir, for this elucid presentation. Are there any questions from the House? Thank you, sir. We close this session. Oh, sir, please.
For in this group of patients, yes, sir. So there actually, if you see, the number of side effects were there, more than 25% of these patients, and the follow-up rate was about 12% or so. Some amount of patients definitely stop the medicines.
What, according to you, is the most troublesome side effect you came across in your practice?
So this is again the hypertension, and somehow the inability of these patients to tolerate, but the number is very small because it's a very innocuous kind of drug which is there.
I would like you to comment on my experience. One chap developed severe gastritis. We know many medicines and maybe all medicines produce bit of a gastric irritation, but this is so prominent it is continued. Do you think it is
Could have
because
been,
of
could have been, sir,
versicolor?
because these gastritis, as I showed in the picture also, it does have the features, but of course, the patients can vary from person to person, and personal experience also matters. So this could have happened. So this is described, gastritis is described with this drug.
Thank you, sir. We close this session and over to Dr. Bali, sir.
Not that much. After all the wonderful lectures we have in the morning, it's my great honor and a privilege to introduce, if I can say, the finest cardiologist this country has produced. And if you go decades back, when I joined PGI, we had 5 consultants, and like all cardiologists, they couldn't agree on anything. And the only thing they could agree on is the finest cardiologist which PGI has produced is Dr. Somaraju. I think it's a journey which is worth studying, more importantly, worth emulating. In the current era, it's very difficult to have role models. But if I have a role model, and I must confess I have not worked with him, I just followed his journey. He is the finest cardiologist in multiple ways. After PGI, he went to Nizam Institute and established the Institute Cardiology Department. In an era when it is difficult to have 1 or 2 or 3 cardiologists to go along with him, with us, he was able to set up a team of 25 cardiologists. Each one of them was a stalwart. And to have all the stalwarts together and mentor and lead them is what he was able to show. And then, as things go wrong, or for reasons, when he decided to leave Nizam Institute, 24 out of 25 left with you? 20 cardiologists, without asking a question, walked out with him. That shows the tremendous leadership quality he has. And then he went on to establish the Care Institute. And he showed that it's possible that in corporate world also, in a financially driven world also, where capitalism rules, it is possible to have an ethical and academic environment, research-oriented also. Till recently, and I'm sure till now also, he has time for research, starts his day very early, 5 a.m. He is in the hospital, first taking care of the research part, then teaching. Academics and research go along. And we talk a lot about our ex-president Kalam. But Dr. Raju, along with Kalam, was able to give us first Indian stent, Kalam Raju stent. And it showed that it's possible to do all these things: clinical excellence, research, academics, and give direction to the cardiology in the country. I have great respect and regard for you, sir. And I think we want to hear from you how this journey has been. And Dr. Raju will be speaking on moral art of medical research. Is that right, sir? No, newer. Please welcome with a standing ovation to the finest cardiologists in the region, country. All yours.
Mic ಇದೆನಾ?
एक सेकंड वो ला रहे हैं सर कॉलर में अभी ये कनेक्ट कर रहा हूँ.
Thank you, sir, Dr. Bali, for telling people more than I really deserved. And I'm not the finest cardiologist in the country. I'm one of the reasonably okay cardiologists, I must say. And I'll tell you a secret of whatever I could do. You know, you're not supposed to tell the secrets of your success. But I must tell you here, because it's a PGI group, I can tell. I surrounded myself with better people than myself. That's the reason why all those things happened. Thank you. Yeah. Okay. Can you hear me? Okay. So I'll take you to something slightly different, not PowerPoint presentations. It is more like a text. Years ago, in around 2017, I traveled to University of Berkeley, San Francisco for a talk on artificial intelligence in medicine. At the airport, actually, I showed my invitation from the university to the airport customs officer. He asked me a routine question. They roughly asked, "No, do you have anything to declare?" Then I said, "Nothing except my ignorance about artificial intelligence." So artificial intelligence was completely new to us that time, and I didn't know much about it. I said that to him. Then he said, he heard about it. He said, my ignorance. He called all his colleagues and so told them that's what he says. He has only ignorance. And all of them laughed and laughed. And then I asked them, is ignorance taxed in US? Then he said, no, it's not taxed. Ignorance is not taxed. Only knowledge and wisdom are taxed in America these days. So back then in 2007, I felt distant from medicine. It belonged to engineers, laboratories, and computer scientists, not to the bedside, not to the clinic. Today, the distance has collapsed. Artificial intelligence is no longer outside medicine. It's moving into diagnosis, monitoring, and everything we do. And it forces us to ask a deeper question about what all is happening around us. There is so much of advance in medicine from 1960, when we were medical students, to now. The medicine of that time could hardly predict what's happening now. So there's advances in technology, advances in molecular biology, genetics, whatnot. There's nothing that could not be done, both in diagnosis as well as management of patients. So medicine is not like other services. In technology, one may celebrate rapid iteration. In medicine, one deals with vulnerability, suffering, uncertainty, and trust. So the present-day medicine, in Thomas Saw's psychiatrist words, he said, when religion was strong and medicine was weak, men mistook magic for medicine. Now when science is strong and religion weak, men mistake medicine for magic now. So the expectations are so high. Society expects that medicine should do everything, and it will not only eliminate suffering, nobody even wants to die. So most of our corporate hospitals, we make more money out of dying patients than otherwise diseased patients. Do you agree or don't agree, sir? Okay. So, but medicine is not magic. Medicine is a science of uncertainty, as William Osler said long time ago. It's a judgment under pressure, compassion under limitation. So innovation in medicine cannot simply mean more knowledge. it must mean wiser knowledge. Over time, we came to believe that meaningful innovation in medicine passed through 3 stages. First, we prove that something is possible. Second, that it is accessible. Third, we use it to deliver compassion at scale. So, possibility, accessibility, compassion at scale. That is the moral arc of medical innovation. I won't take you too long about our studies we did at Nizam's Institute of Medical Sciences on balloon metalvalvoplasty and later stent. In 1985 and around that time, surgery for mitral stenosis used to be extremely common, rheumatic mitral stenosis. And then closed mitral commissurotomy and open commissurotomy in the West were the common procedures. They are well established. But surgery is surgery. So at that time, Professor Jolton Turi from Wayne State, Detroit, came to us and asked whether we could do a study on balloon mitral valvoplasty. Then compared to surgery. And actually, Dr. Ainoi, cardiologist in Japan, did in 1982 itself, did mitral valvoplasty. Around 4 patients he did, but rest of the world completely ignored it. And they never took it up, saying that it's a blind procedure and surgery is well established. Then when Dr. Turi came to India, he went to Delhi and also Bangalore to some of the centers there and asked them whether they want to do any study related to it. He wanted to be associated. So nobody showed interest. Then he came to us in Hyderabad in Nizam Institute of Medical Sciences. Professor Kakar Subra was our director. He came from US and joined us. And then he suggested this possibility of balloon dilatation of the mitral valve compared to surgery. So we wanted to, those were the days when surgeons were dominating cardiology. You are aware of it, many of you. At least older generation. They were not even talking to us. It's not easy. In All Indian Institute of Medical Sciences, surgeons and cardiologists never used to talk to each other. So then that was the time when we had a meeting with Professor Turi and his colleagues and our surgeons. We had a meeting together and wanted to do the study, a prospective randomized study comparing balloon valvoplasty with closed commissurotomy and open commissurotomy. After hearing this balloon dilatation, the surgeons walked out of the meeting. They were not willing. What do you do? So then I went to the director and informed him about, surgeons are not ready to do it. What should we do? Then the director said, nothing we can do when surgeons don't want to do. What is that you would have done, any of you? Okay, I'll tell you what we did. So we talked to our colleagues, a group of cardiologists as a team were working, and we made a decision and then informed the director that we are going to call surgeons from outside the institution. Then the surgeons came back. So that's how we could do the study. We did around 120 patients, total 60 patients for closed commissurotomy versus balloon and 60 per open commissurotomy in late 80s. And then these results were published in New England Journal of Medicine in 1994 and Circulation. And after these publications, the world at large looked at it more seriously and balloon mitral valvoplasty took over. Not only, this is the first time a prospective randomized study was done in valvular heart disease in the world of cardiology, actually. So then there was an editorial in New England Journal of Medicine also at that time. And then that is the beginning of structural interventions in structural heart disease that time. And after that, Dr. Cribier in France started doing aortic valves, balloon dilatation. And after that, now we know TAVRs and all this. That was the beginning actually to do catheter interventions for structural heart disease. So that was the story of that time. And we did cardiac catheterization and echocardiography evaluation, pre-procedure, randomize them, and 1 week later after the procedure, and 3 years later, and follow-up. And then the follow-up was 100%. You know why we could do that? It's not easy to get follow-up in those days. We used to send our own colleagues to get them, patients, and if some of them didn't want to come, then we used to send the police to get them. This what. So then there was only one death in the whole study. You know that death was a patient who was randomized to surgery, he committed suicide. So in other words, how much they didn't like surgery, it was obvious. Okay. Then incidentally, in late 80s, Professor Kalam, we met him. One of his colleagues was admitted with us with a complex cardiac arrhythmia, and he used to come to us and spend time. By his nature, he is very curious about everything. He used to come to the department, sit with us, and also watch our cardiac catheterizations and everything. Then he saw that is the time when we were doing, say, angioplasties we just started around 90s. And then, but there was no stent. And there used to be around 7 to 12% acute occlusions, emergency surgeries and all that. Then J&J and Cook's company came out with stents, but the cost of the stent was around, say, 75,000 in 1990. So when the cost of the stent is 75,000, hardly anyone could afford it. So that is the time when we told this to Dr. Kalam, when he came and saw that, he said, if a nation can build missiles that survive extreme heat and stress, why it can't build a biomedical implant for its citizens? Then we worked with DMRL and DMRD, and that's there was no internet those days and no knowledge of how anything happens that time. So we struggled, and the scientists at DMRL and DRDO struggled for 3 years or more and came out with a stent. And then the stent was available, but there was no animal laboratory in this country at that time. When we approached somebody in US, they were quoting thousands of dollars for the animal implantation. So what do? So then we decided to do it off ourselves. There was no animal lab, so we got some sheep and goats. And then we used to, around 30 to 40 of them, we used to raise them, and one cardiologist was posted to look after them actually that time. So then we have to implant the stent in them. So there was no animal laboratory. So same laboratory that we are using for patients at Medicity Hospital that time. In the middle of the night, around 12 o'clock, we used to take this animal and implant the stent. Then that's how we started off. So because daytime when you do, nobody will want to have cardiac catheterization in the same lab. So then that's how we started. But what happened was, it was not difficult to implant a stent in them because they have short left main and circumflex directly almost is in line with the catheter. It's easy to implant a stent in the circumflex. That's how we started off. Then, but what happened is, the first patient, after we implanted, everything went on well. We shifted the animal, and after an hour or two, suddenly it arrested. It died. So next 4 sheep also died. Similarly. And what do? So then we didn't know how to go about it further. Then we discussed amongst ourselves and then realized that when you are implanting a stent in a normal artery, there is nothing to hold it, unlike atherosclerotic material in a stenotic artery. So, in other words, stent is migrating. and getting clotted. So then we decided to oversize this stent and put it under high pressure. And when we start doing it, suppose vessel is 2.5, we used to do 3 or 3.5 inflation. Then it started working. After that, no animal died, and it worked all right. Then, first time when we got the stent ready to implant in human beings, we had to take the permission of the drug controller of India. When we asked them, they said, we have no system. We don't know what to do with your stent. So then, thanks to Dr. Kalam, we talked to them and said, you have to give a special permission. Then we started implanting them and it worked all right. Actually, recently, there was a patient, some time ago we did. 30 years later, the stent was still patent actually. So, now we come to the present situation, what we are going through in medicine now. So, now we know suddenly specialist knowledge could travel. We did in 2001, we did a private-public partnership for telemedicine and with Mahbubnagar Government Hospital, and it worked well. I won't take you into all those details except telling you. And now the present situation is we have advanced in biology, engineering, data science, behavioral science, artificial intelligence. These years we are now entering around AI in healthcare. We see artificial intelligence is everywhere now. And what do you hear about AI? One way of is looked at is that it will replace doctors. Another way is that it won't and it's not going to succeed. We may have to go back. So AI will not replace the physician, it may extend the physician. But it doesn't know how to care for patients. So we prefer not to think of AI only as artificial intelligence. We should think of it as augmented intention. Because technology amplifies whatever intention guides it. If the intention is efficiency alone, it may make medicine colder. But if the intention is compassion, the technology can help us detect earlier, reach further, and serve better. Not the automation of medicine, but the humanization of medicine at scale. But there is one more frontier we must confront now with all these advances happening now. We have advances in technology, molecular biology, genetics, whatnot. But many of us, at least our generation, we took up to medicine. At the time when we entered medicine, you know how we took up medicine? We have only two choices. If you are a good student, we took either engineering or medicine. Those of us who are not good in mathematics entered medicine. If you are good at mathematics, you went to engineering. Is it true or not true? That was true. Now, even mathematics is not enough. Biology is not enough. We need chemistry. Chemistry is biology now. We need physics. We need information technology, whatnot. Molecular biology. So, in other words, today's requirement for medical education is different. So, medical education now has to be transformed. So, we'll never transform. There is a famous saying by Edward Deming, a quality engineer from US. He said, we'll never transform the prevailing system of management without transforming our prevailing system of education. They are the same system. So, that's the reason why you have to re-look at our medical education. So, we must bring back the bedside method of learning. And unless bedside method of learning is brought back to medicine, medicine is going to lose the public trust. If you want the future of medicine to be wiser, it's not merely smarter, then we must alter medical education. So one of the ideas that is considered and we are talking about it in the morning is we must for us to be educated as doctors today or medical students today, the single medical college model or isolated medical university which doesn't look at anything outside of medicine or biology is not enough. We must move to the 5-pillar model, namely a hospital, a university, an institute of technology, a public health foundation, an information and software organization, all of them connected together, not in silos. So one integrated ecosystem. Why does this matter? Because doctor of the future cannot only be clinically trained, the engineer of the future cannot be clinically blind, public health cannot remain detached from bedside reality, a software cannot remain detached from human consequence. The future professional must be clinically grounded, technologically literate, ethically awake, socially responsible. This is not dilution, this is convergence. Today, many hospitals say they have EMR. How many places EMR is working well? They say it's working very well, but is it true? Electronic medical records. So many of us don't even know how to deal with computers. And maybe present generation may be slightly better, but they are not trained into it. So in other words, for us to be able to, now medicine is all data, all information. So unless we are trained into it, we will not be able to deliver right type of care to patients. But it's not easy for us to be educated again. So we need to take the help of existing information technology institutions. So the future doctors will be trained in this situation of university, information technology, and all other areas. You may have doctors of medicine, as many of us are, doctor of science of medicine, technology of medicine, public health of medicine, information technology, whatnot. So I will take you to something more. In other words, medical education has to be reinvented, redesigned, where we need to be trained in science, technology, and molecular biology, genetics, information technology, and social sciences too. You know, Rodolphe Virchow, all of you heard, father of modern pathology. You know what he said in 1848? In Silesia, there was an epidemic of typhus that time. And having seen it from his own place, he said, medicine is a social science and politics is nothing more than medicine on a grand scale. Actually, he became a member of parliament later, actually. And Michael Marmot of University College London reminded us that in our time, that health is shaped not only in hospitals, but in homes, schools, streets, workplaces, and social conditions in which we live. He brought out the idea of social determinants of health. So in other words, health is not decided, outcome of health, people's health is not decided by hospitals. It is outside hospitals. Only when they get ill, they go to hospitals. So if you truly care about the future of medicine, you must think beyond devices, beyond procedures, beyond algorithms, beyond institutions working in isolation. So in other words, the present system of medicine is too important to be left alone to doctors, and science is too important to be left alone to scientists. I won't say politics is too important to be left alone to politicians, because you can't say that. The future of medicine will belong to those who can unite science with justice, innovation and access, and intelligence with compassion. Because the final question is not, can we build powerful technology? The final question is, can we build more humane medicine and with technology? Politics has medicine on a grand scale. Fewer families fall into poverty because of illness if you do that. Fewer citizens need tertiary care, rescue, because primary prevention is succeeded, and primordial prevention, if you take care of social determinants of health. And the gradient between the privileged and the poor begins to narrow. That's where political will become decisive. Because in the end, the deepest question is not how many diseases can the system treat. It is how many diseases did the political system or the government has the wisdom and courage to prevent by improving the social determinants of health. So Michelangelo You know what he said? The greater, whether all this is possible or not, I am not sure. But we should make a beginning, and we should not give up on it. So you know what he said? The greater danger for most of us is not that our aim is too high and we miss it, but it's too low and we reach it. The too low model is present practice of medicine, corporatization of medicine, and then money-minded medicine. We should come out of it. Thank you. It is in this connection we are talking about this PGI group. Can we make a beginning of doctors or healthcare professionals beyond hospital borders? I am not saying overnight we'll put it, but you can still start off. You need not be in the same city or same town. Across the country, when all of us are there, let us connect ourselves in such a way, at least we take a second opinion to begin with. So a lot of patients are going through unnecessary tests, unnecessary procedures today. Most of them need second opinion. So an honest second opinion is the best thing that can happen to medicine. Whether we can start off, please discuss. Thank you.
Sir, we do have one such group which is WhatsApp active, and we would like that you be active on that group. So it's a WhatsApp group. We post our CNAs, we post our ECGs, we post our clinical concerns, and I think we get a reply within minutes. Somebody would reply it, and if you join, probably we'll have your expertise also and your wisdom with us.
Actually, this idea some time ago, we said before, we thought we may not do. But with the presently connected systems, I think it's very easy. I think we should start it off.
Sir. And we do have, sir, on every fourth Friday from 8 o'clock in the night, in the evening, we have a class which is taken by one of the masters, and only PGI's cardiologists attend it.
Yeah.
So that is also ongoing.
I think we'll start off, and the idea is to move towards the idea of an association of doctors without hospital borders. Thank you.
Thank you, sir, for a wonderful talk, putting in perspective the current medical practice and giving us thought about how to go forward in a comprehensive healthcare for the country and for the larger world. Very subtly highlighting the drawbacks of current medicine and suggesting means also. I'm sure under your stewardship, sir, medicine will move progress forward, and the limitation we have will probably go down. And I feel PGI can do that. Doctors Without Borders is one very good thing which you can, there would be logistic problem, registration and other things, but that's a very nice way to make a beginning. And I'm sure all the PGIs will come on board, all PGI cardiologists will come on board to take medicine forward. It is time that PGI took the lead at the national level and weeded out the problem which have crept in the medical profession. Dr. Raju, please.
Just wanted to just remind ourselves, those of you who are senior, don't retire. Take up the model of teaching, mentoring, and role modeling across organizations. You can do it online, or you can even invite and go to institutions. So in other words, we'll also suggest to the political system, develop a public-private partnership model for this. That is the idea. Thank you.
Thank you, sir.
So there's a little change in the program. We would like to have a group photograph now. 10 minutes from now, we'll be gathering in the hotel lobby for the group photograph, because 2 of our colleagues are leaving slightly earlier. So just for a group photograph.
asked so many questions. And the diagnosis was made only after good history taking and clinical findings, and the history was analyzed in a great detail. In fact, he said that no investigation should be ordered till you, analyze the history and clinical findings. And at the end of our presentation of clinical findings, he said, okay, now you are given only one choice, either ECG or X-ray. What do you want? I think you can recollect that. Because he did not believe in those so many investigations. Like nowadays you're practicing cardiology, we just take so many investigations. He just wanted a single response, whether it was ECG or X-ray. And then whatever he wanted, he gave us, okay, now your diagnosis is final or not. And yes, it led to the final diagnosis just by seeing the ECG or X-ray correspondingly. This was much before advent of echo. Everybody remembered that it was only in late 90s that we got our echo machine. Before that, based on his clinical examination and history taking, all patients were, underwent cath, and most of the time his findings were really nice. So what we said that he could hear through the chest wall. Some vignettes about his life and his character, and many of us you will remember fondly. Number one was his punctuality. Dr. Khatri was the first person to enter the pickings of the PGI campus. He was there at time, and you can always, if your watch was going wrong, you can always correct it according to his arrival. Not only that, the moment he entered a classroom, he saw to it that the door was closed and even seniors might be left out. In case some people, they were able to squeeze in, then he was always mutter in a low voice, it's an insult to people who come on time. And it went 2-3 times till everybody got the message. Then he spent around 2 years in Hammersmith, apart from his Edinburgh fellowship. And the British mannerism was so deeply entrenched in him that the way of talking, the way of dealing with students, the Britishers are never direct in insulting you. They have a tendency of circumlocution. So I'll give you an example, because I had done something wrong. So next day I went to Dr. Khatri and wished him good morning. So he said, okay, how is the weather? So I said, fine, it's fine, the weather is fine. So then subsequently I talked to a senior, that Khatri Sahab said, how is the weather? So he told me that you have done something wrong and go and apologize without any condition. So next day I went and said, I'm sorry for my fault. So that was Dr. Khatri, never ever insulted you or directly. And he was a man of few words, but those words were very profound. if you, so for example, if he said, Dr. Saab, auscultate the mitral area and tell me about S1. Okay. And by mistake, you put the stethoscope on the pulmonary area. He got laid off. And again, suppose you corrected a mistake and you said, sir, S1 is loud, S2 is this, and there is a murmur. S1 in mitral area. Nothing more, nothing less. He was so laconic in his attitude. Then another interesting point is that it's a tradition that when the teacher walked in, all the students stood up. So the moment Dr. Khatri entered, he started, with disdain, he said, if you have respect in your minds, do not stand. The respect comes with the mind, not with your actions. That was his tendency to poo-poo the traditions. Again, he was very honest and man of integrity. If you are beating about the bush, if he asked you any question, if you knew the answer, it's okay. Even if you admitted that you don't know the answer, then it was fine with him. The moment you gave a vague answer, then Dr. Khatri had a very favorite spot on the ceiling where he looked for eternity. And finally, when you said sorry, then he looked down. So he said, be straightforward. If you don't know it, don't know it. I mean, at least admit it. Another interesting point is that when we went from Rajasthan, it's a custom to, visit teachers' homes and pay your respect on some festivals. So I think 2 or 3 of our mustered up the courage, went to his home on Diwali. So he himself opened the door and he said, I mean in Hindi, कि बताइए आप क्या काम है? So we are flustered because here we are offered sweets, you touch the feet and take the blessings. So all 3 of us trudged back to PGI and vowed never to visit him again. Another thing is, yes, as I said, honesty, honesty, honesty. If you remember that we had multiple chambers in the wards, there were not a single ward. So every chamber had 5 to 6 patients. So Dr. Khatri was taking a round and he told a doctor, JR, Dr. Pinto, that, okay, get the ECG done for this fellow. And he moved on to the next chamber. Dr. Pinto immediately followed him, the entourage. So he asked Dr. Pinto, was the ECG done? Yes, sir, ho gaya. Dr. Khatri went back and saw that the technician has just arrived and was putting the leads. And Dr. Khatri remembered this. He scolded him. And from thereafter, Dr. Pinto became a household name. So whenever Dr. Khatri saw us that probably we are lying, he will poke us in the ribs and saying, you are Dr. Pinto, you are acting like Dr. Pinto. So till Dr. Pinto remained in PGI, Dr. Khatri never looked him into his eyes and he was a liar. Then another interesting point is that, initially PGI, they had their MDs taking up all the super specialty seats. Very few people from outside were able to get inside PGI. It's later on when probably from our batch, all those Bangladeshi and Rohingyas started entering PGI. So, but Dr. Khatri had a very special thing that whenever you asked questions, and we were not able to answer, then he always said, "Arey, ye Patiala, Ludhiana, Jaipur se aa jate hai." So he also always wanted that PGI should remain sacrosanct for PGI things. So this is just an image where he, wishing those ships away. He does not want them to land on PGI. Another thing is that he was frugal in his very habits. And he was so oblivious of what is going on in the world. I mean, he was so simple man. So once he called us and he said, Dr. Saab, yesterday a student of ours has come. He was so hardworking, has done very well in life. And I said, what happened? He has got 2 cars. Remember that Dr. Khatri rode on an Lambretta. And he was astonished that a man can do so well in life that he can afford 2 cars. So that was a lesson for us. And also a lesson to how simple that man is. And probably few of us remember that Dr. Khatri was in charge of the rota, whether it's leave, whether it's your classes, whatever. And asking him for leave was a really tough task. I've just named it King Bruce, because you had to try again and again. If you remember the story of King Bruce and the spider. So he had to approach him several times before he gave us leave. So one interesting thing is, one of our seniors, he went and said that my wife is about to deliver the next day. So I want to leave. So Dr. Khatri had a smirk on his face and he said, well, Dr. Saab, you had already done it, what was to be done. Now you are not required. So just let us pay tribute to this man. Today we pay tribute to a mentor who believed that discipline was the foundation of success and excellence should be achieved through consistency, integrity and hard work, what were required at PG at that time. So the values instilled continue to guide us, and his legacy lives on in the students he shaped. Thank you. Dr. Somaraju also has to say a few words about Dr. Khatri. Welcome.
Can you take this?
Thank you.
I'll share with you some aspects of that. One angle of Dr. Khatri is already pointed out, only one angle. Can you see that? This is in around 1975. CT ward. It's called CT ward, no? Even now it's called CT ward? Okay. Cardiology, cardiac surgery ward. And Dr. Khatri around 9 o'clock in the morning, he comes for a round. And MD residents were there, and I was a senior resident in cardiology that time, doing my DM. So then that Khatri, as you already pointed out, is a great teacher, very critical and very abusive, and very unpleasant also in the rounds. Any of you worked with him? Okay, you remember. So always meant well. Okay, I'll tell you, one of the days, mornings, the round started off. So then he keeps asking you questions. Do you examine the patient? He was asking questions related to atrial fibrillation, mitral stenosis. Can you make out, say, a patient with complete heart block? He wants one of us to be able to make out irregular Cannon waves, and none of us answer him. Then, after 4 or 5 beds, none of us are answering to him, MD students or me, and then he says, "Where are you a gift to us from? Where are you a gift to us from?" Just now he said, he never liked people outside PGI join PGI. So some of us were all over the country we used to come. Then again, after saying that, he moves on, and then again he doesn't get any answers. Then he got very angry and said, "Aap sab gadhe hain." Did anyone who hear that those days? When you say it, "Aap sab gadhe hain" these days, today in schools they will send you to jail. Then we never minded it. Then one any of you remember Nitin Malhotra, Claire? Claire is here? Oh, Claire is not there. Okay. So Nitin Malhotra was one of the MD residents. You know what he said? "Aapke bacche hain, sir," he said. So it is. Then Khatri, he doesn't laugh. He said, "You have a good sense of humor, but no brains." Now I am just repeating what happened. Actually, I didn't add anything here. Okay. It used to be tough to take holiday or leave from him, as already pointed out earlier. Then one of the days, I was not feeling well. Then you hardly ever absented yourself in PGI those days as a resident. Then we used to say, the only time a resident doesn't come in time to the ward in PGI is when he died. So it is that tough all over. Then, so I wrote a letter. One day I was not feeling well. I wrote a letter to Professor Wahi. "Respected Professor Wahi, kindly grant me leave for today as I am suffering from Dr. Khatri. Acute Khatritis," I wrote, thanking you sincerely. Then Professor Wahi also used to suffer from him. So he liked that letter and he showed to everybody actually. So there are more, but I leave it here. Thank you.
I think certain things stay with us throughout life. And as you very rightly heard, Dr. Khatri had very strong likes and dislikes. And I was at the wrong end of Dr. Khatri. And it so happened that I was number 3 in the cath lab. And I was presenting data in the hemodynamic round. And those were the days with number 3 would present the data and analyze it. It was a patient who had a shunt lesion, and we were evaluating pulmonary artery hypertension, his reversibility, and other things. So all the consultants were sitting in the front chairs. We had Dr. Wahi, we had Dr. Bidwai, Dr. Sapru, Dr. Anand was at that time, and Dr. Khatri was also there. So I presented the calculation. QP was calculated. This is the body surface area. This was the hemoglobin, and this is saturation, and the QP was so much, and QS was so much. And Dr. Bidwai asked me, how did you calculate a certain thing? So I was trying to answer him. And then Dr. Anand asked me something, how did you take the sample? How many samples you took from the pulmonary artery, and how many you took from the SVC, and all that thing. So I tried to answer him. And then Dr. Khatri asked me, how is the dissolved oxygen? Where is the dissolved oxygen, and how did you calculate the circulating oxygen? That also. So by that time, I was a little flustered. So all 3 asked in that sequence. And I had not calculated the dissolved oxygen. So I said, let me answer Dr. Khatri first. So this was the tone I spoke in. And for a few seconds, there was total silence in the room. And I didn't realize that I had done something wrong. And then for the next 2 years, Dr. Khatri never talked to me. I apologized. I went to his room. After I was told that I had done, a Herculean mistake by raising a voice, but he was unexcusing, unrepresenting. And I was in the doghouse for almost 2 years. And then I became faculty. Even in the faculty, he would not talk to me. And the only time, which was unfortunate, he had a disease, pulmonary hypertension, and blood had to be tested for INR and all that. And one day he told us that he would give his cath patients to different people to do, but he would not give it to me. Okay. Anybody, Jagmohan would do the cases, somebody else would do the cases, but no cases for Bali. One day he said to me that, there is a patient who has a DRV, there's a pulmonary hypertension. Can you do the cath for me? I said, sure, sir, it will be an honor to do the cath for you. So this was a 20-year-old male, had a DRV pulmonary hypertension. We did the cath, finished by about 5:30 or 6. And at 6, I rang him up. He was sitting in his room. And I told him, sir, these are the findings, this is the saturation. And he just said, and we lost him on that night. So very tragic loss, but a great man, never compromised on principle. And he would say, one of us faculty member is like this. He is not Dr. Bidwai, but I won't tell you his name. He is not Dr. Anand, I won't tell you his name. He is not Dr. Sapru, I won't tell his name. So very innocent individual and dedicated to the profession. His 25 or 26 classes for MD were sought out by every MD resident. A single VPC is to be discussed, couplets are to be discussed, origin of those VPCs are to be discussed. That was a systematic manner in which he taught. A great teacher, my tributes to him. Thank you.
Deserve this to be heard. In fact, Khatriyology is a term coined by many people. He hated, you know whom, I will not mention his name. He hated him to the core. But when that gentleman passed away, Khatri attended his funeral. And I was there. As usual, I was never afraid of telling anything to anybody. I asked him, "You hated him so much. Why did you attend his funeral?" You know what he taught me? That I am going to carry it till my death. He said, "Death is a great equalizer. However much you hate, respect death." That's what he taught me. If you go back and think about our own culture, death is a certain equalizer. So, in addition to all his eccentricities, the gentleman is also a great philosopher, and he taught me that thing in my life, in addition to Khatriyology. May God bless him.
So carrying on the same momentum, I would request Dr. Vijay Pathak to come.
So while Dr. Pathak is coming, sir, I'll remind Dr. Meera Raoji that he has promised that he'll collect those anecdotes, write them down, and give us a book called Khatriyology. Dr. Meera ji.
Thanks. So, I will
You
have a
promised
very
that you'll
brief.
give us that book, Khatriyology. You'll write down the anecdotes and give.
No, I also joined when Dr. Sapru sir was the head of department. He was an additional professor, and as I collected the information, he trained in UK. His sense was medical sciences, human behavior, and social architecture. He had about 88 clinical papers and write-ups to himself. He's 90 years plus now, and a giant in his own time, and a teacher par excellence. But he was stern and astute. He had impeccable hold on languages. In fact, he has impeccable hold on languages. A firm yet gentle reformer, even for rebels like me. Not easily accessible, as in my days of experience. One who taught us life as a clinician and a gentleman by his own regimentation, lifestyle, no nonsense, and ultimately of benevolence. How I saw the regimentation was, for us, he was an example to follow in this manner and learn. He'd be there 5 minutes before the time of class. There were 3 classes every week for us residents in the seminar room. And he would be there 5 minutes before the time, before 8 o'clock, and be seated on the first chair, entering chair. That taught us to, it was difficult. Once he had been sitting there, it was difficult to get late and then yet enter. Because I was told that one of our, again, additional professors of those times came 2 minutes late, and he saw Sapru sir sitting on the chair at the entrance, and then he winced and simply went away. He went back and he wrote an application that he was on leave. I will not name him. I do not name him because fortunately he is not here. Otherwise, I could have been asked to stand up and stand on a chair mentioning his name. That's not proper. So, but then, hence we were taught the hard way that position or no position, it does not matter beyond time. That was, and the rank was irrespective in that manner. His lifestyle has been like he always was immaculately dressed, always. He was fair, well shaven every single day. So that was also a part of regimentation. Occasional friendly smile for the residents, at least who still had not passed out. Would always come before, even during winters, before time, and would always leave after the hospital time. Generally, when in conversation, he was quite low in volume, but with a stern voice. He was no nonsense taken, because in the OPDs, many times when we went, when obviously we were in the OPDs posted there, and if there was a case, he allowed the resident to present the case, and he heard patiently in the OPD with a mug of tea in his hand, which was quite frequent during those times in the class. And the principle was provisional diagnosis and the reasons for the diagnosis as a resident. Wayward presentations were taken with a scowl and then liberal scolding, which enabled us to learn and stick to proper, precise history and clinical findings that made us better than what we were. Ward rounds and case presentations in the wards were done in a way that built us stout in clinical cares. Any liberties taken, this was important, because any liberties taken by us residents in reference calls, and those days reference calls were noted down, and if reference were not seen by the resident on call, they were officially noticed to the head. So any liberties taken by us residents in reference calls, either not seeing the patient, not seeing in time, or evaluating properly, or misbehaving with the staff there, we were beckoned to see the HOD, that means Professor Sapru sir, in his chamber. His PA used to come up and say smilingly, Sahab has called you up pronto for a cup of tea. A cup of tea did not mean a cup of tea at all. I mean, I never saw a cup of tea in his room, but I had a profound scolding. So this was meant to be like, wear your pants and belts tight, lest you should be stripped. But not literally, but yes, he was very strict and stern in that manner. Even in the exams, when an examiner said, Dr. Saab, this resident is weak, should he be passed? He had a part of Punjabi also. He was very good in languages, multiple languages. In his Punjabi, he'd say, "O ji, jo tenu changa lage karo, mainu ki farak panda hai." That means the resident would fail. And so we residents stayed back to appear the next time, be prepared better. I did that thrice. So I passed in the third time. But he was extremely humane. That's in the last, I can say, because he was very strict during classes and presentations. But when we needed his backup, he was very humane. Because that's my own realization. That's why I remember him very fondly, despite whatever experience I had. But that those two failures were not because of him. They were my own, shortcomings. So my mother got quite unwell those days, and 6 weeks after joining PGI as a DM senior resident, so I came home and found that she was quite unwell. I was there for a few days and she didn't get well. So I got back, and then I went away without AWOL, what is called away without leave, that's the military jargon. AWOL, nearly for 2 months. I went away for 2 months, and I was in deep depression because I could not see her well. She was not getting better. One day I came back huddling to my duty and wrote down my resignation, and I gave it to sir. I met him personally in his office, and I said, sir, I'm resigning. Let me go. He said, why you want to go? I said, my mother is not well. And since there was nobody to back her, look after her, I would rather go back home and look after her. He said, he took my application letter. I remember it very, very vividly. He took up my application letter and put it in his desk drawer. He said, you take as long a leave as you like, and as your mother needs. You, if delayed, may appear 6 months later or 1 year later, but if you leave now, I no, you will never get cardiology again. So you better leave this application. I will not forward it to the principal, whatever. And he was quite correct, because I could sense it that it was very difficult for me to get back into that training again. It was only thus that I am here, having attained my academics, DM cardiology. But one thing also, additionally, what we learned, and me and Rajiv both, we had the same pattern even when we in SMS we were there for years together. We had the same way of evaluating or working up and backing up the patient, or working on the. That was all his grant. He was indeed a great discipliner also. My regards to him. Thank you.
It was a really heart-touching story, and so many memories are there with all of us. And in that same series, I would request Dr. Rajiv Bagata sir to come and share.
I will share two non-cardiological characteristics of Professor Sapru. One, even when there are 100 patients waiting outside the consultation room, he used to patiently hear the patient complaints and all. That is one aspect I learned from him. Listen to the patient, listen to the patient, listen to the patient. That gives you half the diagnosis. Second thing, another thing I picked up from him, non-cardiological again, never to sign on an unfilled form. Everybody used to go and ask for form. We all come across such things in our lives. Patients come asking for certificates to be signed, reimbursement bills to be signed and all. I myself went saying that, sir, my 2 दिन leave में था, उसके लिए sign कर दो, just to save time. But he would never sign on a black form. He says, Doctor साहब, वो लिख के लाइए, हम कर देंगे.
I will just add that he used to listen to the patient very patiently, but you needed to have a lot of patience to listen to him also. I tell you, so you give him ECG, sir, what is this? Then he will take a lot of time. मेरे को लगता है मैं यार कुछ पंगा तो नहीं ले लिया, गलत तो नहीं पूछ लिया. He will take a lot of time to answer that question.
First of all, I would like to say good wishes from Dr. Sapru. He's healthy and he's doing very fine and he's in pristine health. He mentioned about ECG. About ECG, he will order yards of ECG. You know, there is one ectopic and he would say, lamba ECG chahiye. 3 मीटर में दूसरा VPC नहीं आया और लंबा चाहिए. So that will be made into a roll and kept on the table and stay there. And second thing is, when he's taking a round and somewhere he would lose what is happening around, and you're waiting that Dr. Sapru is ask some question, maybe your answer was wrong, and then he will say, that cow going down is looking nice. So the whole discussion is gone. So whatever question he had asked or answer you had given, so that is gone. So he had a philosophical sting, which he still carries, very meticulous and a great person. But as Dr. Claire said, difficult to be his junior.
So, good evening.
continuing in the same vein, I'm sure most of us have lot many experiences where PGI alumni or PGI itself has helped us to shape our careers and shape our lives. You must be having so many instances in your life. How I see the PGIites handholding their own fellow fraternity persons. In next few minutes, I'll be sharing a few experiences and instances which have really helped me in building my career. So way back in 1990s, early 1990s, twice in a year, trains reaching the Chandigarh railway station would be loaded with passengers traveling from Andhra Pradesh. Young boys wearing sandals and at the most full sleeve shirt in the biting cold in North India would get down and reach PGI hostels in the safe assurances of their seniors who were already there, either working as a PG or pursuing their postdoctoral courses. The young aspirants would be nervously sifting through their last-minute preparations for the entrance exam to be held the next day, their non-academic needs, dinner, etc., being securely taken care of by their predecessors from Andhra Pradesh. With no such preceding cardiology senior to guide me during the course of DM entrance examination in 1992, I had taken the written test. And surprisingly, I was called for the practical examination. Amit Mathur, who was a non-DM resident in gastroenterology, took me the night before the test to meet the gregarious, the popular Saibal Kar, who was probably exam going at that time. Walking through the brick latticed corridor of ODH, I was amusingly comforted by Saibal, who popped in a few patent and predictable PGI questions and their typical answers. Half confused and still very shaky, I did appear for the interview and left for Delhi soon after. I was undoubtedly sure that however well I may perform in the practical test, it would not be enough to make up for the yawning gap left by my theory marks between the second and fourth ranker, which was me. And then the impossible happened. When the result was announced the next morning in PGI auditorium, sorry, the one slide. When the result was announced in the PGI auditorium the next morning by the director, not only was I missing, but also was missing the third ranker, who had also probably left Chandigarh by that time, because he was also not sure that he would be able to get through the practical exams. Amit Mathur, who was in the auditorium at that time, swung into action immediately. With no mobiles in those days, he frantically made calls on landline to Jaipur to my father, where he was directed to call me in Delhi and asked me to come to Chandigarh instantly. In no time, we were driving to Chandigarh on that sultry, hot July afternoon in our beige-colored Maruti 800. And by 6 p.m., we were standing in front of the steps of the Karan block. Amit accompanied me in shorts, and we were pleading our case to the director. Ably supported by the resilient registrar, Mr. O.P. Sharda. I think most of us will be remembering him. O.P. Sharda was a very resilient, a very tough registrar at that time. My admission was through. That's what PGI handholding is, when a non-DM resident helps you in your need of hour. What had started as an awe-inspiring introduction to my seniors on the night before the practical exam was to have a lifelong bonding. Studies and work had started in the right earnest. In that stifling air, there were moments of light-hearted interactions, some dance and music. There at the back, you can see me and Dr. Pathak dancing when we had all black hair, and emotional send-off to dear Saibal. Next slide, please. Yeah. So this is a very historical photograph where Saibal is arranging for his own send-off in the basement of the Karan block. And there I am standing, just trying to stand in front, sozzle all through. And the whole night long, we danced and danced and danced to the tunes of songs like Tu Mere Samne, Rosa Jane Man. And soon after, Saibal left off for us senior. After that, Saibal left off to Australia for interventional cardiology fellowship. Eventually, 2 years down the line, 4 of us appeared in the DM exam, but flunked, giving 100% failure rate. The 3 other were Dr. Surya Prakash Rao, who could not make it today, Dr. Kabardi, and Dr. Grewal. So all 4 of us flunked. Some teachers would jokingly comment on our distinct honor of giving 100% result. But in those times, it was our seniors and some junior faculty members who helped us to tide over those dismal days, always encouraging us to keep our heads high and our chins up. Ultimately, we skated through, and our battle-scarred batch soon would find the air to be fizzier, the grass to be greener, the teachers to be more helpful to us. The red gulmohar, next. The red gulmohar, the yellow amaltas, and the mauve trees lining the boulevards of Chandigarh were being noticed for the first time. And for the first time, I could catch an appreciating glint in the eyes of our teachers for us. So that went me to play tennis in the lazy afternoons on the unused cement courts in PGI. This was more to allay my worries about my future uncertainties. And with that motley bunch of players, there was one Dr. Shyam Thungan. Next, please. He used to come to play tennis with me. He had just returned from Australia for a 1 year after 1 year fellowship in cardiovascular surgery, and he was a very upcoming star surgeon. One evening, when we were catching our breath after a game, he dropped an unexpected invitation to me. Dr. Rajiv, would you like to go to Australia for a fellowship? Saibal gave a call last night and asked me to talk to you about that. I pinched myself. Was it really true? The farthest place till then I had traveled was from Jaipur to Chandigarh. When Indian cricket team used to go to visit Australia on the national duty, the pictures of merry-making crowds in the stadia and the seagulls dotting the cavernous Australian stadia, they had left an impression of utopia that Australia was on my immature mind. And here I was made to dream that I can visit Australia. For the next 2 months, Dr. Shyam would help me with writing letters and applications to the Epworth Hospital, Melbourne. And Saibal fixing up a telephonic interview with Ron, the director of Epworth Hospital. While assisting Ron in one of the angioplasties, Ron asked Saibal, "You know Rajiv? He's from your institute. What do you think of him?" "Ron, he's better than me." Spontaneous came Saibal's reply. "That's a PGI senior holding a junior along." Few months later, I stepped on the Australian soil and was drafted into the foreign land financially, emotionally, and professionally. Cut to 2022. My labor of love, well played, From Here to Eternity, a book authored by me, was to be published and was ready for launch at the prestigious Jaipur Literature Festival. Frantically looking for a chief guest and an accomplished name to write the foreword to the book, I approached Dr. H.K. Bali for help. Help there was. Almost instantly, he suggested the name of the Olympian and world champion, Mr. Abhinav Bandra, for the job. The book launch would not have reached the immense spotlight it got had it not been for the gracious help by Dr. Bali. So this is the picture of the book launch, which was launched in the Jaipur Literature Festival. And finally, before I end, my daughter, who has just finished her DM in cardiology, was to go to EuroPCR for her paper presentation. She wanted to stay back for a week beyond the conference to visit the Institute of Cardiology in Paris. Being aware that Dr. Ramesh, can you have the next slide? Dr. Ramesh had been a fellow there, I turned to him for help, and without any hesitation. Immediately, he got into action and sharp came the required permission. What binds us together? Is it sharing of tough duties? Sultry, hot and freezing Chandigarh? The shared fears of the faculty of the work ethics, or the work ethics inculcated deeply by the PGI culture? A combination of these feelings, perhaps. But once a PGite, always a PGite. Thank you. Thank you. There may be so many instances which I can keep on narrating, But I think because of time, I'm going to stop now. Thank you.
Next, I would like to invite Dr. T.S. Clare, sir, for his talk. And after this talk, we will have some special session to be hosted by Kapil Bhargav, sir, which will be a group discussion between 4 generations of PGI. For that, we will require 5 minutes of this hall to be vacant. Thank you.
Friends, I think where is Raju? Raju has disappeared. Am I right? Raju is here. Okay. So Raju is perhaps the only person who is senior to me, and he was my registrar, and I must admit that I took a lot of inspiration from him, because Raju was the only man in the department to say spade is spade. I say, ye banda sahi hai yaar. So we should follow him. So Raju, great. You know, I have been doing the same thing. So you lose a lot of people. You don't get so many friends if you are straight, but that's what it is. So anyway, my talk is not really about PGI, but I want to just convey that over the years, what we have seen, what I have seen, starting from even Medical College Patiala to PGI to out of India, UK, back to Delhi. It's a pity to see the medical profession deteriorating. The respect and the grace which we used to have is going down and down. So now in the society, we are seen as liars. We are sitting to make money. You advise the patient to have some procedure, he doubts you. So blah, blah, blah. So I don't know what are the reasons for this. Maybe Raju will comment later on. I say these are 3 P's that why we have gone down. One P is politicians. They never hesitate to criticize doctors for getting boards, particularly the private doctors. You know, they make money, they do this, they do that. Then the press. Whenever press finds time, they are very excited to give news about the doctor. One of the ladies was working for Tribune, and she wrote some articles about me, and she used to come with patients, do this, do that. I used to oblige her. But then there was a minister in Haryana whose I had done the CRTP, and when she came, for replacement, she got infected. Anyway, the lady died because of the infection. She had a septicemia, and this lady was the first to write article against me. You have to believe. So second is press. The third is paisa. Paisa is we are involved because in the process of making money, we do unethical things. This is a fact. So that is why doctors are being criticized, doctors are being beaten. So I don't know how to reverse this trend. I don't know. I don't know how to bring accountability, how to bring auditing in the medical profession is something which I would like to discuss with you. But coming off the medicine, I don't know actually why I came in this world. I have no idea. I try to understand कि क्यों भैया क्यों आए भाई मेरे को क्यों लाया गया यहाँ. I don't know. I still don't know. But okay, in simple forms, if I have to say what is the purpose of life? Purpose of life is to first have to educate yourself, to stand on your feet, to look after yourself, look after your family, friends, and look after the society. So many things we see, so many wrong things we see in the society. So I have made certain points that one should follow for a healthy and happy life. I call them Baba Clay's 13 points. Why I say Baba? Because in India, people are not willing to listen to educated people. They don't care about a doctor or an engineer or a philosopher. They listen to Babas. You know, there are hundreds of channels of Babas, but there are no channel of health education in this country. So that's why I said, okay, Baba ban jao, maybe people will listen to you. So what are those points? Many of those points you know, practically all of those points, but still I want to share with you that first is remove fear from your life. I think fear is the biggest enemy of mankind. Fear of death, fear of disease. कार्डियोलॉजिस्ट को फियर क्या मेरे नंबर ना कम हो जाए, सबसे बड़ा नंबर, यू नो, फियर ऑफ माई पीटीसी आर गोइंग डाउन, उसके पीछे बढ़ रहे हैं, यू नो, फियर ऑफ एनीथिंग. Fear of death, I say, is unjustified. Why? Because ek din marna hai, we have to die one day. Perhaps in Hindu religion or in Sikh religion or in Christianity, they say the date of your death, the time of your death, and even the exact place where you're going to die is already decided. So why worry about death? Let it come one day. Let us die gracefully once. People in India die daily. And I tell them that they are living dead because they are in fear of some kind or other. Fear of disease is a little bit more justified. कि मेरे को paralysis ना हो जाए, ये ना हो जाए, वो ना हो जाए. What can we do for that? Follow a healthy lifestyle. And doctors have the most unhealthy lifestyle in India. Let me tell you, the most unhealthy. Their working hours are nonsense. And people take pride in saying, yeah, I finish my OPD at 10 p.m. or 11 p.m. And they say with pride because it's an ego booster for them. And many doctors I've seen, they have diabetes, they have hypertension, they have anxiety, they don't look after themselves. So I think we should look after ourselves first, then the society, and rest leave to the God. We can't avoid every disease. If you're a non-smoker, you are a bhagat, you go to mandir daily, but still you can have myocardial infarction. That's something which is beyond us. The second thing is ego. Ego is the biggest enemy. I am Dr. Clear. I am Padam Bhushan. I am very clear in my mind that nobody has any concern with my Padam Bhushan. What is the concern? How I behave with them, how I deal with them. That's all. Ego is the biggest killer of mankind. Then expectations. Well, I should expect UP Sangh is my junior. He must stand when I come. Expecting. Decrease your expectations from life, even your relationships, your wife, your friends. If you can bring down expectations, then you will be relatively happy. Then, you know, work should be your kind of passion, that whatever you do in life, do with honesty. If you're a doctor, if you're a cardiologist, if you're an interventional cardiologist, do whatever you can do in a best possible way. And regular exercise, yoga, meditation is a must. One must do. I always say people, you should do 4 things in life. 5वीं चीज करने की जरूरत नहीं है. Do your work properly. Do exercise, yoga. जब भी आपको टाइम मिलता है, you must chill. Enjoy करो. दारू पियो, चाहे जो मर्जी करो, फिर भूल जाओ सारा चीज को. And then sleep 7 hours a day. You don't have to do 5th thing in life. So always imagine, tell yourself, you are here to give, not to take. You know, that's a principle. Many religions show the same thing. Never think कि मेरे को किसने क्या दिया. Always think मैंने उसको क्या दिया. So you will be happy. In assets and money, look at the people who are less than you. अगर आपकी नेबर के पास बिग मर्सिडीज है, उसी की तरफ देखते रहोगे तो आप लोगों अपनी टोयोटा का मजा नहीं आएगा. It's all comparison in life. So finally, I always do, and I always advise people that please remember that you are going to die one day. Nothing is permanent in life. And this thought of reminding myself of death, I think has made me a better person. So earning this money, earning these assets with unscrupulous method is of no use. Nothing will remain. Even if you leave crores and crore buildings, आपको कोई मतलब नहीं उसके साथ. And there's no point making even leaving money for your family or your children. Once you are gone, you are gone. Children have nothing to do. आपका, I don't believe in rebirth or this thing. So this is all crap in my mind. I think if you follow these things, you can be more happy, you can be more healthy. Coming back to the medical profession and bringing back the grace, I think PGI alumni, I want PGI alumni to take some stand in this direction. If we can do something, I don't know how to do it, how to bring legitimacy in the profession. I would be very happy to have views of all of you, including Dr. Somaraju, whom I always consider inspiration for me. So I think we need to do something. नहीं तो डॉक्टरों की जो पिटाई हो रही है, एक्चुअली उनकी कम हो रही है, उनको ज़्यादा होनी चाहिए. इफ़ यू सी द ट्रीटमेंट्स डन बाय डॉक्टर्स, I'm talking about cardiologists today, distal LED stented, diagonal stented, nothing else was there. First episode of AF advised AF ablation. So we need to do something. I don't know how to do it, but I think we need to do something before we lose the reputation further and further. And our coming generations are seen as thieves, not as doctors. Thank you very much. I don't want to take more time.
Sir, we have to arrange the hall for the group discussion. So just for 5 minutes, we will have some group photo over here once again. By the time they will arrange, we will have against this backdrop, we will have one group photo.
MD, then I didn't know what to do. Then nephrology was a very good department. That time I think one of the best department was nephrology because of Dr. K.S. Chugh. Cardiology was, I would say, average or below average, according to my assessment. We had only master's step test, you know. We didn't have even that. We didn't have echo. But 2D, the M mode echo came during my presence. So anyway, I gave the exam. I was selected both. Ultimately, I selected cardiology. So I went into cardiology. I thought partly because I was the internal candidate. If I was external, maybe I wouldn't have got, because internal are always the advantage. So anyway, so then, you know, there used to be a round bedside. There was a bedside, and I don't know who was presenting. There was a patient of mitral regurgitation or heart failure. Even that I don't remember exactly. So the candidate presented the whole thing. Then after that, you know, all these consultants, they used to auscultate and tell their findings. So the first turn was Dr. Sapru. So Dr. Sapru, no, first was Dr. Bidwai. So Dr. Bidwai said, well, there is a third sound. And then Dr. Sapru heard it. He said, no, there is a fourth third sound. First sound is this, and there is a fourth third sound. Then Dr. Wahi was sitting there, and he said there is a summation gallop. Summation gallop means there is a third and fourth sound. So that was the day I understood first time in really that I can learn cardio. इनको कुछ नहीं आता तीनों को. No, I'm telling you honestly. इनको कुछ नहीं आता है, बेवकूफ बना रहे हैं मेरा भी. So मैं भी cardiologist बन सकता हूँ. So that was a really thing. And even today I can tell you that many cardiologists, they cannot hear third sound, they can't hear fourth sound. अब तो younger generation तो सुन ही नहीं सकती, because they do echo, they don't listen to the patient at all.
Thank you, sir. And recounting the PJ days, you know, the consultant will sit around you. It reminded you of Red Indians going for a hunt. They will surround a bison, they will go around in circles and shoot arrows till the bison was dead. So I think we had the same feeling there. Regarding Dr. Claire's thinking that nothing outside Patiala is, I mean, it is not existent. So I'm reminded of Yash Chopra. He thinks that India is divided in two parts. One is Punjab and the second is Greater Punjab. So every film of his has Punjabi songs. So let's move to the next group. I will give you 4 minutes. Anything interesting? I think Dr. UP Singh, because he has a lot of anecdotes.
I am the person who has no brains but has a good sense of humor. According to Dr. Khatri. Right. So, you know, what happened when I appeared for an exam, theory was 80% and practical was 20%. And after my entering into the DM cardiology, they changed the rules. They said no, theory has to be less and practical has to be more control. So they gave me 3 marks out of 20 in the practical, but because of the theory, I still made it. And they were very unhappy about it. 1 or 2 months, Khatri would not talk to me. Dr. Sir never talked to me. But then eventually things had turned down because we knew what Dr. Khatri wanted. Whenever he say, go and tell us what is the first start sound like. And we would just put a stetho. We know we have to say it's loud and short. Done. Anything more? Snappy. Done. So, first. Okay, whenever he say, go and auscultate the heart. We knew it has to be S3. So we used to be in less than 3 seconds, we would be back. Sir, it's S3. Yeah, he's smart. He's good. It so happened that then, you know, I was given a second posting in the cath lab and near my final exam. How can you go to the cath lab in final exam when you are working more than 24 hours? Then when are you going to read? I said, when I'm going to read and prepare, we are going to pass you. I said, fine, but rest of our life, you are not going to live for me. I have to practice. I have to do. No. The decision, both Dr. Sapru and Dr. Khatri were sitting. You have to go to the cath lab. Done. 1 day, 2 days, 3 days. I mean, 1 week. It was horrific. So one day, I went to the surgery department. I asked them to give me a small nick here and put a betadine, good amount of betadine, so that it should ooze out. And then a bandage. So next day, I go to the cath lab. Sir, I can't scrub. He knew I have done a badmashi, and he said, UP, you're cheat. You're a cheat. You're a cheat. And this is the first time I saw him smiling.
Anything? Just a minute.
Oh, sorry.
I will give you back. So for the audience, Dr. Ashokan is from Kerala. So he used to take history and he asked, where are you from? So everybody said, Pind to aaye. He came to me, Bhargav sahab, where is this Pind here? Everybody's coming from there. Which is this place, Pind?
Yes. So many remembrances about PGI, I can't describe. I'll just say 2 lines. इसी कश्मकश में जिए जा रहा हूँ, किसे याद रखूं, किसे भूल जाऊं.
In fact, I had a long memory list of PGI because I think I had the longest time in PGI since 90 onward. And I had addition as a working with Dr. Chitani for and he used to say that you beat PGI. And one day I was having dinner with him and Professor Wahi came. I was not knowing that then said, Yashpal, do you know who is? He said, Pyare Lal. I was not knowing Pyare Lal. He never knew why this one, because PL Wahi was Pyare Lal Wahi. So, but he said he is PGI director.
No, sorry. He was Purushottam Lal.
Purushottam. He said Purushottam. He said first name Purushottam, not Lal. Purushottam, he called. And Dr. Wahi was just, in fact, I was really surprised. He was just in front of, he didn't enter the dining room. He was just at the entrance. And he stood at 90 degree when he had a 2-minute talk regarding PGI and something. Then he went away. Then there is something was going on in PGI at that time. There was a discussion. Then he said, at that time when he retired, I joined in PGI. This one, and I was entered the DM. Dr. Tushar was there, and Dr. Wahi used to come. We had a great respect for him because at that time, you know, PGI had a very great internal politics because you already discussed, which should not be, and that is the reason something PGI as a this one couldn't rise up to that point. Otherwise, it would have number one long back. So when Dr. Tushar used to come, we used to have those films, and he used to see and decide about these old patients. So very great. After the retirement also, for 6 months he was coming. And secondly, I just want to tell you, I was offered so many in Germany by Dr. Chatwal. He said, yeah, you are a very simple man. There will be difficulty for you to continue because for promotion there is a lot of politics, and you know many additional professors, there never used to be promotion. I went up to the Supreme Court and I quoted everything, and I was the first professor to be in cardiology. After that, whole cardiology and whole departments, not only in PGI, all over India, the human sources this one, because guidelines were made depending upon your this one. Because if you are doing well and there is nothing, nobody can stop your promotion like that, because that made a total change in India. And secondly, regarding innovations also, PGI, you know that in 2022-3 was ranked among the top 10 in the world, and till now it is being this one between 100 in the world. But that is because of lot of rush during COVID, when there were beds and this one equivalent, results were excellent.
Just tell something interesting here, please.
Interestingly,
Yeah. So I think to conclude,
I will just one
to
thing
conclude, it was Germany's loss that Dr. Ishwal did not go there. So now we move on to, yeah.
मैंने एक इंटरेस्टिंग मुझे याद आ गया सिनेरियो व्हेन आई वाज ऑन कार्डियोलॉजी ड्यूटी एंड आई वाज ए टीपीआई ऑन कॉल रेजिडेंट. तो देयर वाज ए रेजिडेंट हु वाज ओनली ऑन टीपीआई ऑन कॉल. जहाँ भी पूरे हॉस्पिटल में कोई किसी को टीपीआई करना है तो मतलब वो रेजिडेंट की थोड़ी सी वो होती थी कि हाँ भाई, वो मेरा फर्स्ट ईयर जो स्टार्टिंग हुआ डीएम, तो मेरा फर्स्ट पोस्टिंग कैथ लैब में लगी. तो अपने बैच में 3 लोग थे और मैं सबसे पहले टीपीआई लर्न कर रहा हूँ. टीपीआई लर्न करना मतलब बहुत बड़ी चीज़ हो गई उस ज़माने में. तो वो मेरे को कॉल आई, तो संडे था, जो टेक्नीशियन था ना ऑन ड्यूटी, ही वाज ड्रंक.
fully drunk, and Bhim tha, wahi to. वो मैं जहाँ नाम भूल गया. Fully drunk he was, and he was not able. Patient was in going into syncope, and we were reviving him, and we just pulled him from the EMOPD ट्रॉली पे धक्के धुक्के मार के उसको हम लेके आए उधर. संडे शाम का टाइम था 5 बजे का. तो हमने कहा भाई मशीन तो ऑन करो. अब उससे मशीन ही नहीं ऑन हो रही. अब हमें पता नहीं है. फिर हमने कोई कैसे तरीके से और बंदा बुला के मशीन भी मैंने ही चलाई और उधर से टीपीआई भी मैंने ही किया, बिकॉज वो तो स्लम्प होके पड़ा हुआ था. और कैसे मुश्किल से उसकी टीपीआई किया और वो पेशेंट बच गया. और वो बाद में पता लगा कि वो कोई 17 सेक्टर में से गुरुदेव फोटो वाला ना कोई, वो उसका मालिक था एक्चुअली. वो बाद में पता लगा जब उसका पेसमेकर लग गया. फिर उसके बेटे ने बड़ा थैंक यू किया और उसके बाद उसने मेरी कम से कम 5-10 फोटोएं खींची, बुलाया अपने वहाँ पे. तो आई वांट टू से दैट वाज वेरी हिलेरियस कि टेक्नीशियन भी आउट है और पेशेंट भी आउट है और हम अकेले लगे हुए हैं उसको टीपीआई करने.
Yeah, I am in the PGI. I was in the PGI from 97 to 2006, and many of my SRs are there and my teachers are there. Actually, I don't have much interesting things. See, when I was in MD, I thought all DM cardiology, they are all looking like heroes. So I thought that my tension will come down when I enter cardiology. So after coming to DM, then all the MDs were looking like heroes actually. The tension. Yeah, so always it was like that. And I used to hear from a senior, if you work in PGI, you can work anywhere in the world. Everything is taught in PGI, and how to become hero and how to become villain also.
So, which one are you? Just let them finish. These are the youngest group. And I would say, yeah.
You are Rajnikant.
You have got recent memories. So only one specific question from my side. Who was the best female nurse, either in OT, cath lab or the ward?
मेरे को तो नाम ही याद नहीं है, सिर्फ चेहरा याद है. अरे नहीं सर, ये कुछ और प्रेजेंट हो रहा है. इट इज नॉट लाइक दैट. मे बी शायद एक, हाँ वो सही बंदा था. With numbering. So the only female staff I remember is probably Nisha's sister. So I think that is the best candidate.
एक और इंसिडेंस है वो टीपीआई वाला. एक पेशेंट को टीपीआई किया था. ये बताएगा राज.
Actually, suddenly somebody called from the cardiology office, and they were very badly searching for him. And they asked, see, he has to go to Ambala, to a cremation ground. So they were, why? Actually, he forgot to take the TPA and the body has gone to...
That happened earlier in our times also. You know,
PGI is on a regular trip to cremation grounds. It is not the isolated incidents.
Kapil,
and even Duggal and me.
एक डॉक्टर जॉर्ज थे हमारे साथ, हमारे सीनियर. तो डॉक्टर जॉर्ज बोले, यूपी, put the pacemaker under the skin of the patient just to save your skin. One day we were called by the police, and we had to take some written this thing from this. Police had stopped George because the temporary pacemaker, those devices were supposed to be responsibility of the resident in charge of TPI, and there were about 5-6 of them in his bag. And he was stopped at the bus stand, and people were standing with the gun facing them. But most likely these are the live bombs we carry.
I think Dr. Somaraju will have the last word.
Just wanted to.
Yeah.
Claire was saying that PGI was for South Indians, you know. PGI was South Indian. So then the side effect of that I'll tell you. We used to have a surgical resident, one Dr. Lakshmi. She is in United States now. She is also from Guntur. She was on night duty, emergency night duty, and when Sardarji came, and old man, and she was trying to take history from him. So, Sardarji, kaise hain aap? She said. Then she was to take a personal history. कभी कभी पेशाब पीते हैं. पेशाब पीते हैं. She asked. She asked, कभी कभी पेशाब पीते हैं आप? Old man. Then he thought he was not hearing properly. He asked again, क्या पूछ रहे हैं? पेशाब जी, पेशाब पीते हैं. क्या बात कर रहे हैं आप? पेशाब? इसमें क्या है? पेशाब पीने में कौन सा बात? पेशाब सब लोग पीते हैं, बहुत लोग पीते हैं. पंजाब में और ज्यादा पीते हैं. She said. Then what she meant was sharab.
There is a request from the seniors because the young crowd is not familiar with them. So he requested you to each one to introduce yourself, give your name and your workplace. I think starting from this batch especially, because I think the rest of us were pitted against each other for so many days in PGI, so we know each other.
Good evening, sir. I joined PGI in 2000, I think 11. The memory is formatted so badly. So I joined from the army. I did 3 years in PGI and went back to the army. So a lot of. So my name is Colonel Jayachandra, sir. Jayachandra. Jayachandra. Yes. I am originally from Hyderabad, but I am currently at Pune, sir. I am the professor and head of department of AICTS Pune.
I am Naveen Krishna, sir. I did my MD and DM from Chandigarh. So MD I have done from 2007 to 2009. DM 2010 to 13. Now I'm working at Star Hospitals.
I am Smith Srivastav. I am heading Department of Cardiology at ACI Raipur. ACI is named after ACC Chandigarh. So that is one of the connections. And JC has been very good friend. He saved almost 5 years of his army liquor. And our batch was the one that left no stock remaining there.
Sir, I am Dr. Kiran Chulki. Did my DM cardiology from PGI from 2009 to 2012. Right now I am working in Bijapur, my hometown, Karnataka. We have got our own hospital and cath lab. Thank you so much for inviting us here. We feel very proud to be here. Thank you, sir.
Hello, sir. I am Dr. Mukesh Yadav. I was in PGI from 2009 to 2011, and I own my own hospital in Junjunu.
Good evening, all. I am Dr. J. Patam. I am same batch as Mukesh. I have been in PGA from 2004 to 2011 when I complete my MD and DM. Right now, I'm based in Cochin. I mainly do coronaries and some structural work as well. Thank you.
Myself, Dr. Jaipur. I have done DM from batch June 2020 to June 2023. I am working in Seeker Government Hospital.
Good evening, sir. I am Dr. Anil Kumar Chaudhary, currently practicing in Jaipur, NIMS University. I did my MD and DM both from PGI Chandigarh from 2017 to 2023. Thank you.
Good evening, everyone. I am Dr. Pulkit Chabda. I did my DM from batch 2020 to 2023. I am currently working as a cardiologist in Suratgarh, Rajasthan, at my hometown. Thank you.
Good evening, respected teacher. Myself, Dr. Mayank Yadav. I did my DM from 21 to 23, and I working AP in AIMS Jodhpur at present.
Good evening, everyone. I'm Dr. Soumyata Sumendra. I did my DM from July 21 to July 24, and currently I'm working in Jaipur as consultant cardiology at Bombay Hospital Trust.
Good evening, everyone. I'm Dr. Srimant Vyas. I did my MD and DM from PJ from 2015 to 21. Currently, I'm working at Jayadeva Mysore as faculty.
Good evening, everyone. I'm Dr. Sabri Krishnan. I did both the MD and DM from PJ Chandigarh, and now I'm working in Meenakshi Hospital, Tanjavur.
Good evening, sir. Dr. Mukul Bhatnagar. I did my MD and DM from PGA from 2007 to 2013, and I remained professor and head cardiology, Tanda Medical College, and these days I am in Shimla.
I am Saujatya Chakravarti, sir. I was in PGI from 2007 to 2014, and I am in Kolkata at present.
Good evening, everybody, sir. I am Dr. Rohit Goyal, and I did my DM from 2012 to 2015, and I am working at Max Hospital, Gurgaon. Sir. Max Hospital, Gurgaon, Delhi NCR.
Good evening, everyone. I am Dr. Sumit. I did my MD medicine from PGI itself in 2007 to 2010 batch, and then DM cardiology from 2011 to 2014 batch. Jay Chitra and me are batchmates in DM, and myself, Saujatya and Mukul, they are our MD batchmates. So we have a lot of fond memories of both MD and DM times. Thank you.
Thank you all. It's so heartening to note that the PGI brand has so many outlets all over India. Yeah, there's a late entry.
Yes, sir. Myself, Dr. Ramesh Patel. I passed my DM from PGI in 2015. Currently, I'm in Udaipur. And I'm batchmate of Rohit, and all my seniors are there. So I'm feeling and seeing all teachers. Thank you very much.
One thing more I would like to add. There is one thing more particular about me and Mukul. Mukul used to be the first person in MD batch to enter the LT1 every time, along with Professor Verma. And I used to be the last person to enter the LT1 in every lectures.
So I think I'll ask Dr. Ram for further instructions. So thank you, everybody. They are seniors, yeah. Yeah. You have something to tell or recount, yeah.
I am Dr. Partha Chaudhary. I did my MD and DM from PGI Chandigarh from 2004 to 2010, and presently I'm practicing in Kailash Hospital, Noida as senior consultant cardiologist. When I was doing my DM residency, Professor Talwar, he was the head of the department, and he was very fond of me, fond of me in a special way.
Your hands are shaking.
Yes, still my hands are shaking thinking about him. He was very fond of CRT. He had a special interest in EP, and one day he did his, he implanted a CRT device, and I was the senior I was a senior resident there in CCU. So the patient got shifted from cath lab to CCU, and in order to impress him, I knew that he would call me and ask about the patient. I did his ECGs, X-rays, memorized everything about the patient.
Potassium.
He called me after 1 hour, and the first question he asked me was, "Kake, उस patient ने पेशाब पास करा है कि नहीं करा?" And I was stumped. I told him that, "Na, sir, पेशाब अभी मैं पूछ के आता हूँ, sir." And then he scolded me like anything. तो काके ये नहीं पता तेरे को पेशाब पास करने के नहीं करा तूने? And another incident was that I was working with Dr. Reddy. I have very fond memories of Dr. Srinivas Reddy, who is presently in PGI Chandigarh. One day he was, there was one patient, there was a CT of RCA. He was opening up the CT of the RCA, but he was not successful. And it was, I think, in the middle of the winters, and it was very cold inside the cath lab, and the patient had an urge of urination. So every time he used to tell Dr. Reddy, "Sir, बहुत पेशाब आ रहा है." So Dr. Reddy was, he was concentrating on opening the CTO, and he used to scold him, मैं तुम्हारा सीटीओ खोलता है और तुम्हें बार बार पेशाब का बात याद आता है. चुप रहो तुम. And like this, he continued the case for 1 hour. After 1.5, it became intolerable for the patient, and he told कि सर मैं अभी कर दूंगा इधर. Anyways, he was not successful, and then he abandoned the case. Dr. Reddy was not successful. Then afterwards, when the patient got relieved, he asked the Dr. Reddy. He was then worried, sir, मेरा artery खुल गया कि नहीं खुल गया? Reddy could not admit that he was unable to open his CTO. He told him, तुम्हारे पेशाब की वजह से नहीं खुला. बार बार बोलता है पेशाब के लिए. हम डॉक्टर कैसे कंसंट्रेट करेगा? Then the patient told, सर अगली बारी आप मेरे को कैथेटराइज करके भेजना सर.
Now you understand why Dr. Talwar was asking patient ने पेशाब करा कि नहीं?
Yes. There's one more incident. I was assisting Dr. Reddy in permanent pacemaker implantation, in dual chamber pacemaker. Actually, in that time, ACC was not open. There was in Nehru Caron block. It was in the ground floor. There were two cath labs side by side. One was the main cath lab, and another was the side one. Dr. Reddy was implanting the dual chamber pacemaker in the side lab. So while implanting the pacemaker, we noticed that through the window, Dr. Manoj and I think Dr. Ajay Behel, they were peeping through the window and looking like this. Dr. Reddy said to me, देखो, Dr. Reddy केस कर रहा है, सब लोग देख रहा है. तो हमने भी बोला मतलब एक्चुअली आई वाज रेसिडेंट ऑफ डॉक्टर रेड्डी. आई टोल्ड हिम सर आप बहुत अच्छा पेसमेकर करता है सर, इसलिए बार बार देख रहे हैं सब लोग. देन ना डॉक्टर अजय बेहल ही केम इनसाइड द कैथ लैब एंड टोल्ड डॉक्टर रेड्डी आई थिंक योर आरए लीड इज इन द आरवी, यू शुड करेक्ट इट. देन रेड्डी गॉट फ्यूरियस. वो the company person who was there, who was assisting in implantation of the pacemaker, Reddy turned to him. तुम कैसा वो टेक्नीशियन है, तुम्हें पता नहीं है कि पेशेंट का जो लीड है वो आरए में है, आरवी में नहीं है लीड उसमें. And then he scolded him like anything. Ultimately it corrected, and then the case went off well. Thank you.
So there's some special thing about Partha, that he used to laugh a lot on ward rounds. So for that, to prevent that consultant कि वो देख लेगा consultant and डांट पड़ेगी, तो he used to always have a mask लगा के हम राउंड कराते थे पार्था के साथ में. So there is one incident about again Dr. Reddy. Sorry, multiple incidents. So on one Sunday, he called me up that Ram, जल्दी ये कैथ लैब आ जाओ, एक बहुत MI आ रहा है, बहुत बड़ा MI है, जल्दी चलो. तो मैंने सर देखते क्या है, तो बोला सर अभी TMT क्या है, एस्टे डिप्रेशन आ रहा है, बड़ा एस्टे डिप्रेशन, ये बहुत MI है, जल्दी करेंगे. मैंने सर संडे रहने दो, कल कर लेंगे. फिर मैंने CMT देखा, मैंने बोला सर ये नेगेटिव मतलब इसमें नॉर्मल आएगा एनजीओ. नहीं तुम तो ऐसे ही बात करता, तुमको पता नहीं चलता है कि क्या है, ये बहुत MI होने वाला है इसको. उसका एनजीओ क्या है, एनजीओ वॉज नॉर्मल. तुम्हारा जबान ही खराब है, तुम्हारा जबान काला है. तुम्हारी वजह से पेशेंट को स्टेनोसिस नहीं निकला.
Good evening, everyone. I am Dr. Pratik Bhadoria. I was in PGI from 2005. I joined PGI in 2002 and left in 2008. I did my MD and DM from PGI. So I have seen this divide of North and South in PGI, the language barrier, because coming from North, I also faced the same barrier. But there is one interesting incident I told my colleagues earlier also. तो साउथ इंडियंस जब आते हैं तो थोड़ा सा हिंदी टू पंजाबी एक ट्रांजिशन होता है. फर्स्ट दे हैव टू लर्न हिंदी एंड देन टू कन्वे द पेशेंट इन पंजाबी. तो एमडी में एक टोटल हिस्ट्री टेकिंग में बड़ा डिटेल हिस्ट्री टेकिंग होती थी. यू हैव टू एग्जामिन फ्रॉम हेड टू टो एंड आस्क ऑल पॉसिबल सिम्टम्स, ऑल पॉसिबल साइंस. तो एक फेवरेट था कि पेशेंट से पूछना है कि उसको स्टूल्स में वर्म्स तो नहीं आते. तो आई रिमेंबर वन ऑफ द जोक्स दैट वाज गोइंग ऑन अराउंड कि साउथ इंडियन कोई था, ही आस्क्ड द पेशेंट कि बाबा तुम जब टट्टी करता है तो जानवर तो नहीं आता. That was his figurative translation from in his mind from worms in the stool. तो worm बन गया जानवर कि बाबा तुम जब टट्टी करता है बोलो जानवर तो नहीं आता. तो that old man said नहीं जानवर नहीं आता, हम दरवाजा बंद करके करते हैं. So that joke went around for a long time.
My apologies before I disclose one more. There was one more segment, Bengalis, apart from Andhra. And we were told that usko tongue ko, तो वो young lady थी, बंगाली resident was examining है कि जौबन दिखाओ, जौबन. उसने ब्लाउज नीचे के देखो जौबन.
वो बोला, वो बारिश में जा रही ना लड़की को बोला मेरी छाती में आ जा. छतरे में ही had wanted to mean umbrella, मेरी छाती में आ जा. उसको 4-5 लगी, फिर ठीक हो गया बंगाली.
Shall I hand over to Dr. Rajiv for further action? So, Dr. Ram, what is next on the agenda? Okay. So, thank you, everybody.